myself, Dr. Sampurna Ghosh, Organizing Chairperson. From the Organizing Committee, I take my pleasure to welcome you all in the city of Pearl. It is a great honor for me that seniors, juniors, and my colleagues have come from different corners of India. I especially want to thank my foreign faculties, Dr. Prepagaran, who has come from the distance, far distance from Kuala Lumpur, Dr. Monica Pokharel from Nepal, Dr. Chandra Jaiswaria from Sri Lanka. Dr. Manila Laich could not reach because of the current political situation in Bangladesh. Prepagaran sir is ready in the Osmania Medical College to start the cadaver dissection demonstration, which we all are eagerly waiting. I want to add a few words about Elevate ENT Summmit and my hospital, Medicover Hospital. Medicover is a European chain of hospital which have more than 20 branches in India now, and we thrive for advancement in medical science, new technology, and spreading academic knowledge. With this concept, we organized Elevate ENT Summit to discuss about current practice protocol and to shape the future practice. Thank you all again. I invite Dr. Sripati Naidu, Assistant Professor in Koti ENT Hospital and Consultant in Global Hospital, to chair the session. Along with him, Dr. Sripati Naidu from Karimnagar, teaching faculty in Pratima Medical College. Both of them will moderate this session. Sir, please take over from here.
Thank you.
Good morning, sir. Prepa, sir.
Hey, hi. Namaste. You're looking healthy as usual.
Thank you, sir. Hi, Teja. Sir, I'll give to Dr. Satyakiran, sir, to introduce, give your introduction.
Good morning, sir. Prepa, sir.
How are you?
All good, sir. How about you? All good.
I remember our trip to Vijaypur.
Yes, sir. So I take the privilege of giving a brief introduction about Dr. Prepagaran Narayan, sir. Sir is a professor, a senior professor and consultant in the Department of Otorhinolaryngology at University of Malay at Malaysia, Kuala Lumpur. His expertise includes ENT, head and neck surgery, advanced endoscopic sinus surgery, endoscopic skull-base surgery, otology, neurotology, and cochlear implants. He's been a member of numerous national and international organizations, which includes International Consensus on Nasal Polyps Working Group, Asian Rhinology Society, Asian Academy of Neurotology and Otology, American Academy of Otorhinolaryngology, and International Federation of Skull-Base Surgery. He is an author of more than 20 textbooks and have nearly 200 publications to his credit, and has been a well-sought speaker and has given around 600 lecture presentations, both locally and internationally. And on a personal note, he's a great personality, down-to-earth personality, and a great surgeon and a mentor. With this brief introduction, I would like to welcome Dr. Prepa, sir, to demonstrate endoscopic sinus surgery and the skull-base surgery on a cadaver. And we have 1 hour 40 minutes session for this. And Prepa, sir, please take over. Thank you, sir.
Thank you very much. Namaste, everyone. Thank you so much for the kind introduction, and thank you, Sampurna, for the invitation for us to be here. So we're going to do skull-base dissection. So the instruments I'm going to use are basically going to be a Freas, Blakesley, a true cutting and a normal Blakesley, and a cuvette. So these are the main instruments that we're going to use. Yes. So I'm going to go straight to the dissection itself in view of time.
Yes.
And if we look at this gentleman, inferior turbinate, middle turbinate, and if you look up, you can see the olfactory cleft very clearly.
Yes, sir.
The yellow that you see is the olfactory cleft. So the olfactory cleft comes somewhere along to the midpoint of middle turbinate. So this is the area that we will not touch, even when we do subtle flap. Because I think to be able to smell dum biryani is very important for patients and for us as well.
Yeah.
So the other thing is, let's look at the gate system.
Yeah.
If you want to open the sphenoid sinus for a functional surgery, we go medial to the middle turbinate, and if we gently push them away, you can see the superior turbinate there's the superior turbinate, and the opening into the posterior ethmoids, as you can see.
Yes, sir.
Very nicely seen here. And then here, in some cases, there will be a supreme turbinate. Just a small stump of supreme turbinate. That's a sphenoid ostia. To enlarge the sphenoid ostia, all we have to do is go down and push it like this. This way, you preserve the mucociliary clearance, and we should be able to go into the sphenoid itself and identify the structures in the sphenoid sinus in this manner. You can already see the optical cavitical recess ready, yeah?
Yeah.
So once we have done that, let's gently push this back inside. So we have already opened the sphenoid for function. That's how we do it. The only problem with this is there'll be a posterior nasal artery down here, which we have to be very careful about.
Yeah.
So this is now the middle meatus itself. Gently push the middle turbinate away. That's the uncinate process, gate number 1. There is bulla, gate number 2. There's the opening here. I'm not sure whether surgery was B. This is ground lamella, which is gate number 3. And the gate number 4 is the anterior wall of the sphenoid sinus. Gate 1, gate 2, bulla, gate 3, ground lamella, and anterior wall of the sphenoid sinus. So any air cell that is related to the bulla itself, above will be suprabulla, behind will be retrobulla air cells, which is possible there. You can see some amount of retrobulla air cells as well. So the first thing we're going to do is to do an uncinectomy. So the way I like to do an uncinectomy is an antegrade, which means I come from the front. If you touch the uncinate process, you can see where the attachment is. So if we insert the Peyer's elevator, especially along the tail of the uncinate, and we should be able to enter the maxilla straight. So that's the tail of the uncinate that we need to remove. And straight away, as you can see, in this one simple movement, we've opened up the maxilla as well. Without touching the mucociliary clearance. So, Karthik?
Yeah.
Then, there you go.
Yeah.
Then, I'm just going to use this to remove the uncinate process, the upper part of the uncinate process. And the most important part is this. The tail of the uncinate process must be removed as well. So now we are going to remove the tail of the uncinate process. And with this now, with this one single step, you can see how we have removed gate
So
number 1.
You prefer a periosteum, sir, or sickle nerve?
Peyer's elevator.
Okay.
I'm a lazy surgeon. I use very few instruments. Peyer's elevator.
I know.
So you can see gate number 1 has been exposed, removed. Gate number 2, bulla, is clear now.
Yeah.
Gate number 3, the ground lamella, is clear now. And if you see, there's no other damage to any of the structures. All mucosas are kept. At the same time, the maxilla is opened as well. Just push it gently down and flip it across. This way, your mucociliary clearance is not touched. Now, by keeping the upper part of the uncinate intact, we can actually go to the frontal sinus. One way is to climb the bulla, called a bulla intact technique. Now, we don't have to switch to a 30-degree scope. The way I do it is I just put my scope on the floor and then I look up.
Yeah.
And there's usually between the uncinate process and the bulla, there's a vertical shelf. Here, that's the vertical shelf.
Okay.
And depending on the insertion of the uncinate process, the frontal sinus is almost always medial to it.
Okay.
Unless the uncinate process is attached to the middle turbinate. And that's your frontal sinus there.
Yes, sir.
Okay, so you see, so you can actually identify the frontal sinus without changing the scope, and then enlarge the frontal sinus with the Peyer's elevator, and you can see the frontal sinus up there.
Correct. So can I ask a question?
Sorry?
Can I ask a question?
Yeah, please carry on.
You said that the way you do uncinectomy is antegrade. So is there any way you do retrograde, like Metzen-Mouth's technique or something like that, when you have a atelectatic uncinate, something like that?
Yeah, only when the middle turbinate is very much attached laterally, the space is very narrow, and there's a problem that maxilla is very small, but most of the time I do like this, because one instrument, one single stroke of movement, you open the uncinate as well as the maxilla.
Fine.
Gate number 2, that's the bulla, right? So what we need to do is open up the bulla again with a phase elevator, dissect it, and you can see the opening of the ground lamella. That's ground lamella that's being exposed now. Okay? So cutting again. So I'm going to do the dissection exactly as how I would do the surgery in real life. Keep it simple, basic instruments, and keep no bone exposed. So now we are exposing the gate number 3. Once the ground lamella is exposed, you can see how the anterior ethmoid has been exposed.
Yes.
Suprabular region. I'm going to now expose gate number 3. That's the ground lamella.
Yeah.
The vertical and the horizontal portion. Okay? So cutting again. So now I'm going to remove the remnant of the anterior ethmoids. And you can see the anterior ethmoidal artery coming into view. Can you guys see that?
Not yet, sir.
Yeah. There.
Yeah. Got it.
That looks like the anterior ethmoidal artery. Can you see it?
Yes, sir.
Yes, sir.
Okay, good. So now, if we look at this, we've opened gate number 1, uncinate process, exposed maxilla. We've opened gate number 2. That's the orbit here.
Yeah.
Can you guys see the orbit coming to view? Here.
Yes.
Yes, sir.
And you can see we have opened up gate number 2 that shows the ground lamella, the anterior ethmoidal artery, the frontal recess going upwards as well. And we have done it without exposing any bone.
Yeah.
So this is how real-life surgery should be done, with minimal trauma and preserve as much mucosa as possible. Now we're going to open gate number 3. Horizontal portion of the lamina, the horizontal portion of the ground lamella, and the vertical portion. So I'm going to enter the junction of these two, and that should take us to posterior ethmoids. So the anterior ethmoids are multiple air cells, small air cells, whereas posterior ethmoids are large
Fair number.
air cells, but very few. True cutting.
Sir,
So now I'm going to use true cutting again. I'm going to remove the ground lamella. Again, preserving as much mucosa as I can.
sir, if there's
So
a
do
if there is a onodi
Sorry?
cell, how would you approach, sir?
Come again?
If there's an onodi cell, how would you approach it, sir?
True cutting again. Onodi cell.
Huh.
But onodi cell will be way at the back. The same way.
Okay.
Just remove the structure accordingly until you can see the posterior ethmoidal artery. There, can you guys see that?
Yes, sir.
Yeah.
Yes.
So now you have anterior ethmoidal artery and the posterior ethmoidal artery. That's probably onodi cell.
Yes, sir.
Yes.
Yes.
This is the optic nerve.
Yeah. We see.
Can you see, guys?
Yes,
So that's
sir.
your onodi cell. So now we are looking at gate number 4. So how do we make sure that we are in the posterior ethmoids? If we dissect here gently, we should be able to identify the superior turbinate. There you go.
Yeah.
Spinatum.
Can you see the superior turbinate coming into view?
Yes.
Okay. So when you see the superior turbinate like that, yes, then you know you are in the posterior ethmoids. So what I'm going to do now is I'm just going to resect a little bit of the superior turbinate so that you guys can see the opening of the sphenoid that I opened just now.
Yeah.
Can you guys see that?
Yes.
Okay. So with this now, so again you can see how we've preserved mucosa so that the healing will be very nice, okay? Now I'm going to go along the anterior wall of the sphenoid sinus, which is gate number 4. Gate number 4, that takes me straight to the anterior wall of the sphenoid sinus. Okay. The same way now, I'm going to use a true cutting. I'm going to remove gate number 4
Yeah.
and expose the sphenoid sinus transethmoidally.
Yeah.
And I could already see
Optic.
the structures in the sphenoid sinus. Here,
Yeah.
opticoclavicular recess.
Oh,
Correct.
beautiful.
Can you see the optic
Yes.
nerve from the onodi cell that is going across into the sphenoid sinus itself?
Yeah.
Clear, guys?
Yes.
Okay, so see, so we've done frontal, uncinate, maxilla, anterior ethmoid, posterior ethmoid, and sphenoid with 2 instruments.
Yeah.
Phase elevator, and 2 cutting, correct? Okay, guys?
Yeah.
Okay, now we'll go to a subtle flap. Phase elevator,
So before we go,
sorry.
can you just show us the MOCR and the LOCR?
The OCR.
Yes.
Okay. That's the optical cavitical recess here.
Yes.
This one here, right?
Yes. Yeah.
Lateral and medial OCR here.
Correct. Thank you.
And this is the sella.
Okay.
That's the optic nerve. There's a septum in between here.
Yeah.
So this is, any question about this? This is a full house fest.
Yes.
Any question about this?
No. One question.
Good.
A few people earlier used to say that we can remove the superior turbinate entirely. And now the people are saying we can resect the middle turbinate without any problem. So how do you take that? Like resecting middle turbinate or in a superior turbinate for just for an access, is that necessary and required? And what
No,
are
I
the
think
ill
you
effects?
You just have to do what is required by the patient.
Correct.
For someone who's got enough access like this, you don't need.
Okay.
For someone who's got a turbinate like this,
Okay.
then you just take only the anterior portion. Just do whatever's required.
Yes.
So there is no fixed
Correct.
way for any case. You just have to go in with the flow.
Done.
Look at this, guys. Look at the view that we get.
Yes.
Right? Frontal, anterior adenoids, posterior adenoids, orbit, the sphenoid, optic nerve. So we did all this without exposing any or leaving any damage to any mucosa
Correct.
with two instruments, a FLIRS elevator and a two cutting.
Great.
Okay. Let's go on now.
Dr. Prepa, I just wanted to ask a question. May I? I'm
Yeah,
Dr.
sure,
Shakuntala
please.
From the audience. So I just noticed that you have just infractured the uncinate process rather than doing it. So is that what is advocated, sir? Or should we do a complete uncinectomy or a partial uncinectomy that is lower 1/3? Because you have just fractured it, but you have not removed it completely.
No, I have.
You have removed
That
only
is
the
your
lower part, sir.
uncinectomy. That, it's been removed. Your uncinate tail is gone.
The
The
lower-
only thing that is intact is this part.
Yes, sir.
Only the upper one I keep intact because this is my landmark to frontal sinus.
Okay.
The lower part has been completely removed.
Okay. So,
Otherwise, I won't be able to see maxilla like this.
so when do you advocate that we remove the uncinate process completely, or in which cases do we preserve it? Like what is in case of a partial?
No,
uncinectomy?
you have to do what the disease requires you to do. You cannot have one for everything. So I always keep the upper part of the uncinate intact for me to be able to go to the frontal sinus as a landmark. But the lower part, the middle part of the uncinate and the tail, it's being removed, as you can see.
So
Otherwise,
after-
you won't be able to go into the maxilla like this.
So after identifying and opening the frontal recess, do you still keep the uncinate process, or is it removed?
Well, if your opening is big enough, you don't have to take out anything, no?
Okay.
So sometimes when we overdo a surgery, it's easier to redo than to undo. So I think for basic tests, you want to preserve as much structure as possible because our main aim is just access. Sinusitis, the treatment is not surgery. Surgery only provides access.
Correct.
I hope you understand what I'm trying to say.
Sir, what would be your anterior limit for the nasal septal flap or the hot heart flap?
Okay, good question. So I usually don't go very far ahead because the septal flap is never my primary closure. It's always fat. So I'm just going to go dissect down. A septal flap in a cadaver is never easier. There we go. That's the plane I wanted. So you can go down as low as you want, but usually it tests as usual. So I'm going to raise the septal flap all the way to the back, to the keel. See? It's how easily the flap tests. And let me see if we can come to the keel. That's the keel here. And there's the keel on the left side as well.
I think this is the easier way than rather going from behind and doing it.
I think this guy has got no septum.
Yeah.
Yeah.
The Hyderabad people didn't leave this person, sir. Yeah.
So was it done in your hospital? No.
No.
Okay, so here you can see the olfactory nerve. Guys, can you see?
Yes, sir.
Yes, sir. Yes.
Uniform plate. You can see the nerves on both sides. That's why the flap is tearing, yeah? So now we have opened up the keel on the right. That's the keel on the left.
Yes.
There's a sphenoid ostia on the left as well. Okay. Now, how much septum do you raise? So I'm not a big fan of a large septum what do you call it?
Septal window.
Septal flap. You see this? Oh, fine, don't worry. I used to choke. It's okay, don't worry, guys. So what I usually do is I just go mid portion of the middle turbinate. For me, smell is very important.
Yeah.
So I don't go up high.
So that's a superior element, sir. Okay.
So I don't think our septal flap is a great flap here because of the previous surgery. And we don't have a scissors, but that's fine. So I'm going to raise the flap all the way along the inferior portion. There you go. That is based along the posterior nasal artery inferiorly here.
Yeah.
The same way. The same way here. You can go down if you want to, but I don't like leaving mucosas that is damaged. Okay. So I'm now going to use this to do the lower portion as well. A scissors will be better. So I don't use from the back. I do it like this, like how I do a septoplasty. Yeah? So we're sorry about this. We're using a true cutting for the septal flap. Okay, that's the flap there. Not a great flap, but because of the previous surgery, yeah? The same way now, sickle knife again. Sickle knife, okay. So we're going to do septal flap on the opposite side.
In some cases, we can even use a ipsilateral Haddad, sir. For some cases, if you are going
Sorry?
to, you can use a ipsilateral Haddad also for some.
Yes, you can, yes. So it depends on what you're doing for. So here you can see the septoplasty has been done. The posterior septum is missing, yeah? So again, so where do I make incision? Again, mid portion of the middle turbinate. That's the middle turbinate. But you guys use scissors here, yeah? Don't use forceps like I'm using now.
Yeah.
Go inferiorly until you come to the floor of the sphenoostia.
Sphenoid.
Just underneath this. Okay? So you got a Haddad flap on the right and on the left.
Yeah.
Please elevate again. Not a great flap because you had septoplasty before and because we don't have scissors, but that's life. You just have to do, when life gives you lemon, you make lemonade, as they say. Okay? So that's the flap on this side here. Now, let me go a bit more quickly in view of time, okay? So now that we have done the flaps, I can see the sphenoid ostia. Can touch?
Yeah.
Yes, sir.
So now I'm going to keep the flap down,
Okay.
and I'm going to open like how we will do a pituitary surgery. I'm going to open the keel,
Okay.
and that will give us a nice view of the sphenoid itself.
Yeah.
Okay. So far, you clean for me? So far, we've used Prius, Blakesley true cutting.
Sir, sir, you are a big threat for the instrument companies, sir.
Come again?
You are a big threat for the instrument companies if you do like this.
There you go. No, but I just want you to understand that you can do a lot of work with basic instruments.
Yes, yes.
You don't need high-end instruments, right?
Okay.
All you need to know is anatomy. Okay, there you go, guys.
Beautiful.
A nice view of the sphenoid. Can you see?
Yes, sir.
Wide and well pneumatized.
I have to be very careful because I do not want to damage the olfaction. There, can you see the olfaction nerve? So I preserve the olfaction as you can see, okay? So that they can enjoy his dum biryani in the future.
Yeah.
Very important. There we go. So now, here. Let's have a look now. So there is a vertical shelf here. This is blocking the planum. Optic nerve, carotid artery. Optic nerve, carotid artery. That's the planum, sella, and this will be the carotid artery. So there's a lot of other structures. There's some structures here that we need to remove to see the clivus. We will come to that later, okay? The next step is orbit. So here you can see the lamina papilla here is already exposed.
Yeah.
So again, I'm going to use a Freer's elevator. I'm going to dissect and remove the lamina papilla here. And I can already see the middle rectus muscle. So I'm going to use my Freer's elevator again, dissect. That's the anterior model artery coming into view. I'm going to dissect until I can see how the anterior adenoidal artery is entering the orbit here. Okay, the same way now. Can I have a cuvette? So now we're using the fourth instrument, the cuvette. Can you hold the head for it? Okay. Yes. So to do optic nerve decompression, put a cuvette in, and you can just dissect the bone away. That's optic nerve decompression being done. And this is what I'm doing now. The entire dissection is exactly what I do at home.
So
and wherever I operate.
Orbital decompression, right?
Optic.
No,
That's optic.
Until you open the periorbital
Sheath. Nerve sheath.
This is the optic nerve, no?
Yeah. Do you open the nerve sheath you don't open it?
Cut the ring.
Wait, after this, patience, my child, patience. I will just open. Let me take out all the bone first. So it's a very good question. Okay, do you remove the perineural sheath of the optic nerve or no? So if the compression is external, which means that it's just a tumor that is compressing, this is enough.
No need. Yeah.
If your compression is internal, which means it is optic neuritis or something,
You open it.
okay, good. Now I'm happy. Can you see the optic nerve?
Yes, sir.
Yes, sir. Yes.
Things decompress all the way to where it enters intracranial to become the optic chiasma,
Yes.
sickle nerve. So if you have optic neuritis,
Yeah.
which means there's edema inside,
Yes.
then what we do is we cut the perineural sheath like this.
Yes.
That's optic nerve. Can you see?
Yes, sir.
Can you see how thick the perineural sheath is?
Yeah.
So it's very difficult to damage the optic nerve. See how thick the sheath is, yeah?
Yeah.
And then you have to come across and cut the ligament of Zill.
Annulus of Zen.
Yeah.
Sir, you are given the perineural incision lower down. There's a chance that the ophthalmic artery can get injured.
Very good question. So I'm going almost midline. Can you see?
Yeah.
Your ophthalmic artery is always inferior, 90% of the time.
Okay.
That's your artery. Down there. Can you see that?
Not that well appreciated.
Here. Your artery will be down here.
Okay.
So as long as you go in the middle, look at where my incision is. It's in the middle.
Okay. Fine.
Okay? So the artery would originate from here,
Okay.
which that's your artery.
Yeah, got it now.
Okay? Can you see, guys?
Yes.
Can you see how low it is?
Yes.
It is almost inferior. So as long as you go middle like this,
Okay.
you're quite safe.
Fine.
So now let's go into the orbit.
Sir,
So-
one question.
So
Yeah?
before that,
Yeah, sure.
I can ask. So in case of
Yeah.
post-traumatic optic neuropathy, so what is the limit of the incision you give in the perineural sheath? Is it at the site of the injury, or how far should we, open the sheath?
Oh, you mean the optic neuritis?
Yeah,
So
post-traumatic
if it's like
optic
post-video
neuropathy.
therapy, if it's
Post-traumatic.
post-video therapy, you need to cut the whole thing. Optic neuritis is very rarely localized.
No, sir,
It's always
post-traumatic
almost-
optic neuropathy, post-traumatic, in case of a trauma
Then I
following
just
a-
remove the external part.
Okay, sir.
But I will always remove all the way up to here. But the traumatic optic neuropathy, I will not make this incision. We will only make this incision if there's edema. You may have a CSF leak, but the CSF leak stops on its own.
Okay.
So now-
So in case of idiopathic intracranial hypertension, in that case, what do you do? Do we open the perineural sheath, and what is the extent of the incision?
No,
In
but
case- in
we
case
don't
of-
open the
in
neural
IIH.
sheath for idiopathic
IIH.
intracranial pressure.
Okay, so we just expose the nerve without incising the sheath, sir?
Yeah, it depends on the indication why we're doing the surgery for. So that's the anterior adenoidal artery.
Yeah.
That's the posterior adenoidal artery. Guys, can you see?
Yes, sir.
Can you see how it's tenting away? Sickle nerve?
So where does the intracranial optic nerve start? Is there
I'll
any
show you.
landmass?
That's good. I want to face. I'll show you later. I'll show you when I do the skull base.
Done.
Yeah, that is the anterior adenoidal artery. Guys, can you see?
Yeah.
Yes, sir.
So we're going supraorbital,
Okay.
and we're coming to the orbital fissure already. Here,
Yeah.
I'm crossing the midline, and that's the orbital fissure.
Yes,
So
sir.
this is trans
Orbital.
orbit via the nose.
Yeah.
That's orbital fissure. So now you can actually go into orbital structures to the nose as well, as long as you're above. And you can see how the anterior ethmoidal artery will never get damaged. They just get stretched.
Yeah.
Okay? And they go between the superior oblique and the middle rectus muscle here.
Yes.
The same way you can see how the anterior ethmoidal artery and the posterior ethmoidal artery are just stretched. And that's the orbital fissure. And your optic canal will be here, just about here.
Okay.
That's your superior orbital fissure there. Clear, guys? Sickle knife now?
Sir, would it be easier to bipolarize the anterior ethmoidal artery?
But why? Like, it's not bleeding, it's not causing you problem. Can you charge more by bipolarizing this? No, right?
Sir,
No, okay.
you were saying about the bone between the superior orbital fissure and the optic canal. That is the optic strut or something?
Oh, that's lower down.
Okay, lower down.
That's orbital fissure, that's lower down.
Okay.
So now I'm going to cut the periorbita.
Yeah.
So most people will cut in 3 lines.
Yes.
Me, being born lazy as I am, I just make like an apron,
Okay.
and I cut and remove the whole thing like an apron. Which is much easier in real life than in cadavers, but we will try. There you go. Can you see, guys?
Yeah.
So instead of doing 3 lines, I just remove the entire periorbita as much as I can like this. So now we are looking for muscles now.
Yes.
So here is orbital fat, anteriorly a lot of orbital fat. Posteriorly there's very few orbital fat. I'm going to remove the orbital fat so that I can identify the middle rectus muscle. That's your middle rectus muscle. So if I go a little bit above,
Superior oblique.
I should be able to identify
Third now.
the superior oblique as well. Where's the junction? The junction is here. Just about here, the junction of the middle rectus and the superior oblique. Guys, can you see here?
Yes.
So if you enter here, now we are between the middle rectus, superior. You actually go intracornal to remove tumors from here.
Yeah.
The same way, if we dissect lower down, we should be able to identify the inferior rectus muscle. There. So this is the junction between the superior limit of the middle rectus, the inferior limit of the middle rectus. That's the inferior rectus muscle. Can you guys see that?
Yes,
Yes,
sir.
sir. Yes.
So now I'm just going to cut this. So now we are going to go intraconal. So I'm going to go inside the cone. So now we are going dissection intraconal. So sometimes if we are lucky, oh, beautiful, oculomotor nerves.
Third now.
Yes,
Yep.
sir. No.
Okay?
Yes, sir.
Yes.
Beautiful.
This must be because I have Alina and Teja next to me. Can you guys see that? Very nicely
Yeah.
seen. So this supplies the middle rectus muscle, the oculomotor nerve. So I'm going to go deeper inside now and see whether their luck will let me find the optic nerve.
Optic now.
Do you think we can get it?
Yes, sir.
Can. It all depends on how much fat we have. Because we have only 1.5 hours. I want to show you as much as I can. So this is the oculomotor nerve there. There. I think I had a glimpse of the optic nerve.
Yes. One.
There, guys? Optic nerve.
Great.
Then please clap for Alina and Teja
Yeah,
for
sure.
the
And for you too.
oculomotor nerve. Can you see?
Yes.
That's the view of the oculomotor nerve here and the optic nerve very nicely seen.
Yes.
Okay. So here, you can actually go above the optic nerve. So there, I've gone above the optic nerve. Those are the branches of the vessels along the optic nerve. And if we are lucky, we can go under the optic nerve there. I'm going under the optic nerve. And you can see the ophthalmic arteries branches under the optic nerve. Can you see?
Yes,
So we
sir.
are below the optic nerve going almost to the other side already. Okay, that's orbit, guys.
Yeah. Great.
Any questions about that?
No, sir.
All good.
Okay, so now we go on into maxilla.
Yeah.
So I'm going to do a middle maxillectomy. Yeah. So we don't have a scissors. I'm going to use a true cut to a turbinectomy first.
So one crazy question from my side. So
Yes.
can we do any squint surgery, transnasal, transorbital?
Why? Like you don't like the ophthalmologist? Like, give them some business, lah. You can. I have a video of middle rectus transection
Okay.
by FAST and how the surgery was done endoscopically. I'll show you to you one of these days. Yeah.
Yeah. Thank you.
Okay. So this is the turbinectomy done.
Okay.
Not so elegant without the scissors. So now we're going to go into middle maxillectomy. So I'm going to go, this is the way I do it, yeah?
Okay.
I'm inside the inferior margin, I'm already inside the inferior meatus. Sorry for a while, it's just the light source black. Okay, there we go.
Yeah.
So I'm going to go to inferior meatus. I'm going to push the whole thing away like this. Oh,
Okay.
no scissors, right? Okay, took a thing, okay, fine. So then what we need to do is to cut this. It'll be better if you have scissors, but we don't have, but it's okay. So I'll just use a true cut. So now we are entering, maybe you can use a divider, no?
Yeah.
Okay. You know the divider? Yeah, I'll use a divider. So far, guys, we have done the entire dissection with 4 instruments, yeah? Prius, Blakesley, sickle knife, and a cuvette. So now I'm going to use a debrider to remove the medial wall of the maxilla. So that is the nasolacrimal duct. When you do this, you have to make sure your nasolacrimal duct is identified. Sickle knife? That's the duct there, guys.
Yeah.
Sickle knife. Can I have a backbiter?
So kerosene punch will do.
Yeah. So now I'm going to use, this is the lacrimal duct here. Can you see?
Yes, sir.
Yeah. So I'm just going to open the duct so that you don't get any more epifola after this. Okay. So with this now, I'm going to use a backbiter to remove the anterior wall all the way. Can you hold the head? There. See the duct, guys?
Yeah.
Okay. That's the duct there, which I multiplied just now. So I just want to get enough space so that I can go all the way lateral. That's the maxilla now. Can you see the infraorbital nerve?
Yes, sir.
Yes.
This elevator. So the next step would be to do a SPA. So that's your SPA artery coming into view soon. Go subperiosteally a few millimeters from the attachment of the middle turbinate. And if you dissect, there is nothing left but the artery itself. There you go. This is the artery, guys? That's the sphenopalatine artery there.
Yes, yes,
Yes.
sir. Yes.
Okay, so now we have done that. What I would like to do now is to go to infratemporal fossa.
Okay.
So here, I'm going to go into the maxilla itself. Make a hole into the posterior wall of the maxilla. Let's hope it's not so hard, okay? I just want to use Carriston punch to give me a little bit more space before I go to infratemporal fossa. What's the time, guys?
Sir, you have time, no problem.
So
I'm okay?
we have 1 more hour to go.
1 more hour to go. Also, you mean it's only been half an hour so far? Okay, good. So now I have enough space. So now I have enough space to go into the maxilla. So I'm going to use my Carriston punch to remove the posterior wall of maxilla. So that's the mucosa. And I'm going to follow. That's fine. Thanks. So I just want to follow and remove the posterior wall of maxilla. You hold here, girl. Thank you. So sometimes you can just. Okay, good. So my aim now is to follow and expose the sphenopalatine artery. Okay, can you see I'm coming close to the SPA? There, guys, can you see, guys?
Yes, sir.
SPA is exposed now. Okay. So I just want to open up a little bit more bone. So now I'm going to go and expose the posterior wall of maxilla a little bit more so that we can do an infratemporal fossa dissection and pterygopalatine.
What would be a lateral limit, sir, of bone removal?
Okay.
A lateral limit.
So you see the infraorbital nerve here?
Yes, sir.
So if you dissect up to the infraorbital nerve, that's pterygopalatine.
Yes, sir.
if you go lateral to the infraorbital nerve, then it becomes infratemporal fossa. So this part is all very dependent on the cadaver itself, how thick the bone is, and so on, yeah? But I will show you the important structures.
Sir, would it be ideally for do a Denker's, modified Denker's to do this approach, or we can do it like this?
Come again? Oh, you can, yes. I'm just trying to save time. If you do modified Denker's approach, you will have better exposure.
Yes, sir.
But I'm just trying to save time so I can show you skull base, yeah?
Yes, sir.
You can do modified Denker's approach, absolutely, for infratemporal fossa. You don't need modified Denker's approach for pterygopalatine.
Yes, sir.
Okay, so look, the entire floor of the orbit is loose, which is great. Lexley? So now I'm going to remove the floor of the orbit.
Yeah.
Can you see, guys?
Yes.
Okay. Just give me 1 minute. Let me remove all the bone pieces so that our dissection becomes much clearer.
Sir, you don't like using a drill in the cadaver, but in normal, in a live scenario, do you use?
Oh no, same. I will do the same. Drills are very expensive for us. So the dissection I'm doing and showing you, it's exactly the same dissection that we do in real life. In real life surgery as well. I will only use a drill when I really have to.
Open up the
I work for a
sphenoid.
government institution. I don't own a hospital like you, Sipati. There you go. So it's all about the question of fulcrum. Can you see, guys?
Yes.
So now I've removed this bone, and I can already see the descending palatine arteries.
Yes, sir.
Okay, guys, can you see, guys? This is the descending palatine artery. Sphenopalatine artery. Is it clear on the screen?
I think literally
Yeah.
if you clear the fascia.
Yeah.
Let me remove
The
this.
periosteum, once you open up the periosteum, we can see it.
Yeah, we'll do that. Let me remove as much bone so that I can open periosteum in one sitting.
Yes, sir.
And expose everything, yeah? There we go. So now we are actually coming to the lateral wall of the sphenoid sinus. Can you guys see that?
Yeah.
So we're coming to the Meckel's cave region already, yeah?
Yes, sir.
Yeah? So now we're already coming to the Meckel's cave region and the cavernous sinus region as well.
The transpterygoid.
Here.
Translate.
Can you guys see this?
Yes.
Yep.
So this will be your V2,
Yes.
somewhere down here. Okay? That's V2 here.
Yeah.
The Whedon nerve is here. V2 is here. And optic strut will be up here. I'll show you all this as I dissect later, okay? Let me open up this one first. So far, is the dissection clear?
Yes.
Yeah.
I
Okay,
think
good.
you can reorient once you finish the bone removal.
Okay, now let's open the infratemporal fossa. So the first thing I want to do is to remove the periosteum here. So when we remove the periosteum here, hopefully we should be able to visualize the maxillary artery.
I am here.
Yes. 2 branches. Sir.
That's V2. Very nicely seen.
Yes, sir.
Okay, guys?
Yep.
So the same way, I can see the descending palatine coming from here.
Yes, sir.
So if we track backwards, that's your maxillary artery.
Yeah.
Yes, sir.
IMAX.
Tortuous.
Come again?
Very tortuous artery.
Yeah. Oh, being born is a torture, no? So maxillary artery is very tortuous as well. So here is the maxillary artery. So I'm going to dissect the artery. So even in real life, when I do this surgery, the Teja will tell you, he was my fellow before, I use a sickle knife. Because my sickle knife in my hospital is so old as I am. It's as blunt as that. Can you see, guys?
Yeah.
That's the maxillary artery.
Yeah.
This is the descending palatine here. Can you see?
Yes,
Yes.
sir. Yes.
And then this becomes sphenopalatine.
Correct.
Okay? So the same way now,
Sir,
if
in a
we are
case of
lucky,
angiofibroma, if we
Yeah.
have to take control of the IMAX laterally, how to proceed?
right? So basically, I don't embolize patients with the angiofibroma because embolization is not cheap.
Okay.
So what I do is I open the maxilla like this,
Okay.
You clip it.
The artery. Can you see the artery?
Yeah.
Yeah? Can you see the artery down here?
Okay.
That's the IMAX. So I just clip the artery here.
Where?
Here.
Okay.
So this is phenylpalatine here, descending palatine here. This is where we'll clip. And the descending palatine, and then we continue with the surgery. The descending palatine, oh, beautiful. Here you can see the descending palatine. Can you see the two nerves?
Yeah.
Sir, yes.
Wait, let me focus a bit. Yeah.
Yes.
Greater descending palatine,
Yeah.
lesser descending palatine. Can you see, guys? Nerve,
Yeah.
the conductor of the orchestra. So the same way as I would do in real life surgery, sickle knife. At the back here, if you dissect, you will see the temporalis muscle.
Yes.
You can see the fibers. So if I move
Longitudinal fiber, yes.
Yes.
there, temporalis muscle there, and the IMAX will come between the two pterygoids here. So now let's continue our dissection. So follow the V2.
To make it scale.
Let's follow the V2 backwards. And here would be the foramen rotundum. So I'm going to dissect this a bit more gently. There, guys. Foramen rotundum. Can you see?
Yes, sir.
Okay, the same way, so that's V2. So if I dissect here a little bit more, can you see nerves coming out from the infraorbital nerve? Can you see these nerves, guys, here?
Yeah.
That's your pterygopalatine ganglion here. This one here. So once we have identified V2, which is here, if you go downwards, that's the Widden's nerve. Clear, guys?
Yes, sir.
Sir, yes.
Okay, so we have V2 and the Widden's nerve, side by side.
Yeah.
That is a pterygoid
Pterygoid
wedge.
wedge.
Correct. So this is Widden's nerve. So this is where your sphenoid gets lateralized. This is where your middle pterygoid and lateral pterygoid meets. This is where you get lateral viscera to the sphenoid side nerve. Okay? The same way, if I go above the V2 or rotundum, you will come to the maxillary strut.
Okay.
And that takes you to the orbital fissure. Above this. That's V2. That. Can you see the bone here?
No, not that.
Between, let me dissect a little bit more.
Yeah. I request the audience to pose questions, if any, please.
There, guys. V2, the bone in between, which is the maxillary strut, and you can see the superior orbital fissure above here.
Yeah.
So the orbital fissure above there. Clear, guys?
Yes, sir.
Okay. So you see the entire dissection here we did with a sickle knife and a Kaizen puncher. So now what I would like to do, here you can see the ophthalmic artery.
So once, can you please just tell the landmarks
infraorbital artery.
in aspect to the sphenoid sinus?
Can you see, guys? The artery that follows the infraorbital. So now what I would like to do is to identify that comes from V2 and the nerve that comes from radian. This is pterygopalatine ganglion. It's not often you can see this very nicely. Yeah? The next step, I think I need a piece of gauze or something. There's a lot of fat, so I need some piece of gauze or something. So I'm going to cut the ganglion. Okay, so now, so I'm going to push this. I've already cut the pterygopalatine ganglion now. I'm going to push this away. Can you see the lateral fossa of the pterygoid? Wait, let me get something to, just a piece of gauze, fine. Can you see, guys? This is just pterygoid, the lateral wing, lateral pterygoid, yeah? Lateral pterygoid plate. Just use a, so, suction first? Can I have a second? So let us just clean off the fat that's coming in the way. Okay? So that I can show you the next structure. Okay. Please elevator again. So I'm going to use a Freer's elevator. You can see the middle pterygoid. Okay. Here. Guys, beautiful.
Yeah.
Anyone from the audience who wants to ask a
can see
question,
very
please send the
nicely.
mic. Please.
Okay. Now you can see it very nicely. Now I'm happy. That's the subperiosteal space that you need to go in. Here you can see the pterygoid wedge itself. The middle pterygoid, infraorbital nerve, middle pterygoid wedge. That's this is the infraorbital nerve that forms V2. There. Okay. Now we have a much better view now, yeah?
Yes.
V2. Infraorbital nerve. Agree? Median's nerve. Can you see?
Yes, sir.
Okay. So this is now the middle pterygoid. On the side, this is the lateral pterygoid. So I'm going to dissect the muscles away from the lateral pterygoid. That's the lateral pterygoid wedge there. And that's your V3.
V3.
This is your foramen ovale.
Yeah.
Can you see clearly?
Yes, sir.
There. Foramen ovale. You can see the anterior branch and the posterior branch very nicely. The posterior branch goes between the two heads of lateral pterygoid. There's a song by Toto called Leah. Lingual nerve, inferior auricular, auriculotemporal. Can you see, guys? The anterior branch and the lateral branch. Okay, that's the infratemporal fossa. Any questions about this?
No, sir. No.
Okay, fine. So, Karthik? Yeah.
Sir,
So now we go to skull base.
Sir, the level of parapharyngeal ICA, one delegate want to know about that.
What's up?
The level of parapharyngeal ICA, intercarotid artery.
Parapharyngeal ICA.
Yeah.
To reach the parapharyngeal ICA, we have to dissect much more. We have to go beyond this.
Okay.
If you continue your dissection behind here,
Yeah.
you will actually come to the middle meningeal artery, foramen spinosum.
Okay.
So your artery is way too far to the back. The ICA will be way at the back here. Here, beautifully you can see foramen ovale with anterior and posterior branch. You continue your dissection, you will have middle meningeal artery and foramen spinosum. Your ICA will be at the back here.
Okay.
Yeah?
Fine.
Yes, far posterior. Unfortunately, 1.5 hours. I think I better spend it on skull base, yeah? Okay, guys, shall I go skull base now?
Yeah, please go ahead, sir.
What's the time now?
I have an announcement. Anyone who would like to have a cup of hot tea, it is served outside. You may go and have the tea.
So we have 40 minutes more.
Okay, fine. So can you send a hot cup of coffee for Teja, me, and Alina as well?
Sure,
You
sir.
wanna- So I'm now going to open the skull base. Okay,
So,
sure.
meanwhile, can you just reorient the audience once again? All the landmarks, please.
Sure, sure. Just give me 1 minute. I'll just remove the keel first, and then we are good to go. Then I show you all the landmarks. Hold the head again.
I would request the
sometimes-
audience, if they have any questions, they can directly ask or write in a piece of a paper and hand over to us. We will ask on your behalf. Either way.
There you go. So now, once you've made like a V osteotomy, you can just push the keel away like that. Blixley. So every step I'm showing you is what I do in real life as well, yeah? So when you do a dissection with the same instruments you do in real life, it becomes like what the pilots do, a flight simulator, all right? So a dissection should be exactly, as much as possible, mimic real life. Otherwise, then the learning process is not complete.
Dr.
Okay,
Kripa
good.
Sampurna here. Just wanted to tell you the hall is full and nobody is going out for tea, that they can miss the dissection. But I want to tell you there is another separate, equally good LED screen outside where the same thing is being shown. So in the tea counter also you can see, audio system is also there. You can hear what sir is saying.
Okay.
Sir, carry on.
Okay. Thank you, thank you. There we go, guys. So now, there's another shelf there. So if you see, we are still doing using Blakesley to do all our dissections here.
Yeah.
Okay, good. You guys happy with this? Okay, both my big bosses give me approval. They're happy with this so far. Is it cool, right? So now, if we look at this now, a quick overview, right, as you wanted. Sphenoid keel. Anterior and posterior model artery. Anterior artery, let me just clean a bit more. So those of you who just joined us, okay, this is the orbit.
Yes, sir.
Anterior model artery there. Can you all see?
Yes, sir.
It's the anterior ethmoidal artery, posterior ethmoidal artery. We are going all the way to the optic canal as well as the orbital fissure, the supraorbital fissure. You can see transorbital, transnasally, the artery doesn't snap, yeah? It just pulls over. Then just now we showed the optic nerve inside as well. We showed just now the optic nerve inside just now, yeah? So same way now, infraorbital nerve. This is the middle turbinate. I'm going to push it down. Sphenopalatine artery. Maxillary artery, as you can see. Descending palatine. The greater descending palatine nerve and the lesser descending palatine nerve is here. This is infraorbital nerve with V2.
V2.
Foramen rotundum. This is Widden's nerve here. So this is the middle pterygoid
plate.
Yeah, lateral pterygoid plate, pterygoid wedge, and if you go along the lateral pterygoid, you will find the foramen ovale with the anterior and the posterior branches of V2.
Yeah.
Correct again?
Yeah.
Here now is the sphenoid sinus.
Sir, you want to show the Meckel's cave by following the
Come here.
Meckel's cave.
Next one, coming soon. Optic nerve, carotid artery. Optic nerve, carotid artery. Sella. Okay? So planum is from the anterior wall of the sphenoid sinus, horizontal. Tubercle.
Yeah.
Sella. Paraclavial carotid right, paraclavial carotid left, clivus. Okay.
Yes.
Now, this way now. Can you see V2 here?
Yes, sir.
Okay. So if you follow the V2 backwards, can you hold the head to me? Thank you. This is now all luck to see how strong Alina is and how hard the bone is. There you go, guys. I'm going to follow the V2 back.
Yes, sir.
And that takes, oh, this is beautiful. Orbital fissure. Can you see? Good, huh? Okay. You can see now V2.
Yeah.
Foramen ovale. That's your maxillary strut. This is your orbital fissure.
Okay.
Up here.
Yes.
Yes, sir.
You guys? So the same way now, it's a bit hard already. Let me try. I should have eaten more than just cornflakes for breakfast just now. There you go. So now I'm following into the orbital fissures here. That's V2.
Yeah.
I'm following cavernous sinus now.
Yeah.
Yes.
This is the carotid artery.
Yes.
The bone between the optical cavitical recess. Let's see. Can you hold it here again? Okay. I remove the bone in between as well. Good. So this bone, if I remove this, we're in a Meckel's cave. It's a bit thick. Let's try.
Sir, here you would advise a kerosene punch or J curate?
Yeah, the reason why I don't want to drill is the bone will disturb everything. Okay, bang?
No, sir, no. A kerosene punch would be better, no, sir? Elevated.
Is it? Okay, let's try.
Okay. So, where is the lingular process of sphenoid?
Come in.
Lingual process of sphenoid.
What is a lingual process of sphenoid?
So, that I heard in your dissection course in Malaysia. I was not able to
Lingual
understand.
process.
Yeah.
Ligament.
I'm not sure.
Lingual process.
I told you that, is it?
No, Amin Kasam.
Oh, I don't know. That's too high tech for me. I'm a simple ENT surgeon who just do simple surgeries and go home.
Okay.
Okay. So now I'm going to remove the bone laterally. Pija, do you know where's the lingual process of sphenoid? Do you?
Yes.
Okay, all here. Let's ask Dr. Google. He might be able to give us a better. Okay, guys, let me clean the scope a bit more. Okay. Can you see the bone being exposed here? I want to expose a little bit more bone before I do a dissection. V2, going backwards. This is your Meckel's cave. I'll open it for you.
Yes.
This is the orbital fissure. So your V1 will be going here. V2 is here. Lower down here will be V3. So I'm going to lift it up. Guys, can you see? V3 is going down. This is Meckel's cave. But before that, before I open all the space, Let me open the bone along the skull base so that we'll open everything together. Okay, guys? So just bear with me while I remove all the bone over the planum. So in a cadaver, it can be very difficult to not breach the dura.
Yeah, it's adherent to the bone.
There we go. Okay, there. Now I'm outside dura. There's one part I was inside the dura. Can you see, guys? That's outside the dura. Now I'm going to go. That fella being exposed.
Yes, sir. Crossing the middle.
The same way now, I'm going to remove the floor of the cellar.
Sir, you use a carotid Doppler in your live cases?
No, we don't have one. If you want to donate one, we are quite happy. I'll name it after you.
Sir,
We
I
don't
asked,
have a Doppler. No.
sir, I asked Dr. Google about the lingual process of the sphenoid.
Uh-huh.
It says it's the raised lateral edge of the carotid sulcus.
Okay.
It indicates
I'm
where
sure-
the body of the sphenoid merges with the greater wing.
I'm sure we have exposed it, we just don't know what it is. What the mind doesn't know, the eyes doesn't see, as they say.
Yeah.
Okay, there we go. So, but what I'm showing you is a surgical anatomy. The anatomy that you will require when you do surgery. Right? So not an anatomy, but anatomy that you will require when you do surgery. So now I'm going to the cellar,
See, that's a carotid artery.
the floor of the cellar.
Underneath that bone, that part. Once you
So
do
now
that-
let me see whether I can go up here or not. Planum. The planum is usually a bit more difficult. The bone to resect is a bit difficult. So in real life, I do the same. I will drill a little bit to go show me where the bone is, the dura is. Then I use a Kaizen punch. Simply because the drills are expensive for us, and we try to limit the usage of drills on the government side. Okay, that's planum coming into view. Can you see, guys?
Yeah.
Dura. I just want to go above this and expose more dura as we can.
Yeah.
All right. Let me remove all the bone, then we'll expose the structures, guys.
Fine, sir. Sir,
Okay,
Dr.
so this is
Vinod,
the
sir,
bone.
Dr. Vinod Felix, sir, is with us. So he has shown the lingual process here.
Okay,
Thanks, sir.
good.
Thank you, sir.
So we don't have to show you that, yeah? So I've removed the bone above the optic nerve.
Yeah.
Can you see, guys?
Yes, sir.
So this is the most difficult part of the dissection,
Yeah.
where the dura goes upwards like this. Here.
I
Okay?
think you should show them the right way to use kerosene. All cannot use the kerosene like you.
Come here.
You show the right way to use the kerosene, sir. The correct
What
way
am I
to
doing? Why, guys? Am I using the kerosene the wrong way?
No, you are using. All can't use it like you, sir.
No, you
Loading.
can. It's just anatomy. Respect of structures and anatomy. I'm not doing anything unusual. I'm just doing exactly what I do in real life surgery.
It looks
You
like
know
that
your
for you, sir.
anatomy, your extradural, you're fine. Okay.
Yes.
Only thing that is left for us to open now is the clivus. Chisel again. Shall we just open the clivus one shot? How many more minutes do we have?
So we have 30 minutes more.
Okay, we'll do that. No, it's okay. So this is paraclival carotid on the right, paraclival carotid on the left, correct? Okay, bang. So we have a drill. The only reason I'm not using it is
Spoils
it will
the
cause a lot of bone dust. Bang, bang. Okay. Bang. Okay, good.
So one of
Right.
the delegate want to ask what kind of a kerosene sponge, angled or a straight, up-biting, down-biting, and what size is to be used?
Yes, I only use this.
Okay.
Yes, we only have one kerosene.
Okay.
Donations are
Size,
welcome.
2 mm
What
or
I'm
3 mm? 2 mm.
You should do
Okay.
it, yeah.
Great.
Bang. Okay, good. Perfect. Bang. Okay, good. Bang. Okay, good. Bang. Okay, good. Crescent punch. So this is what I do in real life in clivers as well. I'll use a drill, expose a little bit of dura. Can you hold the head, girl? The head is moving. Thank you. Then I use a carisons to remove the remaining bone. See, the reason why I do this is because for us, it's expensive, and the patients have to pay. The hospital does not pay for the drill. So sometimes we end up using the same drills again and again.
Sir, you get a lot of bleeding here, sir. Venous bleeding comes here normally.
Come again?
You get a lot of venous bleeding here.
Yeah, you will have a clival plexus that bleeds a lot. I'll show you the clival plexus after this. So you can see the bleeding coming into view, already bleeding already.
Yes, sir.
So the same way now, I'm going to go lateral so that I can see the carotid artery. So you have to be careful of this part here because you can easily enter and damage the sixth nerve. And I'm going to go lateral on this side as well. Can you see how effective the crescent punch is?
Yes, sir. Yes. In your hands.
No, I think it's just a matter of practice, no? There you go. Yeah, there's a cellular floor that's being removed. Okay. You see how everything cracks? So once it cracks, don't bite. Just flick like this. The same way now, I'm going to remove this bone. The same way now, I'm going to follow the paraclival carotid downwards, yeah? I just want to have enough exposure to be able to show you the structures. Otherwise, we will take too long of a time. This will show you that the basic FAS and basic skull base that we are doing in 1.5 hours with, 5 instruments so far? 6? Okay. 6 instruments so far. It can be done. It's just a matter of knowing your structures and knowing your anatomy well. Okay. So we are at the floor of the sphenoid sinus. Guys, can you see?
Yes, sir.
If you want to go lower, you can drill the sphenoid sinus floor.
Okay.
And then, okay, good. Suction. Before I open the dura, let me just remove as much bone as I can so that we can open the dura easier. We will need a 30-degree scope later, yeah? Flexly again. Flexly again. Okay, so I'm going to follow V2 and see whether, there. This is the bone covering the macral scape, guys. Can you see?
Yes, sir.
So the same way, I'm going to remove the bone that is at the junction of paraclival and sella. There's a sella floor that I'm removing now.
Yes.
Okay, there. So this is the clinoid process. In real life, I wouldn't do this. We will just cut in the center because at the top there, you have the ICA ring around the ICA, yeah? So I'm going to leave that behind.
Okay.
Okay, I think this is good.
Yes, sir.
Yeah.
No, I think we need to go here a little bit more. Okay, chisel. Let me expose the macral scape a little bit more, yeah?
Okay.
Chisel. Okay, bang. 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 So I'm removing the bone. Can you hold the head down? Okay, bang. Bang. Okay, good. Bang a bit. Bang. Bang. So this piece of bone is a bit hard. Okay, bang.
Yeah.
Bang. Okay, good. So we're getting there. With this, the macral scape should be exposed. Bang. Bang. Okay. Bang. Bang. Bit more. Bang. There you go. Beautiful. Guys, can you see? You happy now?
Yeah.
Bang here. Can you see the paraclival carotid?
Yes, sir.
Okay. See, Teja is using the hammer. He's a strong man, as you know. Bang. You see his size afterwards, you'll understand. Bang. Okay. Bang. Bang. So you see with a clavicent punch, you can, with a chisel, bank, can control it very nicely. Okay, let's see. And now I'm going to remove all bone before we start opening up the dura. This is the bone that was over the carotid artery just now, yeah? So put it here, the same way, we need to remove this bone here, over the carotid artery.
Yeah.
Okay. I'm going to shove it down here. And that's the bone over the clivus here.
Yeah.
Okay. Lovely. Ready, guys?
Yes, sir.
We are all set, sections. So let me show you the anatomy
Yes,
first before I open the dura. Okay, so here is the dura of the planum.
Yes, sir.
Optic nerve. Carotid artery. So we remove all the bone on this side, yeah?
Yes.
Can you see the ledge between the optic nerve and the dura? This is always the most difficult part to reach.
Okay.
So we have removed the bone over the carotid artery,
Yes.
optic nerve. So this is planum,
Yes, sir.
tubercle, sella, clivus.
Yes, sir.
Here we have removed the bone from V2. I've removed the maxillary strut as well, so you can see the orbital fissure here.
Yes.
You can see the macral scaphe down here,
Yes, sir.
the paraclival carotid,
Yes, sir.
the carotid siphon, and the clivus.
Yes,
Clear,
sir.
guys?
Yes, sir.
Okay, sickle knife. So let's do planum first, yeah?
Okay.
So, pituitary first. I'm going to do it exactly how I'll do a surgery.
Okay. Where to give the incision, like?
So, cut the dura,
Okay.
cut the dura here,
Okay.
and cut downwards. So that will expose your pituitary gland.
So, in a way, how to avoid injury to the inferior hypophyseal artery? Yeah. You were giving incision, transverse, and then extending like a plus superiorly and again posteriorly. So,
I didn't understand it. I'm sorry, I didn't understand the question.
how to avoid inferior hypophyseal artery injury?
Oh, okay. Good question. I'll show you. So basically now, I've opened the pituitary gland.
Yes.
So if you have microadenoma, you just take a little bit of the tumor.
Okay.
That's microadenoma. If you have macroadenoma,
Okay.
you remove all the tumor
Mm-hmm.
from inside,
Okay.
as you can see, like this.
Okay.
Okay, that's macroadenoma.
Okay.
So here you do it until you see the diaphragma. Okay? So here I'm lifting this up, and you can see the posterior clinoid there. Can you see, guys?
Yes, sir.
That's the upper third of the clivus.
Yes.
Shall we this here? Now, second knife. So now let's dissect the blood supply of the artery. That will explain the question to you.
Yeah.
So your superior hypophyseal artery comes from the ICA here.
Superiorly.
So this is where your superior hypophyseal would be. This one. Can you see?
No, no.
Your inferior hypophyseal is this one. Is it clear, guys?
Yes, sir. Very
Superior, inferior.
Okay.
So when you operate, you just stay here. There's no reason for you to go to the sides.
Okay.
The same way here, if we dissect that, that's a superior above, and this is inferior below. Here. So you can actually dissect and push up the entire gland like this.
Transposition.
This transposition.
Transposition.
Blixley? We don't usually do that because 80% of the patients actually have a transient pen pit anyway. I just remove this first. So this part,
Yeah.
the posterior clinoid, you have to be careful when you remove this. So sometimes, Blixley,
Yeah.
you can accidentally
Nick the artery.
tear the ICA. There's a ring around the ICA
Yes.
at the clinoid portion. You can actually tear that. Section again.
Yeah.
Patient is bleeding, guys. Please tell the anesthetist. Okay, guys? Okay. So now we have a very nice view of the upper third of the clivus as well.
Yes.
Okay. Now we are going to open up. We are going to open up. Sella is done.
Sella.
Pituitary surgery is done. Now we are going to open up planum.
Transplanar.
Okay. So this is the optic nerve.
Yes.
I'm going to cut the perineal shield around the optic nerve.
Yeah.
So as we cut it, hopefully we can see the ophthalmic artery.
Inferior leg.
Should come from here. That's your ophthalmic artery. Can you see?
Yes, sir.
There, ophthalmic artery. The same way, I'm going to cut across here and find the optic nerve on the opposite side.
Kayesh.
Chiasma is here.
And that's the ophthalmic artery here.
Yeah.
Stock.
Clear, guys?
Yes, sir.
So the same way, there's a bit of bone I need to remove to show plenum. Alina's already holding the head. Okay, that's bone I need to remove to show plenum. Okay, good. Now we are going to follow the optic nerve. Where does optic nerve become intracranial? Here.
Yes, sir.
Can you see the dura?
Yeah.
Dura?
Yeah.
So now it's going right optic, left optic, optic chiasma, pituitary stalk.
Yes, sir.
The same way I'm going to dissect
Laterally.
the arachnoid space between these two.
Yeah.
Suction. So you can see the carotid artery right,
Yes, sir.
carotid artery left, pituitary stalk.
Ophthalmic artery goes across.
I'm trying to see whether I can remove the CSF between these two. Oh, good.
Yeah, beautiful.
There you go, guys. You can actually see the basilar artery.
Basilar artery.
Can you see the mammillary bodies at the back
Mammillary
there?
body is there.
Okay, give me a second. So, this is the space where we remove craniopharyngiomas.
Yes, sir.
Okay? Pituitary stalk, optic chiasma. Here you can see the mammillary bodies here.
Yes, sir.
Basilar artery, posterior cerebral, superior cerebellar down here. And that's the third nerve.
Third nerve.
That's the mammillary bodies, hypothalamus there. Pectoral membrane. Okay, guys?
Yes, sir.
So this is craniopharyngioma. So we've done sella, we have done tubercle for craniopharyngiomas.
Yeah.
Now we are going to go into plenum. So here now you can see the right ACA.
Yeah.
You can see the left ACA. I'm going to put my scope on the floor so you get a 30-degree view. And this is the intercommunicating in between them. And you see how the ACA turns inside.
Yeah. Is the anterior
Can you see?
communicating? Yeah.
Right ACA, left ACA, the intercommunicating. And sometimes, if you're lucky, you might be able to see the artery of Hübner, frontopolar. You can't see here. That's the middle cerebral vessels here. Okay, guys? So plenum done,
Yeah.
tubercle done, sella done.
Yes, sir.
Next, we go to cavernous sinus.
Yes, sir.
So I'm going to cut just lateral to the carotid artery. So that should take us straight into the cavernous sinus here. So tomorrow I'll show you how we operate on cavernous sinus and the bleeding that you get from cavernous sinus.
Yes.
I'm going to cut this across.
Beautiful.
So I can already see the big guy coming across there. Okay. Then you want to dissect the artery gently away. So if we are lucky, we should be able to see the nerves now. It all depends on the anatomy. Okay, the big guy here is the third cranial nerve.
Third.
Can you see?
Yes, sir.
This one. Okay.
Yes, sir, yes.
Fourth is usually very small. It's difficult to see. Let me cut a little bit more here and see whether we're able to see the sixth. The sixth is usually like a sling. And it's a free floating. That's your sixth.
Yeah.
Let me cut this first. Okay, guys. You can see now third nerve very nicely. You can see the sixth nerve. And now I'm going to open up the macroscope. Remember V2?
Yes, sir.
Yes.
You follow the V2 back. So V1 will be here. Remember the maxillary strut that was here in orbital fissure?
Yeah.
So now you have V1 going up. Here. Can you see, guys? V1.
Not that clear, sir, but
Here, this one.
yes, sir.
The lateral wall, that's V1 here. V2 is here.
Yeah.
Now if I cut this open, you have the macroscope exposed.
Yes, sir.
So So basically, 3, 4, V1, V2, these are in the cavernous sinus portion. All this is cavernous sinus.
Yes, sir.
The middle cavernous sinus, lateral cavernous sinus. V2, Meckel's cave, and sometimes you can lift up the entire Meckel's cave, and you can see where the third nerve, there. Can you see here, guys?
Yes, sir.
That's where the third nerve enters. So this is Meckel's cave. Sixth nerve, third nerve, fourth is underneath here, V1, V2, and V3. So this is Meckel's cave.
Yes, sir.
I'll show you videos tomorrow how you go to Meckel's cave.
Yeah.
Any questions about this?
No, thank you very much.
No? Now we go into clivus.
Yeah.
So what I'm going to do now, what is basilar artery?
Yes.
Yes, sir.
Okay.
So before
Mr. B.
Where would be the
We
longest
call it
first
Big
step?
B, but in India, Big B is Amitabh Bachchan, right? For us, Big B is basilar artery.
Yeah.
Okay. Now I'm going to flip open the transclivus.
Yeah. Beautiful.
So now, yeah, good. 1 minute. I'll just flip it open like this for a while. Push this up. I'm going to go along, my scope's along the floor now, so you get 30-degree view. And we're going to now,
Pike.
okay. How much more time do we have?
So we have
10 more minutes. Okay.
15 minutes.
Next, 15.
Yep.
Okay, good. So the incision I made along the clivus, I'm not going to make it bigger.
Yeah.
Can you see, guys?
Yes, sir.
Cousin touch. I'm going to open up a little bit of the jiva. His tips keeps falling backwards. Hold the head, go. Hold the head for me, yeah? Thank you, thank you. Okay, good. Suction again. So I'm going to take out some of the CSF so that we are able to see. See this? What I'm going to do is I'm going to push the pituitary gland up.
Yeah.
Okay, guys? Now, this is a much better view. Is it okay if I cut the gland so that you have
Yes,
a better
sir.
view?
Yeah.
I have your permission?
Yes, sir. Please go ahead.
Okay. There we go. That's better view now, right?
Circle of.
So now you have the entire skull base open, as you can see.
Yes, sir. Beautiful.
Suction, guys. I'm going to suck the CSF. You see how easy it is to damage the hypothalamus?
Mammillary
Guys, saw?
bodies. Mammillary bodies.
Yeah? Okay.
Yeah.
Good.
And even-
Now let's have a look. Basilar artery.
Yes, sir.
Sometimes, if you're lucky, you can see the vertebral
Vertebral
artery.
artery also.
You see the betas here. So here now, the atherosclerotic plaques. Okay?
Yes, sir.
Posterior cerebral left, posterior cerebral right, superior cerebellar, third cranial nerve.
3 and 3.
Here.
Yeah.
Okay, I'm going to dissect a little bit of the, and see whether we can see other nerves or not. Okay.
6.
Then, fifth nerve, the big one then.
Big one
Yes,
is
sir,
6.
yes.
5.
Five.
Okay?
Yeah.
We'll suck up for you later and see. 6 will be lower down.
Yeah.
Okay. Yeah, so now, what I want to do is suction again. Okay, give me a, let's take off this entire gland. It's in our way. Okay, and let's take out this one here. Okay, good. Now, suction again. So now, let's see whether we are able to identify the third ventricle.
Yeah.
There you go, third ventricle.
Yes, sir.
Sickle knife. Okay, guys, beautifully seen, guys. Can you see?
Yes, sir.
Choroid plexus,
There it is. Yeah.
and that's the fourth ventricle.
4th. Yeah.
The aqueduct of Sylvius going down.
Yes, sir.
Okay?
Beautiful.
Down is aqueduct of Sylvius, and that's choroid plexus up there.
Yes, sir. Choroid
There.
plexus is
Can you
up.
see?
12 o'clock position.
Yes, sir, yes.
Yes, sir.
Okay, nice. Okay. The same way now. 30-degree scope. We're going to change our scope now. can you cut fascia for reconstruction? Just a small piece of gauze. No, just no, here. Just cut for me a small square. So now we're going to use a 30-degree scope, yeah? Where's the gauze again? Yeah. Give me a gauze. So now we're going to change to a 30-degree scope. This 30 or? 30, okay. So I'm going to twist the scope this way. But before that, again, let's have a look again, okay? Okay. Ball probe or something? Okay, so now we are looking with a 30-degree view.
Yes, sir.
The right ACA, the left ACA, the intercommunicating.
Yes, sir.
And you can see how it's going into the fault. Can you see, guys?
Yeah, fault.
Okay. So you can see the right and the left ACA and the intercommunicating going to the faults there.
Yes, sir.
Optic nerve,
Yes, sir.
ophthalmic artery.
Yeah.
And let's see whether we are able now. Okay, there you go. Foramen of Monro.
Yes, sir.
Foramen of Monro
Yes,
on the
sir.
left.
Yeah.
You guys see that? So
Yes,
sometimes
sir.
we are lucky, that's lateral recess.
Yes, sir.
My suction is going to a lateral recess. My scope is going to a lateral recess
Yeah.
on the left side.
Yes, sir.
Okay, oh, beautiful.
Beautiful,
Nice.
sir. Excellent.
Okay, so now I'm going into the lateral recess on the left side.
Yes.
Foramen Monro. I'm going to turn this way. That's the foramen
Right.
Monro on the right side.
Right side.
Okay, so now I'm going to come back. Let's see. I'm going to rotate the scope a little bit
Downwards.
and see whether we're able to see the fourth. There you go. So now I'm looking into the fourth ventricle itself.
Yes, sir.
Pectoral membrane.
Yep.
Can you see?
Yes, sir.
But that's the maximum clarity that we can have. That's going into the fourth ventricle already.
Yes, sir.
You guys clear?
Excellent.
So now we are going to look for the, wait, hold on now. We need to clean this a little bit. Structures in the third, whether we can see the other structures or not.
Yeah.
Okay, now let's have a look. Ball probe, yeah, sorry. And a bit of a suction as well. We need to suck out the CSF. Okay. So, again, basilar artery, posterior cerebral on the left, posterior cerebral on the right, basilar artery, third cranial nerve, and see if we are lucky enough to be able to see other structures.
It's 5.
There, fifth cranial nerve, guys.
4th there.
Lower down is the 7 and 8. But let me rotate a bit, huh?
Yes, sir.
Third cranial nerve, fourth cranial nerve, this one.
Yes, sir.
Okay, then let me focus a little bit more. Okay, fifth cranial nerve,
Yes, sir.
7 and 8
7 and
complex
8. Yes, sir.
cranial nerve here. Okay, wait, let's get another one. So if you want to take a picture,
Yeah.
I'll preserve for you guys for a while. You all can take a picture if you want.
It's being
Just
recorded,
pay-
sir.
You just have to pay Teja and Neha 100. How much you want? 100 rupees each. Okay, there you go.
Okay.
Fifth, 4, 5, 6, 7, and 8 down there. Section,
Yes,
no?
sir. Got it.
Pick out the CSF. Sometimes you get much better view. Ball probe again. I think it's much better view now. Clear, guys?
Yes, sir.
Okay. Fourth nerve up here.
Yes, sir.
Fifth nerve, the big guy here.
Yes, sir.
Sixth nerve.
Yeah.
And 7 and 8 complex down there.
Yes, sir. Got it, sir.
Intra-aortic canal.
Okay. Now we do reconstruction. Any questions so far?
No, sir. Sir, in life surgery, can we touch the vessels intracranial? It is said that neurosurgeons, our neurosurgeons don't allow us to do so. So,
No, but you guys, but you know, I think we have to be very clear about something. We are ENT surgeons.
yes.
You stop dura. Don't
Yes.
go beyond dura.
Okay.
We're not credentialed to do work like that. So I never go intradural unless my neurosurgeon is next to me.
Okay.
Please remember, You won't like it if maxillofacial surgeons do FAS, right?
Yes.
You won't like it if they come and do what do you call cochlear implants, right?
Yes.
So let's give neurosurgeon the same respect that we want from other people.
Yes.
Okay.
Most
How
of
do we
the times-
reconstruct the thought spiral?
Yeah.
So you can put this here,
And suture.
put a fat inside.
Yeah.
Remember the dura that I kept?
Hmm.
Now, the problem now is my septal flap is not that great because of the previous septoplasty. But let's see, where is my pathetic septal flap?
Sir, can we use something Surgifoam or
Yes.
Yeah, you can, but Duogen is expensive for us. I don't have the money that Sripati has got. So we just use fat. So this is supposed to be my pathetic septal flap. Remember, it was post-septoplasty, I couldn't raise it properly. So you can reconstruct it like this. That's for Cliver. The other way is to do a gasket seal. That means you put a fascia on top of it, then you put a piece of bone.
Okay. Fine.
Right side, flaps better, huh?
So,
Yeah, still. And then you put a flap on top of it.
yes, sir. Beautiful.
Okay, guys?
Excellent.
Now, transplanum.
Sir, I
So
think we
this
are
is-
running short of time. 5
Okay,
minutes
this
more.
is last one. So I'm
5
going to
minutes,
pack planum and sella.
Yeah.
You put a fat and you reconstruct. Okay, guys?
Yes, sir.
I would like to thank Teja, Neha,
yes, sir.
Alina. I'm so sorry. My apologies. It's Alina. Please delete everything I said about Neha and use Alina Khan next to me. And all the team here. Thank you very much and thanks for letting me be in Hyderabad. 6 instruments, guys. Carrison punch. Scalpels in 1.5 hours. Thank you, thank you.
On behalf of the organizing team, we would like to thank Pripa sir, Teja, Alina, and the staff there. And immensely thanks the audience too. And thank you very much, sir. It's a beautiful demonstration. Thanks a lot.
Thanks Sampurna for such a great body. Get a fresh body.
Sir, clap for cadaver dissection. So this was wonderful demonstration in such a small time, and everybody is very happy about the quality of the cadaver we got. So I especially want to thank the forensic department in Osmania Medical College. Without their help, we couldn't have done it there. Dr. Elena, Dr. Ashok Prithviraj is there from Medicover team, who is consultant and in the executive committee, organization committee. And I also want to thank Bhargav, Saful, our scrub nurse who have been to mortuary to help them, the audiovisual team. Special thanks to Rakesh from Storage. Rakesh, can you please say a hi if you are there? And Naveen from Medtronics. Staff of the mortuary, really, really appreciate your effort to do all this. We are moving to session 2.
We are going to start our another session right now, that is otology, and I'm here, Jyoti, your MC, for the next 2 days. So, should we begin, ma'am? Okay. I would request Professor Somnath Shah, a professor and head of the ENT department at Bardhaman Medical College and Hospital, Kolkata, along with Dr. D.S. Arun Kumar, an ENT consultant and who runs his own setup named Anjana Vidyala Multi-Speciality Hospital at Rajmundry, to chair the session. Dr. Ashwarya, I would like you to be here. Dr. Ashwarya.
వచ్చిందా చూడు.
Shall I call the speakers? Where the speakers will sit? This session will be for 20 minutes. 15 minutes will be our speaker session and 5 minutes for our audience question answer sessions. So after 5 minutes, if you have anything to ask, you are free to contact our faculty at the luncher or whenever they are available. Thank you.
Should we start? Sampurna, should we start? Because we should not waste any time, I'm calling Dr. Anirban Ghosh. And I'm going to introduce Anirban Ghosh. Okay. So what he is going to discuss is how to improve the result of the ossiculoplasty. Regarding the introduction of the Anirban Ghosh, they have given me a paper, but I know Dr. Anirban Ghosh from the first year of he was a student of Calcutta Medical College and I was posted at that time. So he used to be a very keen student, very good observer, and he used to work day in and day out in the ward. So he developed keen interest in the ear surgery, micro ear surgery, and he received the gold medal in the university examinations. After that, also we had an award session there. He received that K.K. Ghosh Memorial Award paper in 2006. After that, there is no end of the journey. He is very much interested, he is having a keen interest on the tympanosclerosis. He had a lot of works on the tympanosclerosis, published a monograph of the tympanoplasty. What is not written here, that he had published a book on the ear surgery, which was published by the Theme publication. It's not mentioned here. Also, he had a multiple paper, international paper and national paper. As far as I remember, I had 25 papers as a co-author with him. So it's my privilege to introduce Dr. Anirban Ghosh. He works in a small place, but his load, patient load, his dedication and improvement, he has got his own dissection lab, he has got the full setup. So he does all sorts of surgery. With this, may I request Dr. Anirban Ghosh to start his lecture, how to improve the hearing improvement, which is the main outcome of our ear surgery.
Thank you, sir, for your kind introduction. After this beautiful session on cadaver dissection, I'm going to take something on a very usual topic of middle ear surgery, that is ossiculoplasty, and how to improve the results. I thank you, Dr. Ghosh, and the team of Medicover, Elevate ENT Summmit, for inviting me. Now we will start our topic on ossiculoplasty and how to improve the result. So what is ossiculoplasty? It is basically correction of the ossicular chain abnormality with the aim to improve hearing of the patient, and ear should be safe, dry, and it must work properly. So basic mechanism of middle ear is basically, middle ear is having a impedance matching transformer mechanism, because the impedance of fluid in the inner ear and the impedance of air is different. This R, the value, this is R, the energy transfer from air to the fluid, 40 decibel is loss. So it is increased by the tympanic membrane. Aerial ratio, that is the tympanic membrane, is to the stapes, where there is a large area, same force, lower pressure, and here is the smaller area and much higher pressure. So this aerial ratio gives a rise of 26 decibel, whereas the ossicle, that is the handle of malleus, is to the long process of incus is 1.3:1, which gives a 2 decibel gain. So there is actually 28 decibel, but practically there is 20 decibel gain due to the loss of inertia and everything. So why this is important? Because in ossiculoplasty, we have to connect the tympanic membrane with the footplate or the oval window so that the energy is transferred. Are involved. Minor, it is normally in the middle ear, which is very rare. Most commonly, it is the footplate fixation associated with other ossicular or suprastructure abnormality. And the prognostic factor, hearing prognosis, depends on the presence of round window, pneumatization of middle ear, course of facial nerve, etc. This is the basic topic we are going to talk, that is acquired ossicular pathology. Normally, we see as a consequence of chronic otitis media with or without cholesteatoma, more common with cholesteatoma. Mostly, long process of incus is necrosed, followed by suprastructure. Malleus handle is usually preserved. Subtotal perforation will normally have shortening or absence of the malleus due to medialization. Ossicular disruption can be present due to trauma and etc. To categorize ossiculoplasty and to document it, we must have a classification. The classification of Austin classification, which was in 1974, has, when the malleus, here stapes means the stapes suprastructure. When malleus is present and suprastructure is present, it is called class A. It is in 60%. When malleus present, stapes absent, 23%. Malleus absent, stapes present. Malleus absent, stapes. 4 classification A, B, C, D, where A is the basic one where incus is necrosed. After that, a modification came of Cartouche, where O is the ossicle intact, E is ossicular head fixation, and E is stapes fixation. Drawbacks are the partial necrosis of lenticular process, isolated malleus fracture or stapes fracture was not included. So what are the prerequisites of a good ossiculoplasty? So we must create a stable, well-ventilated middle ear, intact TM, absence of ongoing infection or cholesteatoma. Sometimes ossiculoplasty is staged for this reason only. And prognostically, we can tell that this patient will have a good prognosis by having a MERI, that is Middle Ear Risk Index system, by Cartus in 1994, where they took consideration whether there is tympanic membrane perforation or not, cholesteatoma or not, granulation tissue, ossicular pathology, that is the Cartus classification. And recently in 2000, they have added whether the patient is a smoker or not. Ossiculoplasty outcome parameter staging, that is OOP staging, and SPITE, that is surgical, prosthesis, infection, tissue, and eustachian tube factors. What are the different materials? What are different materials do we use regularly? First of all, the important factors for a good material, it should be biologically stable, resistant to resorption, non-reactive. It must have a correct mass and stiffness. It should not be very heavy and it should not be very stiff, easy to handle, and ideally low cost in our Indian setup. We can have autograft, that is the graft from the patient itself, that is patient's own ossicle, bone or cartilage. Advantage, it is biocompatible, no cost, low risk of extrusion. Disadvantage, it takes more surgical skill and time. It may harbor cholesteatoma and it is not always available. Homograft, that is from cartilage or bone or ossicle bank, where you have to preserve the ossicle in 70% alcohol for at least more than 1 month. Advantage, the operating time is short and no risk of harboring disease. Disadvantage, prion disease or Creutzfeldt-Jakob syndrome, only seen in 2 cases till now. Alloplastic, titanium, steel, gold, porous like plastipore, like these things, these are plastipore, and bone cement like hydroxyapatite, and titanium. In all practical purpose, in our setup, we use either cartilage or a plastipore or PTFE or a titanium. Now, a few important definitions of ossiculoplasty. What do you mean by columella? Columella means it is the connection between the neotympanum and the ossicle. And what is assembly? Assembly is the connection between 2 ossicles. And what is TORP and what is PORP? Total ossicular replacement prosthesis when the footplate is present, suprastructure absent, and partial prosthesis when the superstructure is present. What are the factors for a better ossiculoplasty? First is the tension. The tension between the ossicles, it should not be very tensed and it should not be very loose also. If it is very loose, there will be less energy transmission, and if it is very tense, then also the movement of the ossicle will be hampered. Round window protection. There should be some amount of air in front of the round window so that there is a lateral movement of the round window membrane. Angle. This is very important. Whenever we put an interposition ossicle or an incus like this, and this is the tympanic membrane, the force, the sound force is F, and it makes an angle alpha with the stapes superstructure. Now, this force F with an alpha angle, the F1 force will present on the stapes superstructure, and only F2 will be the force that produces movement in the endolymph. So, how to overcome that? We can put a prosthesis like a vertical prosthesis from the tympanic membrane, and we should reduce this angle. This angle should be between 45 to 90 degree. It should be centered in the neotympanum, and there should be a space of at least 0.3 ml around the ossicle. That means the neo-ossicle should not touch the posterior bony overhang or the bony annulus, so that it will dampen the hearing. Before going to the ossiculoplasty, this is the area called the isthmus area, posterior isthmus area. We must clear the posterior isthmus area from any granulation tissue and etc., so that our incus can become mobile. And the best ossiculoplasty is the ossicles or the assembly of the ossicles that God had given. And if we can preserve this by just removing the granulation tissues and all, we will have a better hearing. Now we are coming to the actual different situations of ossiculoplasty. First, you can see we can have less than 10 to 20% necrosis of the long process of incus. In these cases, if you cover it with a periosteum or a hydroxyapatite, you can have a good hearing result. Situation 2, when the incus is necrosis, there is a partial necrosis of the incus, and it is more than 20-30%. And you can tell these patients there will be a necrosis of the lenticular process of the incus later on. In these cases, we should remove the incus and create an assembly between malleus and the suprastructure by giving a sculptured autoincus interposition, that means between malleus and stapes suprastructure. Transposition means between stapes suprastructure and the neotympanum, or we can give a short columella of cartilage or a partial ossicular prosthesis. Now, Austin Carthu's type A, we can give autologous incus interposition, but we must keep in mind the skill and the time is more and cannot be done if the malleus is much anteriorly or medially placed. In these cases, you have to do a malleus relocation technique. So you have to stretch or cut the tensor tympani tendon, and you have to stretch the anterior malleolar ligament. So malleus will be held with only the help of the superior malleolar fold. And the malleus will come up to the same plane of the stapes head. We can give partial ossicular prosthesis. We can give cartilage minor columella or the small columella. There is a recent literature, and I was very lucky to be with him, Robert Vincent at France. They have come with an idea that even with a suprastructure present, we can put a TUR prosthesis with a silastic band. The silastic band, the band will hold the prosthesis with the suprastructure, and they have seen that this gives a better stability and energy transfer. This is creation of the short columella, how we create a short columella from a cartilage. We put this cartilage like this and put a hole and put it on the stapes suprastructure with a small slit for the stapedius tendon. This is the malleus mobilization technique. Now we are mobilizing the malleus medially so that it comes up to the level of the suprastructure. This is the partial prosthesis titanium. It is very important to put a cartilage interposition between the prosthesis and the neotympanum. And this is our technique. For a few years we have done this. A small piece of sliced cartilage over the titanium prosthesis, and we are suturing it with 6-0 Vicryl. Austin type B, when the stapes is absent, we can give autologous sculptured incus, homographed cartilage, or TURP. This long columella, that is from the footplate to the neotympanum with cartilage, ossicle, and TURP. But when we put a long columella, the disadvantage is Medially, there is no support, as the foot plate is a plain thing and we are putting the prosthesis on that. And laterally also there is a mobile tympanic membrane. This is creating a long columella. This is total ossicular replacement prosthesis, and we are creating a small cartilage shoe by putting a 23 number of suction over a sliced cartilage and cutting accordingly. So this small columella, the small cartilage shoe, will hold the prosthesis onto the foot plate. Whenever the malleus is absent, we can, this is again from Vincent et al. They are using, this is called malleus replacement prosthesis. We do not use it. And when there is malleus and stapes, both are absent, so mostly seen in canal wall down mastectomy, we can give cartilage or ossicle long columella from foot plate to the tympanic membrane. Even we can use TURP with cartilage shoe and interposition. So this is a small video. You can see these are the two parts of a titanium TURP, and we are putting the titanium TURP inside. And now we are creating a small cartilage shoe. Cartilage shoe is from the sliced cartilage with a small hole to hold the base of the this TURP. And after that, we will put this thing into the foot plate. And after that, we will put in cartilage. See, there is a space between this, your posterior canal wall, and the prosthesis. Even if you put a cartilage interposition, there should be a space. It should not touch your posterior bony canal wall. And this is ossicular head fixation, mostly seen in tympanosclerosis, where you can see we are removing 2 millimeter just above the ossicles, so that there is no tympanosclerosis or granulation tissue or ankylosis. And we are, after removing this thing, we are putting a very fine silastic sheet over it. Very fine silastic. Sorry for the video. This video is not good at all. This is a small silastic sheet. We cover it, and after that we do tympanoplasty. We are getting a very good results with this. So even if you don't do an epitympanotomy, you can remove the tympanosclerosis, or you can remove the fixation of the ossicular head like this. And stapes fixation, it is a very dangerous situation. Sometimes we see in the foot plate tympanosclerosis, we can remove the tympanosclerotic plaque and etc.
Anirban, time is 15 minutes is up.
Okay, sir.
I think
it's 2 minutes.
Okay.
This is the world literature where you can see with the stapes superstructure, the results are good. Without it, the results are not good. This is a canal up technique. Is a results comparison of canal up technique. But the important part is 45% of all planned canal up techniques eventually require canal wall down technique. So in canal wall down technique, again, if there is a superstructure, the results are good. Without superstructure, results are not good. And if you do a canal wall reconstructions, the results are even better. So, conclusion, the presence of stapes superstructure is the single most important factor for a good hearing outcome. Presence of malleus handle is an independent prognostic factor. Percentage of extrusion rate of prosthesis is 5 to 8% in our study. Incus interposition is technically challenging, and it yields no better result than transposition. Cartilage short columella and the prosthesis provide same results. Titanium TURP and major columella produce almost the same long-term results. And it should be individualized. Stapes superstructure present and absent options are clear. And if possible, please try to preserve the malleus handle, because if you put a prosthesis or a columella between the handle and the foot plate or superstructure, the stability and the vibratory functions are better. For all practical purpose, for cholesteatoma surgery, the option should be canal wall down with ossiculoplasty with cavity reconstruction. So this is all about ossiculoplasty, and thank you for your precious listening. Thank you.
Thank you for your nice presentation. We are already running short of time. Actually, we didn't fix up the timer here. And
Timer was fixed.
time is fixed there. So it's up. But basically, to summarize it, it's a good presentation. I think the discussion part will be doing it later. But the most important prognostic factor for any ossiculoplasty, whether it will stay or failure, is the eustachian tube function. If your eustachian tube is not functioning, if your middle ear mucosa is not proper, whatever ossiculoplasty you will do, it will again in the long term, it will go into the failure, it will go into the extrusion. So these are the important point. I think rest of the question we can discuss it.
Sir, you can take 5 minutes for question answer.
Okay.
And we have hand mics here. Whoever wants, we can pass on.
So hello, do you have any experience with GIC?
Experience with, ma'am?
GIC, glass ionomer cement.
No, madam. We don't have any experience.
So that GIC is a good one. Particularly the long process of the Incas, Jubercar is used, that GIC means that ionomer cement, and that gives a normal ossicular assembly.
So as far as GIC concerned, we have a series of GIC. We have had good as well as certain very dicey results. So what has happened is when you have a 2 mm gap between, so you can measure that gap using a suction. And if you have a 2 mm gap, you can bridge it. And earlier we were bridging it, and few of the patients. So they did have a high frequency loss, and I'm still. Once you place the GIC and shape it in that area, you cover it with a temporalis fascia. It sort of gives you a good cover. But since few of our post-op patients have had excellent immediate results, with long-term there is a high frequency loss. So I'm just wondering whether it is the weight issue and trying to see what's the problem.
Even, madam, in all the long reports, they have taken 3 parameters. One is the airborne gap, second is the air conduction threshold, and third is the bone conduction in higher frequencies.
Yes, true.
Because in the long term, there is a something high frequency bone conduction loss in some of these cases.
Exactly. And if you look at these long-term ossiculoplasty results also, like let's talk about 25 years down the line or 20 years down the line, none of the series will give you a very satisfactory result. So ossiculoplasty in itself might give you say 10 to 15 years might be, but with long-term, so there is an issue of this artificial thing. Yes, fluctuation, because you keep listening and there's attrition. There are a lot of things which are involved.
I'll just share our experience at SMS Medical College, Jaipur. We have been doing these ossiculoplasties for like last 20, 25 years. I've used even the top and pop and titanium and everything, you know. In the long-term results, I've seen that these top and pop also they extrude in quite maybe around 25% of the cases we have seen on the long term. So for the last 5-7 years, what we have started doing is a vertical strut. We make a wedge-shaped cartilage. It is just like maintaining the same aerial ratio the God has given to us.
Right.
Ratio of the tympanic membrane to the footplate area.
Right.
So we make a wedge. It has got a flat surface outside which touches the tympanic membrane. It has to overshoot the membrane a bit, and the conical part goes to the footplate, even if the stapes suprastructure is present, to give you some middle ear space. We have also published that in IJLO. So for last 5 years, I am seeing these results. Although there is high frequency loss with these cases also, because this direct shooting is going to the labyrinth.
Yes.
But my patients are happy because AB closure is there.
Right.
So that is, but I have yet to publish my long-term results.
Sir, this type of results have been already published, that even in the presence of the stapes suprastructure, they are putting a torp onto the footplate, and banding it with the
just like Robert Wilson does.
silastic
Okay,
band. And
silastic band technique.
This is giving a good result, but as Madam has already mentioned, the long-term result should be, we should take consideration of the long-term results.
Thank you.
Let's move to the next session. I'll take the pleasure to invite Dr. S.K. Apparao sir. He is a leading ENT surgeon from Visakhapatnam and a renowned ENT surgeon in Andhra Pradesh and for that matter in the entire India. He is more known for his otological skills. He is a past president of Indian Society of Otology and past president of AY South Zone, past president of AY AP, and attended more than 400 surgical workshops, conferences, seminars, dissection courses in India and abroad. And moreover, he is a good sportsman. So with the brief introduction, I will hand over the session to Dr. S.K. Apparao sir for delivering his lecture.
By the time we start our next talk, if anybody has a question, any questions to be asked after 15 minutes of the talk, you are free to ask, and we have a volunteer here. She'll come to you with a mic. Thank you.
Good morning to all of you. At the outset, let me thank Dr. Sampoorna Ghosh and her team for excellent academic activities they are conducting. So my topic is today's stapes surgery and my experience. See, so what is this? Simply you are looking at the table. The most important part of the surgery of the stapes is the field of the surgery. For that, how to achieve it? Starting from the position of the patient head, table position, and your chair, and your height of the chair, all this matters for a best field to get best results. So you are dealing with the posterior tympanic space. For that, and less condition, that means head up position of 15 degrees and neck extended and tilted towards the surgeon. That's the best position to get a maximum field of the surgery of in the stapes. So, regarding the infiltration, you know, we have to take a small gauge needle with a length 26 gauge needle and infiltration. I'm not going to stress much on this particular point, but it should not produce any much bleeding. No, so your injection must be very effective only in subcutaneous planes and especially in a thicker part of the skin. That reduces the blebs and bleeding and contamination. So you should have a clean field while doing stapes surgery. Next, coming to the identification of the chorda, you should be very careful. You have no right to damage the chorda. You have to try to preserve, if it requires more time also, spend more time to preserve the chorda. Suppose if you happen to operate patient on both sides stapes surgery, we lost the sensation of the taste, it matters much. So chorda tympani nerve preservation is, you have to be cardial with the chorda, and you have to put a decongestant, and you should not stretch too much. That produces taste sensation disturbances. And if at all is needed, you do a drilling of the scrotum area and lengthening of the nerve. And if it fails, then the release from the undersurface of the malleus. There is a mucosal attachment to the malleus. If you release that mucosa, it will become more lengthening. So that's how we have to achieve the space. So what is the space required? That means ideal space is to see both the windows, both the nerves, and both the ossicles. That is your ideal field for the stapes surgery. If you cannot achieve good field, it's cumbersome surgery. Placing a fistula is difficult, curating is difficult. So everything becomes difficult in a constrained space. And bone removal. So especially for junior colleagues, my message is, you have to use a very good curate. The reason is, the scrotum is like triangle, like a cake piece. So first to make this part of the bone thin, then go to the edge of the scrotum. Suppose if you use more force, there is a chance of slipping onto the incus, onto the foot plate, resulting in SL loss, resulting in facial damage. So should be very careful while curating it, and should have good quality and good control of your curette's action. You should not use your shoulder. You should use only your lumbricals and fingers movements. That's very, very important. So most of the surgeons, right-handed surgeons, they feel comfortable when they operate left side, because the movement is towards you. The curettage of the left ear is here. When comes to the right ear, it is like this. So be careful while handling it, and if you feel difficulty, make it thin with a drill, then curate it. So what is next is, avoid contamination of the middle ear with the bone dust. For that, you keep a gel foam, wet gel foam in the middle ear to avoid bone dust, or even if you drill or curettage, the bone dust produces complications later. I had one case where the bone dust has produced fibrosis between the incus and the promontory with the fistula intact. After 3 months, the patient developed hearing loss, tinnitus, and vertigo. That is because the fibrotic band is pulling the incus to the promontory, towards promontory. The fistula is plugging into the vestibule. So, clean wash of the middle ear before perforating the foot plate. The other point is, we are all doing stapes surgery with local anesthesia. That means Xylocaine, Adrenaline. Are they cochlear friendly? No. They are known for ototoxicity. So, foot plate is nothing but a cup. The wall window is like a cup. So, the Xylocaine and Adrenaline solution will be collected in that. Before perforating the foot plate, you should be careful to wash it, the entire windows areas. Or if you make it more friendly, wash with a Decathlon. That's more friendly. So avoid contamination with the Xylocaine and Adrenaline solution in the foot plate area, even round window areas also. That is importance of the middle ear wash. So next is, anyhow, we need to see the mobility of the ossicular chain, whether intact or not. Rarely I have come across 2 cases of third window syndrome. Ossicular chain is mobile, conductive deafness, In those days, the CT scan was not there. So we couldn't understand. Again, we gone for hearing aid. So that also is we have to exclude. And rarely we can come across anterior malar ligament fixation, in which the restriction is of the malleus also can produce conductive loss. But Indian scenario, it's not very common. But European society, they have a lot of anterior malar ligament fixations. So this is how we have to check for the oscular chain mobility and fixation. Measuring the fistula length. This is very, very important. So what we have discussed already, you can see the two windows. That is, one is round window and oval window. Two oscles, incus and stapes, and two nerves, that is chorda and the horizontal portion of the facial nerve. This is the ideal field for best results. And once we open the vestibule, you cannot do curettage. And the open vestibule if you expose for the light source heat, that can also produce damage to inner ear. So before perforating the foot plate, you should be pakka about your space management and instrument management, maneuverability of the instruments. That is, you should make it pakka, then only open the foot plate. So measurement is with one is the measuring rod. The other way for the junior colleagues, I suggest take 4 mm piston and place it. It's like a mock drill. Whether this curettage space is sufficient or not, whether your instrumentation is correct or not, whether the position of the patient is correct or not. After opening the vestibule, that becomes very easy. You don't feel tense and your heart rate will not increase. The other thing is, if you are operating a stapes surgery, don't do any strenuous exercises, don't take beverages. That produces mild tremor. And stapes itself produces tension and tremor. So you don't add beverages which increases your measuring the piston with both the measuring rod and the piston. Yeah, coming to the perforation. So we have defined the bowel window is free of gelican and ateline, and the space is sufficient for maneuverability, and the perforator must be high quality. It should be very strong and very sharp. You have to have a 2-0 paper. For the goldsmiths, they use it. You keep it in your instrument alarm. Once after the surgery, just make it sharp under microscope. That's how you can maintain your instruments in better quality. The perforation is always perpendicular to the incus. It should be perpendicular, not angular. Suppose if you produce a perforation in the foot plate in the angle fashion, there will be friction for the piston. So it should be vertical movement. That means your perforation must be perpendicular to the long process of the incus. That's how we'll get perforation. Suppose if you come across a thick foot plate, what is the management is? Just take first 0.8 mm, 6, 5, 4, 3, reverse. It will become like a cylindrical, not like a cylindrical, it's like a cone. Then again start with 0.1, 0.2, 0.3, 0.4, then it becomes cylindrical. In thicker foot plate, the perforation must be wider than normal thin foot plate, because there is friction with the piston. To avoid that, It should be perpendicular. It should be wide enough in a thick foot plate. This yeah, just logical. See, about the piston. The loop of the piston, if you take a cut section, it is rectangular. Rectangular cut will have more surface area to hold the piston with the incus. That means the transmission will be good without producing necrosis of the incus. That's the principle of that rectangular surface. But if you take a shaft cut section, it is circular. That is to avoid friction to the movement in the foot plate. Suppose if the piston is like a square type, it produces more friction because more surface area. The circular is less surface and more effective. So that's how they design the pistons. Insertion of the piston. So usually what we do is we'll put there is a piston holding forceps. It should be 140-degree angle, not like straight. That means your fingers will come into the field. If it is 140, the piston will be like this. So visibility is clear with 140-degree holding of the piston. That is how the insertion will take place. Piston crimping. The crimping force has got a typical crimping has got only, it has got two limbs. The posterior limb is fixed, only anterior limb will move. Suppose if you want to use any other instrument, that will pull the piston out. Suppose crocodile forceps, if you use it, it will pull out of the vestibule. So it should be, the posterior limb should be fixed, only anterior limb should be active. And the pressure should be constant and more period, not like, don't crush it. Pressure in the corona, yeah, this is very important. While next step is to, now we have done a stepidotomy and fixed the piston. Now, the most important, more tensible job is how to handle this stapes. So cut the crura, the tendon, and cut the neck of the stapes. Take out the neck and the head of the stapes only, not the crura. Because what we need is a bypass of the crura movement. So we are avoiding the stapes. Not that it's not a cholesteatoma or disease or something else to remove the entire stapes. What is needed is to bypass the movement of the stapes. We can we have cut the neck and removing the head and neck of the stapes. That is suffice. The gap between the crura, leftover crura and this incus is around more than 1 millimeter. That is sufficient for the movement of the stapes. So handling the crura, handling the foot plate, all produce a lot of tension and possibility of complications. Why people are opting for laser stepidotomy is because of the fear of handling the foot plate. So in this scenario, we are avoiding the foot plate management. We are not touching the foot plate. We are not touching the crura. So that means you are getting the results without injuring the foot plate and its sequelae of SL loss. So sealing of the perforation with the soft tissue, and this part should not have a xylic and adrenaline also. The site you are incising should not contain xylic and adrenaline. So be careful about it. And repositioning the TM flap. So most of the flap, after repositioning, what will happen is the edges may bleed. blood may collect in the tympanum and produce mesotympanic, hemotympanum and its complications. I had one case where they just had bled so much and collected in the middle ear, and the patient had a vertigo, and after 3 days, they exploded this lot of blood. So, to avoid that, like embolization, to take a gel foam with the Decatron, wet gel foam, and press against the cut edges of the meatal flap, and press against it. It produces microembolization of those vessels. It will control bleeding. So gel foam, I use only gel foam, no cotton balls. And you should be careful about eternal usage and eternal wash. And bone dust should be washed out. Middle ear wash is very, very important. Usage of antibiotic drops in the middle ear is no role and should not use. And glove powder. So we get a powder gloves. For a middle ear surgery, not only the stapes, better to use without powder gloves. No powder gloves. The powder glass is one of the reason for the intact eardrum. Hearing improvement is there, but weeping ear, that's called meningitis. Most of this because of the glove powder and thank you very much for the patient hearing.
Sir, that's a wonderful lecture, sir. So each and every step you delivered a lot of tips how to improve. So any quick questionnaires for 1 or 2 minutes? Yeah, thank you.
Thank you, sir, for the wonderful presentation. Which instrument did you use for cutting the head and neck of the stapes?
Yeah, that's it. Curved scissors, sir. Curved scissors.
Which scissors?
Is it chlorotomy scissors?
Chlorotomy scissors, like
Chlorotomy
chlorotomy scissors.
Okay.
Same thing can be used.
Okay.
Sir, one more question. Why you said should not be, we should not use the antibiotic drops in the middle ear, sir?
So, what is the antibiotic drops? Most of the antibiotic drops in the open vestibule is autotoxic. It's autotoxic.
Sir?
In the inner ear. Because we are opening the inner ear.
Sir, very nice presentation. But while you are cutting the head and the neck of the stapes, is there any, there is no chance of fracture and out fracture of the foot plate?
No, if you cut properly in enough space, there should be enough space for the handling of the scissors.
Okay.
Then it is easy to cut the neck of the stapes.
Sir, before cutting, do you dislocate the ISJ?
Yes, of course.
Normally you dislocate it and then cut.
Hi, sir. Pawan Singhal. Sir, I have seen Dr. Suri Prabhu at Kerala. He used to do a stapes suspension technique. I started doing that technique in 6 cases I've done so far. And I've seen better results there. What he does is, I'm just sharing his experience and my experience about that technique. What he does is, he keeps the whole stapes structure with the stapes intact. He makes a hole there, stapedotomy, puts in a piston. Then either with the laser or with a sharp pick, what he does is, he breaks the posterior crura. And once it has been broken, then he takes a curved pick and he moves the suprastructure on the promontory, and it keeps touching the promontory like a suspension. Okay. So this is how he is keeping the caustic reflex somehow intact. I've started doing that in 6 cases, seeing good results. No long-term follow-up is there, but that is an alternate technique I wanted to share with you.
I think it requires more skill. What you are telling is not a handling the crura and making it weak and displacing onto the
promontory
with intact,
IS joint.
That's
and
very
the
difficult.
ligament.
Very difficult because to reach
makes a suspension.
To reach the promontory, it needs 40 degree,
yes.
At least 45 degree.
Yes.
Then when the 45 degree from the joint, joint will be
It's
lost.
a difficult one, but doable, sir. I could not do it in maybe 4 or 5 cases, but then with patience and practice, Now 6 cases in my series.
Good.
Hello, good morning, sir. Sir, I wanted to ask, what is your preference regarding diameter of the piston which you are placing? Always 0.5 or always 0.6, or is there any, preference according to the hearing loss you are seeing in audiogram?
Regarding the piston diameter, I'm using 0.5. 0.5.
Always 0.5.
Always 0.5. But initially I started using 0.4, but maybe the junior, not much of seniority in those days, the piston is to be bent. I used to be very scary, and again I will to take. But 5 is strengthy and gives a low frequency is better.
Good morning, sir. Very impressive presentation, and I would like to ask you one question. What is your experience on laser stamps, sir?
Laser?
Yeah.
I'm a poor man, stapes surgeon,
Yeah,
so I don't have any laser. But as for the laser is concerned, what I heard about the laser and I have discussed with the laser surgeons, what we used to think is when you use a laser, it produces heat and SL loss and cochlear damage. It's not true. It's not true. It is. So, if you have a laser, very good tool. You can reduce your tension. And even laser also, it's like a bomb. It's like a bomb. If you don't use it in proper way, it can produce problems. Like too much charring is there, you don't clean the thing, that can produce a bomb. It can produce total SL loss. So even with laser also, don't say that it's 100% safe. It is 100% comfort. There's a lot of difference. The comfort zone will increase for the surgeon. And even laser also needs more space to avoid accidents.
Sir, thank you, sir. Sir. So we would allow maybe around 1 to 2 questions. Why? Because we are running short of time, sir. Okay. If you don't mind.
Okay.
Thank you very much, sir.
Thank you very much, sir, for the elaborative discussion on stapes surgery.
Now, I call upon Dr. Abhishek Srivastav. Okay, everything is will be given there, so I'm not telling all these things. Abhishek is a very young and dynamic surgeon, self-made surgeon. He is the first person in the West Bengal who did CSF leak repair when he was a third-year student. Rest everything has been written there, so I'm not going to tell. So he does lot of innovative things on, and most of the people of India doesn't know him. Only those who are close, like me, I know what work he can do. And I invite Dr. Abhishek Srivastav to share his experience on, share his experience of subtotal petrosectomy, which very rarely the ENT surgeon does for the management of chronic otitis media. Over to Abhishek.
Thank you, sir. Thank you. Good morning, senior delegates and my friends. Today, my topic of discussion is subtotal petrosectomy in chronic otitis media patients with inner ear complications. Before starting my presentation, I must acknowledge the book of microsurgery of skull base. I learned the tricks of doing subtotal petrosectomy from this book actually. And if you come across patients like this, in which you see already 2-3 times the patient has undergone surgery for cholesteatoma, and they present with lot of complications like post-oral fistulas and facial nerve paralysis. And adding to this type of complication, now we are seeing a spectrum of patients with malignant otitis externa. When we were PGs 20 years back, we didn't had that number of malignant otitis externa patients who used to present to us in our OPDs. Now, if you see patients more than 40 years with chronic discharging ear, with intractable otalgias, our first suspicion is to exclude malignant otitis externa. I'm including such patients in this series for my experience regarding subtotal petrosectomies. I'm excluding the neoplastic lesions in this presentation because this will unnecessarily increase the time of presentation. So our experience is not that big. We have been doing subtotal petrosectomies at my center for last 5 years, and we have managed to do almost 21 cases. The major part was male patients who were above 40 years of age, and we did any bilateral total subtotal petrosectomies in our series. 2 of the patients underwent facial nerve grafting, 1 had a facial nerve decompression. Most of the patients who presented with inner ear complications had lateral canal fistulas and also superior canal fistulas in some of combined cases. 1 patient had a cochlear fistula on the promontory, and 3 cases that we did for CSF, apart from discharge, they were operated more than 4 times for mastoidectomies for cholesteatomas. They ended with discharging ear. Also, they had discharge of the CSF from the same ear. So, describing the case distribution for these cases, we had primary cholesteatoma cases for 4. Then we are operated on malignant otitis externa on 3. Surprisingly, we had also 2 cases of TB mastoiditis. 1 had facial nerve paralysis. Both these TB mastoiditis patients were treated as CSOM. They were operated for tympanoplasties by endoscopic methods and all that. They ended up in bad failures, and their biopsy of the mucosa after the surgery came out to be as tubercular lesions. So we also had recurrence here. Where recurrent is they were operated beforehand. 9 cases were of cholesteatomas and 3 were non-cholesteatoma patients who underwent subtotal petrosectomies. I will elaborate in later why they were chosen for subtotal petrosectomy. So what are the indications when we select patients for subtotal petrosectomies? It's recurrent disease. Patients had inner ear involvement. They had giddiness. They had bad hearing, actually almost dead ear. They had facial nerve paralysis, range from grade 4 to grade 6. They had CSF otorias, then temporal bone tuberculosis, malignant otitis externa. Neoplastic growths and traumatics have been excluded in this series. So coming to what is subtotal petrosectomy is, we all are into doing mastoidectomies, but subtotal petrosectomy is a bit different from doing regular mastoidectomies. It follows the principle of, in fact, removing almost all the air cells. You can leave behind some Peters effect cells, but principally you must exenterate almost all mastoid air cells. You cannot leave mucosa in the operated cavity because they can end up producing mucoceles in the operated cavity. The external auditory canal is closed so that there is no communication between the operated cavity and the external environment. And there is obliteration of the operated cavity with abdominal fat and temporalis muscle flap. There has to be a complete removal of the disease and obliteration of the cavity to follow the principle of subtotal petrosectomy. In these cases, imaging is must. You cannot go by clinical diagnosis or X-rays to make a surgical planning. You must make the patients undergo HRCT temporal bone. In fact, you have to have some checklist of the radiological findings before planning for surgery. You must see the pneumatization. You must see the ventilation, because if the patient has got a poorly ventilated mastoid, be sure you are going to get a sclerosed contracted mastoid and a atelectatic tympanic membrane in that case. You have to see the external ear canal also, because you have to drill down the tympanic bone and also see the TM joint anatomy in relation to the ear canal. The size and the presence of the emissary vein is also important, because you are drilling far behind the sigmoid sinus in doing a subtotal petrosectomy. if you are going to find some big emissary veins, be prepared with bone wax and Sergi cells to encounter the bleeding. Then the anatomy of the sigmoid sinus is also very important in relation to the mastoid cavity. Jugular bulb, you must see whether it is high-riding jugular bulb, the bone over the jugular bulb is proper or it's dehiscent, because you are going to drill out the hypotympanic air cells. So in case of a dehiscent jugular bulb, the chance of torrential bleed is there. Carotid artery. In my series, I have not seen any of dehiscent carotid arteries, but in literature it is mentioned that in 10 to 15% of the cases you can have carotid artery dehiscence near the area of eustachian tube opening. So in tegment tympani also, when you are doing revision mastoidectomies or revision cases, many a times you will find a dehiscent tegment tympani area where you can see some meningoencephalocele hanging into the cavity. Facial nerve also is very important. Then the size of the fistulas in the lateral canal, superior canal, or the cochlea has to be seen in the HRCT temporal bone, and you must be competent enough to find out yourself, because many a times your radiologist might miss these things because he's not seeing the patient as closely as you are seeing him. So extent of the disease is another important factor when you are trying to do a subtotal petrosectomy, because by definition subtotal petrosectomy we are going to preserve otic capsule, but it is not must. You can also drill out the otic capsule if required to completely exenterate the disease. Now, after the CT, the next important thing that you have to look after is the audiogram. Audiogram doesn't mean only pure tone audiograms. What we strictly follow before putting our patients for surgery in cases of subtotal petrosectomy, we do SDS and SRT in such patients, and also a hearing aid trial. That hearing aid trial is done in front of me, and I ask the patients whether they are satisfied using the hearing aid or not. Because you are finally you are doing a radical surgery when you are going to close the ear, and there is no chance of using hearing aids in such patients. So any patient at any time of your clinical examination shows that he is having improvement with hearing aids, the chances to avoid the subtotal petrosectomies can be taken. But if the patient is having a poor SDS score, poor SRT, and his response with the hearing aids trial is not up to the mark, then be sure the best treatment you are going to give to your patient is a subtotal petrosectomy. If PTA is something like this, be sure there is no use of keeping the ear open and trying for hearing aids in such patients. So when you prepare the patient for the surgery for subtotal petrosectomy, it's not like regular mastoidectomies. You have to shave the hair about 7 centimeters far from the hairline, superiorly and posteriorly, and also the inferior quadrant of the abdomen is also cleaned to harvest the abdominal fat. Positioning is just like simple ear surgery. You have to make the patient supine with head turned away from the surgeon. If you have got a facial monitoring system, then it's good. But if you don't have that, it doesn't mean that you cannot do the surgery. The procedure for this, you have to have a post-auricular S-sepate incision, which starts from the temporal region and goes below the mastoid tip. I will just show you on the picture how it is done. The incision is far up to far down. The upper part of the incision is to harvest the temporalis muscle flap, which we have found in our series to be working like Haddad flap in the nose. It is very good flap for reconstruction of lateral skull base defects. Then second step is you make a C-shaped musculoperiosteal incision. This C-shaped musculoperiosteal flap that you harvest forms the second layer of closure of your blind sac actually. So once you have done that, elevated your flaps, external auditory canal is sectioned from 6 o'clock to 12 o'clock, as you do it in your post-auricular approaches for mastectomies or tympanoplasties. Added to this, you have to elevate the anterior part of the skin also with the cartilage so as to facilitate the blind sac closure. So in the blind sac closure, once the skin and the cartilages have been elevated, the stay sutures are put and an artery is passed transcanal through this lumen, and the stay sutures are pulled out so that the entire skin comes out and it is ready for suturing. It is sutured with 30 or 20 vicryl. Once you have completed the closure of the external auditory canal, then the next thing that you need to do is you need to exenterate the medial skin part of the external auditory canal with the tympanic membrane and the ossicular chain, and that is removed in toto actually. So after doing all those things, you do a regular mastoidectomy and you go on increasing your extent of dissection to exenterate almost all the air cells that come into your way, and you in fact skeletonize the facial nerve and the labyrinth, and so the final cavity looks like something like this, and you make sure that you have meticulously done the hemostasis in each and every part. You don't need to expose the facial nerve, sigmoid sinus and the meninges during the part of the surgery. If they are already exposed, then there is no part, but every effort should be made that these are not exposed by your hand. So apart from doing this, you have to drill out anteriorly near the eustachian tube part to exenterate the pericarotid cells. In this, the mastoid tip is left behind, it's not drilled actually, and there are some technical parts for drilling the supralabyrinthine part. Use the diamond drills in reverse mode to avoid injury to the facial nerve and the superior canal. The micro respiratories are used, and meticulous use of cotton balls soaked in adrenaline is a must to elevate the mucosa from the middle ear. So it takes care of the hemostasis, and also the removal is done. You must take care not to subluxate the stapes suprastructure. So then comes the role of obliteration of the eustachian tube. There are different schools, they follow different ways, but you can use actually bone wax combined with periosteum or muscle of the tensor tympani to occlude the eustachian tube. It works very good. So while drilling this area, you must be very careful of the carotid, because carotid lies very close to this area. So finally, when it comes to the obliteration of the operative cavity, you have to use the abdominal fat. What we have come across is we use abdominal fat soaked in rifampicin capsule. Rifampicin is actually mixed in the saline, and then the harvested fat is kept in that. It provides a good antibiotic coverage to the free tissue abdominal fat and avoids infection into the post-operated cavity. And over that, we rotate the temporalis muscle flap to make a good closure here, good closure of the operated cavity. So once you have closed it, the temporalis muscle, you see we have created mobilized in fact the temporalis muscle, and we create a pocket finally underneath the sutured temporalis muscle to put up the fat. So these are the ways how we harvest the temporalis muscle and rotate it onto the this. So temporalis muscle is sutured back into the operated area by using 20 vicryls over the sternocleidomastoid and posterior osteoplastic musculoperiosteal flaps of the occipital area. So wound closure is done with over a drain, and 20 vicryl is used for the suturing. A compression bandage is applied over the wound, and we admit the patient for 7 days. But I have written is amoxicillin and clavulanic acid as written in the books, but I prefer using piperacillin tazobactam in such patients for 7 days. If the patient is having a CSF leak, we'll discuss it in. We don't put any drain for long term there. So how to follow up these patients? We follow up these patients for 3 years, and we put up CTs. We asked them to get their CT scans at 1 year of the surgery and following 3 years after the surgery. In cases of previous cholesteatomas, we use contrast MRIs to detect the recurrent diseases. So what are the auditory rehabilitation? In our experience, we have not done any Baha implants or CI in such patients. So this is one of our early patients when we were reluctant enough to use temporalis muscle rotation flaps. You can see how the post-auricular wound gaped and the fat was protruding out that. Then after that, we were routinely doing the rotation of the temporalis muscle and trying to close, because in the revision cases, what matters is that the poor vascularity of the post-oral area. So just mobilizing and suturing that area doesn't help. You need to have a vascular flap behind the incisional margin so that you don't end up having such complications. So thank you for your patient listening.
Thank you, sir. You dealt it very well.
It's basically a very big topic. I tried to concise it.
You confined it to the time.
Yeah.
Thank you, sir. Now we'll take the question and answer sessions in the lunch break. So we'll go to the next lecture. Let me take the pleasure to invite Dr. Srinivas Dorsala, sir. He is a consultant in Annaya Healthcare and honorary professor at Jawaharlal Nehru Medical College and adjunct faculty at Yenipova Medical College. He introduced microvascular free flap surgery in MS Ramaya Medical College and has a special interest in complex airway surgeries and contributed towards the establishment of cadaver-based advanced surgical skills lab at MS Ramaya Medical College. He runs a 3-month mentored learning course in Vertigo for ENT, neurology and audiology professionals. He has been awarded the inaugural Dr. P. Ghosh Award for Innovation in ENT by Delhi State AOI. Sir, with this brief introduction,
thank you, sir.
The stage is yours.
Yeah. Very good morning to all of you. It's great being here, and so far it's been very excellently organized from the time I entered the gate onwards. So congratulations on that effort. So let me start off with this thing: what to and what not to expect from investigations in vertigo. First thing to recognize is that vestibulometry is not equivalent to vestibulology. Getting some numbers, getting some charts does not make you a vestibulologist. The purpose of investigations is to get insights, not some numbers. So now, asking the right questions. Okay. So just let us take the example of ECG. When we do an ECG, we ask the ECG if there is a myocardial ischemia or an infarct. We ask the ECG if there is any abnormality in the rhythm or a rate. We don't ask the ECG if there is a mitral regurgitation. We don't ask the ECG whether there is an atrial septal defect. Maybe there are some gifted investigations can answer these questions. So when somebody comes to you with a hearing problem, what we do is, when we have a hearing problem, we think it is deficient care if you don't do even a simple pure tone audiometry before treating the person with a hearing problem. So that much we do, unless we are very clear that this is very recent onset and I know that is conductive, something like that. Otherwise, we do a pure tone audiometry minimum for a person who comes with this thing. Like that, there are some minimum investigations that we should do for a person who comes with a balance problem. And that minimum question, first move, at least one question, 2 questions, 3 questions we should try to answer for a person who comes with these things. What are those questions? Are the 5 vestibular end organs functionally intact is the question that we are supposed to ask first of the patient. So what are the 5 end organs in the inner ear other than the cochlea? The 5 end organs are the lateral canal is there, anterior, posterior, utricle and saccule. What are the investigations that answer this question? For caloric, we have calorics also. For lateral canal, we have the calorics also. In addition to the caloric, we have tests called functional head impulse test and a video head impulse test which can answer the question. Anterior canal, again functional head impulse test or VHIT. Posterior canal, same test. When it comes to utricle and saccule, a O-vamp and a C-vamp. So having a tool like a functional head impulse or a video head impulse test plus a VEMP, okay, vestibular evoked myogenic potential, can answer this one question whether the 5 end organs, the vestibular end organs, are functionally intact or not. That much question is answered. Okay, it is like doing a pure tone audiometry for the cochlea and the middle ear. Okay, that much is there. Now fine, I am going to ask this question, but what is this answer going to solve the problems? Which diagnosis rests on establishing the functional intactness of the 5 end organs? Vestibular neuritis. Why vestibular neuritis? If it is acute vestibular neuritis, it's a clear diagnosis. The moment you look at the nystagmus and then do a clinical head impulse test, you get the diagnosis. But the problem is especially important in finding out old lesions. Something 3 years ago, 5 years ago, patient had one vertigo attack. Now the patient is having some maladaptive symptoms. Patient is having some vague symptoms and you don't know what it is secondary to. To bring out that, these tests are going to be very beneficial. And there are certain patterns, like if there is a superior vestibular neuritis before, patient is going to show in that 5 end organs, anterior, lateral and utricular will not be functional. If the person has had an inferior vestibular neuritis, then the posterior canal and saccule will not be functional. Like this you come to know. When it comes to labyrinthitis, all the canals including utricle, saccule will not be functional. Of course your pure tone audiometry will show profound hearing loss. There is a condition called bilateral vestibular loss. This is very important cause of imbalance in the elderly where both the inner ears are not. Again there, you will see that functional intactness of these end organs are not there. And it also gives a key insight in sudden sensorineural hearing loss etiology. What is the etiology of the sensorineural hearing loss? Sudden. In sudden sensorineural hearing loss, we think either of a viral inflammatory etiology, one of them, of course, there is also autoimmune, and then the other thing is maybe it is because of a vascular event. Now, if in sudden sensorineural hearing loss, if you can demonstrate with these tests, the person has a posterior canal deficit and a saccule deficit, or just one of them if we have just one tool, then vascular etiology for the SNHL is a very, is almost certain. Now, how does this have an implication clinically? The clinical implication is we can go low on the steroids, we can avoid steroids, especially if the person is diabetic and all those things, and be more aggressive on the revascularization strategies that we do for sudden sensorineural hearing loss. Now, the second question, is there free-floating debris in the canal or debris attached to the cupula? This is the next question that you're going to ask. Now, how are you going to do this? You're going to establish this by positional tests. Now, what are the positional tests going to tell? It is going to evoke some kind of a nystagmus if there is a debris in the semicircular canals. Which are these? Posterior canal will produce a upbeating right torsional nystagmus. Posterior canal left is going to produce a upbeating left torsional nystagmus. Anterior canal downbeating and right torsional. Anterior canal left will be downbeating and torsional left. Anterior canal right will be torsional right. Right horizontal, right beating horizontal, and left horizontal, left beating horizontal. These are the signature nystagmus that comes with each of these canals. But when you look at this signature, you have to have one caution, that is nystagmus of every canal can show reversal. It means if there is only right side canal that is affected, you may get a right beating horizontal nystagmus, but in another position it can become left beating. Or if the right posterior canal is affected, you get upbeating right torsional nystagmus, but in another position it becomes downbeating left torsional nystagmus. So when you're supposed to interpret this particular chart, you have to take the stronger of those nystagmus and then interpret the chart. But if you have only one nystagmus, you don't have any confusion, you just use the chart and you know which canal is affected. Why do you need to identify the canal? Because the maneuver that we are going to do is going to be based on which canal is affected. Most important point here is the nystagmus tells which canal is affected, not the test. Just because you did a EPLI does not mean make it a posterior canal BPPV. Okay. Now, within this, is there any role for doing only clinical, or is there any advantage of using an equipment? Okay. What is the equipment? Recording based tools for BPPV. Most clinical cases can be diagnosed without any special recording tool. Most of them. Almost 80 to 90% of the time you don't need a tool. You just do a clinical positional test and you get the nystagmus and you'll. But video recording with removal of fixation, it can be video frenzel, it can be video nystagmography, or the latest tool that I have launched called as a cranioculography, which gives head position along with the eye movement, ensures that small debris BPPV is not missed. Why is it so important not to miss a small debris BPPV? These are only, the debris is very small, you get only 2-3 small beats once you get into the position. You should not miss this. Why is it? These are actually the patients who are going around from consultant to consultant with very vague symptoms. And all that they have is a small debris BPP. You do a repositioning maneuver and the patient is perfect. But if you have to pick that up, okay, for that, those small, it's a small group of patients, but then if you have to pick them up, then you will need a tool. Recording is also important in multi-canal or switching canals varieties of BPPV. Otherwise, 90% of the cases you can manage without any special technique. Then the third question that you're supposed to ask of, or you can ask of vestibular investigation is there any dehiscence in the otic capsule? Any dehiscence in the otic capsule. It can be posterior canal, superior canal. Most common is superior semicircular canal dehiscence syndrome. The way to unmask this dehiscence, there are two ways. One is a pure tone audiometry. In pure tone audiometry, you get subnormal bone conduction thresholds. You have to tell your audiologist, don't stop at 0. The moment a person answers for 0, don't stop there. Go beyond. Ask at -5, -10, -15. You have to ask the audiologist to answer, to check for this, because otherwise they will think, okay, 0 is normal. They will never test below this thing and you will miss this particular diagnosis. Subnormal bone conduction thresholds. Then OVEMP and CVEMP, excellent waveforms are seen even at very low stimulation thresholds. Very low, this thing, even 60 decibels, you may get very good waveforms. That means this person has a otic capsule dehiscence. It can be, what is otic capsule dehiscence? One of the commonest examples which has become very famous is the superior semicircular canal dehiscence syndrome, but there are other dehiscences also in the otic capsule. Then the fourth question that you can ask of investigations is there any vestibular asymmetry? What is vestibular? How do you unmask vestibular asymmetry? Previously, we used to do a lot of things, calorics, this to tell asymmetry chart and all those things. I will tell you very simple scheme. Nystagmus is the cue to vestibular asymmetry. Severe vestibular asymmetry, nystagmus is there even in the presence of fixation. Moderate vestibular asymmetry means no nystagmus in the presence of fixation. Nystagmus appears only on removal of fixation. Mild, no spontaneous nystagmus with or without fixation, but nystagmus appears on head shaking. That is mild. Only at that time it comes. Now, in this nystagmus, there is again right-left asymmetry, which means the asymmetry, the vestibular asymmetry is between the right and the left, between the right ear and the left ear. So horizontal torsional nystagmus with small upbeating component. This shows there is a unilateral vestibular deficit below the level. The other test, the first question would have answered if there is a complete loss, but this is going to answer if there is a small asymmetry between the right and left. And if there is a vertical asymmetry between upper canals and the lower canals, means anterior canals and posterior canals, this will show up as upbeating or downbeating nystagmus. And here the lesion is likely to be in the cerebellum, the midbrain or the medulla. Now, this question, what is that going to? Why establishing right-left asymmetry is important? The right-left asymmetry establishing is important because often the only abnormality demonstrable on investigations in Meniere's disease is just a right-left asymmetry. That's all. Okay. If after several years of recurrent vertigo, there is no demonstrable asymmetry, you are likely looking at vestibular migraine as an explanation for the patient's symptoms, then Meniere's disease as an explanation of the patient's symptoms. Then the fifth question, there is, of all the things in the center, we have the vestibular center. The vestibular center, most easy to diagnose, most easy to pick up in investigation, is the vestibulocerebellum. Vestibulocerebellum has a flocculus and a nodulus. So is the cerebellar flocculus functionally intact? Yes, you can answer that question. Impaired smooth pursuit and impaired vestibulocular reflex suppression test. Vestibulocular reflex suppression test can be done even with your mobile phone. Just hold the phone, go one round right, one round left, asking the person to keep looking at the camera. If the person is, the flocculus is intact, functionally intact, patient does not develop any nystagmus. If the flocculus is not intact, patient develops any nystagmus even while fixing at the camera of the phone. So it is like that. You can pick it up in 5 minutes. Okay, so this is how you are going to answer. Then is there a cerebellar nodule? Is the cerebellar nodulus intact? You can pick up some cases of nodulus abnormality by doing a simple chair rotation test and not a sophisticated big chair rotations, a clinic chair rotation, one round in 1 second. After that, a normal patient should not have a post-rotatory nystagmus. If you can demonstrate a post-rotatory nystagmus, if just after one round over 1 second, then the person definitely will have some dysfunction of the cerebellar nodulus. Then the next question is, are there any maladaptations to vestibular deficits? There are some people who have had some vestibular deficit or some vestibular event, including BPPV before. And it's, as a secondary consequence of that, they would have developed maladaptations. What is this maladaptation? There are visual dependence. What is visual dependence? The moment they see a fast moving bus in front of them, they feel imbalanced. If they see some train moving, they feel imbalanced. Even wind swept trees they see, they feel imbalanced. This kind of thing. They have developed a maladaptation. What is this maladaptation? Excessive dependence on vision for their orientation. Excessive dependence on vision for their orientation they must have. There are other people who develop something called surface dependence. What is surface dependence? They need proprioceptive impulse excessively or proprioceptive signal excessively to be able to walk or maintain their balance, because they have become too much dependent. The moment you keep each of these things in any of, you put either of these people in a carpet situation for the surface dependence or visually conflicting surroundings in visual dependence, the person has problems. Which investigation will unmask these things? Posturography will unmask these things. Next, what not to expect from vestibular investigations? All complaints related to balance need not arise from abnormalities in the vestibular system. This is a very, very important point. Simple example as an illustrative case. There are multiple, but as an illustrative example, orthostatic hypotension. It is the classic and very commonly misdiagnosis in imbalance. Vestibular test cannot be expected to make this diagnosis. You need to check the blood pressure. You need to check the blood pressure in the supine position, in the standing up position, and these things, and that is how you are going to get the diagnosis. Next, do not expect a correct diagnosis when clinician who is caring for the patient is not personally involved in the history and in the formulation of differential diagnosis. Just because you have done so-called complete vestibular evaluation in some lab, you have sent to some this thing, but if you are not involved in the formulation of the differential diagnosis, even if God is reporting the tests, you have to be involved in it. Okay, otherwise it is not going to be. With that, 50 seconds left. Thank you so much.
Sir, that's wonderful, sir.
Thank you, sir.
You are in time. You finished in time.
Thank you, sir.
Yeah, then we will have some questionnaires.
Yes, sir.
Any two questions? Sir.
Also expect vestibular endolymphatic hydrops as a cause of sudden sensorineural hearing loss?
Endolymphatic hydrops is a fluctuant hearing loss.
No, it can come out as a drop attack. And
it can come as a drop attack, yes. It's a very common cause of drop attacks.
That's what I'm saying.
Yes.
If you have a sensorineural hearing loss in a person, do you expect viral, vascular and endolymphatic hydrops or just viral vascular?
So you are talking about one condition, that is endolymphatic hydrops in a person who has developed sensorineural hearing loss before. Yeah. That is the delayed endolymphatic hydrops or delayed mean areas disease. Yeah, that is one thing. Yes, sir, fine. And
if we don't work on that, we might miss endolymphatic hydrops and not treat it.
Absolutely.
We are treating only the viral and the vascular.
Absolutely.
So I have seen many people only giving hyperbaric and intratympanic or steroids and
without treating the...
Not thinking of doing diamox and other things.
Yes, sir. Super point, sir. Thank you, sir.
Any more questions?
Oh, sir. Thank you, sir. Thank you.
You can't find any other encyclopedia of neurotology else than Srinivas. I think he deserves a big round of applause. He knows this subject to the depth of the mitochondria if we talk about human biology. He knows about neurotology. Thank you so much for delivering such a beautiful lecture.
Thank you, sir. Thank you, sir.
Each and every query solved in such a single lecture, I think.
Yes. Thank you, sir. Thank you, sir. Thank you, sir.
Thank you so much. Now it's time for our felicitation. May I request Professor Somnath Shah to felicitate Dr. Anirban Ghosh and Dr. S.K.E. Apparao. May I request Dr. Anirban Ghosh. Now may I request Dr. D.S. Arun Kumar to felicitate our speaker, Dr. Abhishek Srivastava and Dr. Srinivas Dorasala. Now it's the turn to felicitate our chairpersons. May I request, sorry, still the session. We are still in the photo session. Oh. Now we'll felicitate our chairpersons. May I request Dr. S.K. Apparao to felicitate our chairpersons, Professor Somnath Shaha and Dr. D.S. Arun Kumar. I'm sure we all have enjoyed the session. Before we conclude this session, I would like to extend our gratitude to our chairpersons, Professor Somnath Shaha and Dr. D.S. Arun Kumar, for expertly guiding the session. Thank you for your time and effort, sir. And I would also like to extend our gratitude to our speakers for the valuable insight. Now, let's move on to our inauguration session. It's amazing. It is beautiful to see such an overwhelmed crowd. There is a request for all of you that if you find interesting to not to miss all the sessions we have organized for you, you can please enjoy our Hyderabad weather and the scenes all around. This is our IT park of Hyderabad. So you can sit in the balcony and you can enjoy the vision and the work which are being organized for you. Before we... In 10 minutes, we are going to start our inauguration session. Before that, I would like to introduce the reason we have conducted this Elevate ENT Summit 2024. As it is believed that future is not something we enter into. The future is something we create. Hence, the theme of these 2-day seminar is Shaping Future Practices. Throughout these 2 days, we have an exciting lineup of national and international guest speakers, presentations, and networking opportunities planned for you all. In this summit, our aim is not only to provide valuable insights, but also to inspire and provoke thoughtful discussions and stimulating new ideas in ensuring excellence in patient care and endeavor to shape our future ENT practices. Shall we start?
I request the delegates, you can visit our stalls, which is being exhibited all kinds of machines and the requirements for our doctors. So you can please pay a visit to our stalls by the time we arrange all the formalities for the inauguration. I request all the delegates who are in the balcony to please come back to the hall as we are about to start our inauguration session. I know all are enjoying the beautiful monsoon view of Hyderabad, but still I would request them to please come inside the hall. As we are running short of time, I request the delegates to please come inside the hall for the inauguration. Thank you. To begin our event, we would like to invite our esteemed guests onto the dais. Dr. Anil Krishnan Ji, Senior Consultant Intervention Cardiologist, Chairman and Managing Director, Medicover Hospital, India. We are thankful for all his support, but unfortunately, sir is not attending the summit session today, but we are wholeheartedly thankful to sir. Next, we call upon Dr. A. Sharath Reddy, Director, CTO, and Complex Coronary Interventions Director, TAVR and Structural Heart Diseases, and Director of CATH Lab, Medicover Hospital. May I request sir to come onto the dais. Next, our guest, Mr. P. Hari Krishna, ED, Medicover, India. Unfortunately, even I think sir is coming late, so we will felicitate him later. Next, we request Dr. Satish Kumar Kailasam, Group Medical Director, Medicover Hospitals, India, and Director of Medicover Institute of Emergency Medicine, to please come onto the dais. Big round of applause, please. Next, I call upon Dr. Sampurna Ghosh, Organizing Committee Chairperson and Consultant ENT, Head and Neck Surgeon and Cochlear Surgeon at Medicover Hospital, High Tech City, Hyderabad. Ma'am, I know you're very busy looking at the organizing things, but please come on to the dais. Dr. Sampurna Ghosh, ma'am. Next, we call upon Professor D. Prepagaran Narayanan, Senior Professor and Consultant in the Department of Otorhinology, Head and Neck Surgery, Faculty of Medicine, University Malaya Medical Center, Kuala Lumpur. May I call upon now Dr. Deen Dayal, Medical Director of Deen Dayal ENT Care Center and Chennai Hospital. Dr. Deen Dayal, sir. Now we call upon Now may I call upon Dr. Dwarka Nath Reddy, an incoming president, IMA Telangana. He was the convener AAPI Global Healthcare Summit 2022, Hyderabad. He was the convener of 14th Asia Oceanic ORL and HNS. He was in the Congress Party 2019, Hyderabad, and was the Overseas Coordinator TTA, Telangana American Telugu Association, AAPI. He was also CWC member, IMA headquarters from 2018 to 2022. Dr. Dwarkanath is a patron of Tirumala Srinivas Tirupati Trust Tirupati, and he was an editor of iJones and Indian Journal of Otolaryngology and Head and Neck Surgery from 2006 till March 2012. Welcome, sir. So now we proceed to the inauguration of our event. We will now, shall I continue? We will now proceed with the lighting of the lamp, a tradition that signifies the removal of darkness and the onset of knowledge. I request our honored guests, along with the organizing team chairperson, Dr. Sapuna Ghosh, Dr. Ashok Pudiraju, and Secretary Dr. Sandeep Dachuri, to kindly proceed to the lamp for the lighting of the lamp ceremony. May I now request Dr. A. Sharath Reddy to address the gathering.
So respected dignitaries on stage and faculty, and dear attendees of this Elevate ENT Summit, which is co-supported by Medicover hospitals. I thank all of you for coming over to share your knowledge for our final objective of elevating our patient care, in our societies and in our country. We as a group, Medicover Hospitals, started in 2015 with one hospital in Hyderabad, and we expanded to 24 hospitals now across 4 states, spreading across Telangana, Andhra Pradesh, and Maharashtra and Karnataka. And we deeply realize
that the growth is a byproduct of advancement of science and elevation of scientific individuals inside our organization. That is our innate DNA of Medicover. In fact, that is what made us grown very fast in last 9 years from 1 hospital to 25 hospitals. And I thank entire ENT department of our hospitals, Dr. Sampurna Ghosh and Dr. Sandeep and Dr. Prithvi, for taking up this ethos of organization forward and conducting such a nice program with a great scientific content, and all stalwart faculty from national as well as from international community to spread our knowledge, across all the ENT community in our country. And we as organization always, underpin your efforts and this ENT community's efforts in spreading your knowledge forever. So we are always there behind you to support as an organization for any such kind of programs, because we strongly believe that is what makes us evolve and grow together. Thank you once again, and I wish all the success for this program. I wish this program becomes a landmark and we keep organizing every year from now onwards. Thank you once again. Yeah.
Thank you, sir. Now may I call upon Dr. Satish Kumar Kailasam to say a few words.
Good afternoon, everyone. It's a very great pleasure for us to meet here, such a big gathering today. When we started thought of this conference, actually, I think in January, we started our work, what the venue, how to go ahead, what type of the surgeries we have to show, where the audience likes, because the engaging audience, engaging the faculty, engaging the delegates is most important for any successful workshop and successful conference. I think the ENT team has put a lot of efforts, especially Sampurna Ghosh and Sandeep and Ashok, and medical and administrative team has put a lot of efforts for this big achievement of the conference. I would like to welcome you all. I'm thrilled to welcome you all for this great conference today, the first type of conference, international conference, Elevate ENT. When I propose this word Elevate ENT, then the thoughts and the impression has gone up at high sky. Then that we have to do it. We have to do it. We have to make sure that everyone at the end of 2 days, they should feel that they have learned a lot and they'll start practicing the same. And coming to Medicover Hospital, we always strongly believe that we want to invest in medical excellence, medical academics and research, so that the community will get benefited. The best possible care, advanced possible care will be given to the patients at any point of time, everywhere in India. So that is our logo, that is our motto, that not just practicing at hospitals, we want to educate, train, networking and sharing the knowledge. That is our motto. That is the reason we all gathered here. I'm thankful to all the faculty, dignitaries, and a lot of the faculty came from the out of India also. I think they did wonderful workshops today morning for the cadaver workshops. I would like to thank everyone, especially the government hospitals and IMA, and who are supported today, Osmania Medical College and Hospital. Tomorrow our team is going to show the live surgeries to you also. And the sponsors especially, they supported very much so that we all gathered here. Hopefully we see more such conferences every year in every department. We would like to do it, and our motto will remain the same: educate, train, network, share knowledge, and to give the best possible care for all the patients in India. Thank you very much.
Thank you, sir. Now may I call upon Dr. Prepagaran to say a few words to our audience.
Namaste. Thank you so much for having me.
As you know, my great-grandparents are from India. And I always imagine how they must have left India because of poverty. They were rubber tappers in Malaysia. And how they must have felt when they were leaving their home country to go to a foreign country just to get out of poverty. I don't think they ever dreamt that their grandson will be standing in India giving lectures one day. And every time I come, I see how progressive. I feel like I'm in Europe. I can't believe I'm in India. This place reminds me of Europe. I see young people who are so driven to excellence. I think another 10 years from now, India will rule ENT in the world. Thank you very much for having me.
Thank you, sir. Now may I call upon Dr. Deen Dayal, sir, to say a few words to our audience.
Good afternoon. Good afternoon, and dignitaries on the dais, and friends, and all the delegates who have come in. Actually, I would say that Sampoorna and her organizing team have done a marvelous job. They've done, and they definitely need a big applause for that. I mean, you have almost nearing around 400 delegates and very well organized, and the morning sessions have gone off excellently well. I must say they've done a great job, and I wish the Department of ENT all the best. With all the support from the Medicover, I think it is going to do wonderfully well. All the best, and let's enjoy the show.
Thank you, sir. Now may I call upon Dr. Dwarka Nath Reddy to address the audience.
Namaste, everybody. I think it denotes elevate. I think the people have really elevated the workshop of this nature. So my congratulations and thanks goes to Sampoorna and team, Sandeep and everybody, and more so again the people who are behind the Medicover, that they are covering so many people now, the Medicover. See, fortunately, several things are happening in Hyderabad as far as the medical is concerned. Name it medical tourism and whatnot. And along with this, regularly they are happening, these sort of workshops are happening in several faculties. And in fact today, immediately this is over, I am going for another workshop that is going to happen on cardiology. So this sort of situation is happening in Hyderabad. I think this is most happening place. And once again, I congratulate Sampoorna and team for all the excellent work they have done for this workshop. And more so all the delegates. This is another wonderful thing. For a delegate, for a workshop of this nature, 400 and odd people coming over and then participating is a big, really a big show. So once again, I thank each and everyone who are involved in this great workshop, and all the best for the endeavor that is being done for so far. Thank you very much.
Thank you, sir. Now, may I call upon Dr. Mehish Deglukar, CBO Medical Hospital, to address the audience.
A very good afternoon. Very great event. Congratulations to Dr. Sampoorna, Dr. Sandeep, Dr. Prithvi, and all the team at Medicover, organizing committees, and a special thanks to all the delegates. Let us give a very big round of applause to the delegates who are here, more than 300, more than 400. Without all of you, this program is not successful. Respected dignitaries on the dais, as Dr. Sharath, our Executive Director, mentioned, our journey 9 years started from one hospital to 24 hospitals across 4 states. And definitely we are committed for such kind of academic programs. This is our third academic program in T-Hub. and we have booked another 3 in next 4 months. Thanks to the committee, thanks to all my team and all the medical heads under the guidance of Dr. Satish Kailasam. We are definitely committed for such kind of great programs, national, international conferences. Once again, thanks to Dr. Sampurna, Dr. Sandeep, Dr. Prithvi, and all the delegates for making this program one of the best in the country. Thank you.
Now, may I call upon our most vibrant, energetic, organizing team chairperson, Dr. Sampurna Ghosh.
I just want to thank all of you. I know how the delegates have come from all the corners of our country, from Jammu to Kerala to Bengal to Tripura, Rajasthan, Tamil Nadu. I may be missing few names. It is a wonderful feeling for me. I'm so grateful that you thought these 2 days will be worth coming here. Everybody I know is busy practitioner, so time is the money here. All of you came, that makes all the effort worth. A special thanks to my foreign faculties, Dr. Prepa, Monica ma'am, Jaisurya ma'am, and Manilal sir could not come, that you could travel so long to make this event successful, all my national faculties. It is only probably because of blessings of my gurus, Dr. Somnath Saha, Dr. J.M. Hans, who came, and that is the reason probably I could even dream and execute this kind of program. So no words enough for their blessings on me. Dr. Dindal sir, Dr. Dwarkanath sir has been guiding me since the beginning when I started planning, and I knew nothing about how to organize this kind of event. Ranveer sir, Shekhar sir, and the whole association, Hyderabad ENT Association, has been always very inclusive and encouraging to the young people to whatever they want to do. The Telangana Association, they have helped me in all the way. Dr. Anand Acharya sir helped me to connect to the Osmania Medical College. Dr. Satya Kiran Sripati, who are there from the beginning in the morning, took a lot of stress out of me. I want to thank all of you, and special love for my girls team, Elena, Aishwarya and Neha. Without you, this was absolutely impossible. The whole Medicover team. I want to thank Satish sir and Durgesh sir. Day and night I made calls after calls. Sir, this work has to be done. This work has to be done. They have never felt irritated. I want to thank Sharat sir. When I joined this institute, Medicover, he told me one thing: can you make ENT as a department of excellence? I said, yes, if you provide me the equipments. And they made their promise. They not only provided equipment, they have always encouraged me to do the academic programs I want to do. And this support, huge support from Medicover only made this possible. Last but not the least, the sponsors who had trust on me. I would say as a beginner, as an organizer, I'm just beginning. So in spite of having no experience, they never questioned my ability. Without knowing what the delegates number will be, what the arrangement will be, they're close to me and they said, yes, we are with you. And that is how it was possible. Thank you all for coming. If there is any inconvenience, please forgive me and enjoy the show. Thank you.
Thank you all the dignitaries on the dais, and off the dais also, who patiently were waiting till now. It's almost coming to our lunch hour, so we'll end our inauguration session here now. Thank you all of you for joining us this morning. We will now
1:40 the session will start. Next session.
We will now be taking a break for lunch, and we will resume our program at 1:40. So, not much of time, but still time for lunch and networking. Enjoy your lunch, and we look forward to see you back here shortly. Lunch is served in the balcony. I'm sure everybody knows about it. This is our balcony here. Oh, my
I need a
Please stay cool and enjoy the session. Okay. Now we'll start with the first speaker.
Yeah, so good afternoon all. The first speaker is Dr. Nitika Gupta. Madam is presently working as consultant at Dr. Gupta's ENT clinic, Jammu. She is an assistant professor in Government Medical College, Jammu. I know her. She has special interest in allergy and immunology. She has done her fellowship in allergy and clinical immunology. So over to you, ma'am.
Just a minute, madam. Hello. The time given is 15 minutes. Please try to finish it. Okay. 20 minutes is the session. 15 minutes is the 5 minutes. Hello. 20 minutes is time. 15 minutes is session. And 5 minutes for the question answers. Okay. Please.
Good afternoon, everybody. So after the lunch session, I hope my talk doesn't make you sleep. So we'll be talking about phenotypic management in CRS. We all know that CRS is a medically managed disease where surgery plays a very important role. But sinus surgery alone is not sufficient to manage all cases. There are patients who require good post-operative care to prevent recurrences, which is very common seen in patients who are not managed well post-operatively. Now, there are multitude of known and unknown factors from host environment which come together to constitute various endotypes we see in our clinical practice. Once the mucosal barrier is breached, there occurs an intrinsic response at the cellular and the cytokine level, which further leads to development of various inflammatory cascades and finally leads to development of CRS. Now, if the surgery applied is not in harmony with the pathophysiology going on in the body, it becomes a problem. We are bound to fail. But if we acknowledge that sinus disease is a group of conditions wherein the type of inflammation and the resultant mucostasis is part of the pathophysiological mechanism and sinus surgery is done to break that process, we will succeed. I want to talk about moving away from the typical concept of dividing the rhinosinusitis with or without nasal polyposis. We all know that polyps form because of inflammation, fibrin deposition, and cross-linking. The formation of the polyp is basically the end point of all the inflammatory cascades going on. I'm going to start by talking how it starts in the nasal cavity. The EPOS group has defined this very well in the EPOS 2020 paper. The first step is basically to identify in a case of CRS whether it is a primary disease or a secondary disease. Now, primary disease means it is not secondary to any other disease. So as you see on this slide, there are three divisions. Anatomic distribution, we have to identify the endotype and the phenotype. So in the anatomical locations, we have the localized disease, whether the condition has been localized, is there in a particular anatomic section, or it's a diffuse disease where it can be patchy or there can be a gross diffuse involvement, bilateral involvement. Now further, next step is to identify the endotypes. Now EPOS 2020 defines basically two endotypes. We have the Th2 inflammatory cascade, which is also called the type 2 inflammation, or we have the non-Th2 cascade. Now the eosinophilic inflammation, which is basically the type 2 inflammation, is IgE mediated inhalant allergy or it can also be associated with non-inhalant allergy. So type 2 inflammation is generally steroid responsive, and so they are the common drugs which are used. These are also the group which responds very well to the biological agents, which I'll be talking about in the subsequent slides. Next, we have the phenotypes. Now, amongst the localized group with the type 2 inflammation, we have allergic fungal rhinosinusitis. Now, this is that there is non-clearance of fungal containing mucin in a patient who is sensitized to fungal antigen. But there is involvement of a single anatomical functional unit, like this. So next, we have in the localized category, which is the non-TH2 type. So in this is classical sinusitis. Someone can have blockage of osteometal complex. Someone can have isolated sphenoid or frontal involvement. These are patients who will actually have subepithelial fibrosis, basement membrane mucosal hypertrophy, and this consequently leads to non-clearance of the disease by the medical therapy, and we have to do surgery in these patients. Next, we have the diffuse involvement. Now, in diffuse involvement, we have type 2 inflammation. In type 2 inflammation, we have 3 clinical pictures which we see in our practice. The commonest is the central compartment atopic disease. Now, central compartment atopic disease is basically a term which is also called as the exuberant allergic rhinitis. These are patients who have respiratory allergies, who had allergic rhinitis, but the inflammatory cascade has now started leading to polypoidal changes or development of polyps along the middle turbinate, the superior part of the septum, or the superior turbinate. The middle part of the sinus cavity is getting involved. This is typical central compartment atopic disease. And you have to identify the patient at this particular point. So endoscopy helps you to identify the patient with this central compartment. If you identify the patient in this scenario and you identify the allergen sensitization patterns in the patient with CCAD, you can actually revert these patients with just medical management. You can avoid surgery in a lot of these patients. At times, these patients do require surgery because of the pressure changes, but in post-op, you need to start them on allergen immunotherapy. Because with precision medicine, with P4 medicine, this is the answer, that you have to give the best possible treatment to a patient. Next, we have the eosinophilic nasal polyposis. Now, it is usually associated with adult onset asthma. These are patients who didn't initially had sinus disease, but they had respiratory issues throughout their life. These are patients who are generally in the 30 to 50 years of age group. Please understand, it is not IgE mediated. This is a group which has eosinophilic inflammation. So on histopathological slides, you will see tissue eosinophilia, but these patients will not have inhalant allergies. But they are very well responding to steroids and to biological agents. So this is the slide which shows that how the biological agents act on the key players in the inflammatory cascade. And the biologicals which are clinically approved are omalizumab and dupilumab. I have been personally using omalizumab in my patients. I also use omalizumab biosimilar with very, very good results. So there are certain indications where you can use these biologicals. The EPOS 2020 paper mentions about the criteria which need to be fulfilled for you to start the biological agents. Now the patient should either have undergone endoscopic sinus surgery, maybe a recurrent case, or you have taken up the patient for endoscopic sinus surgery and you want to improve the post-op results. The patient should have proven type 2 inflammation. The SNOT score should be on the higher side, around 22 to 40. The patient should have concomitant asthma. The patient would be requiring a lot of systemic corticosteroid use, or the patient has a sense of anosmia there. So among these, if you fulfill 3 criteria, you can start biological agents to the patient. What we do in our clinical practices, we start omalizumab once a month, 300 milligram, and generally after 4 or 5 injections, we reevaluate the patient. If the patient is responding very well to the biological agents, we can continue. Since I'm already also practicing allergen immunotherapy, I tend to limit my usage to 4 or 5 injections only, because most of these patients will respond very well to allergen immunotherapy consequently, and you will not require to further give biological agents. Coming on to the third category of type 2 diffuse inflammation, we have allergic fungal rhinosinusitis. Now these are patients in which you see diffuse involvement. The scans, you will see remodeled sinuses. You can see typical fungal stipplings. You need to operate these patients to restore the nasociliary function, to get the sinus function back. So you see on one end of the spectrum in the interaction of fungus and the human body. If the patient is immune hypersensitive, the patient will develop allergic fungal rhinosinusitis. But on the other spectrum end, if you see that the patient is immunosuppressed, you will develop invasive fungal rhinosinusitis. Next, we have the non-Th2 diffuse group. Now, these are the patients who will not respond to corticosteroids. You have patients who are generally older, often smokers. You will start them on medical management. You generally start them on nasal steroids, and they are not at all responding. The polyps are still the same size. The same blockage is there. So once you do the functional endoscopic sinus surgery in these patients, you evaluate the tissue histopathology, you will find that these patients do not have eosinophilic predominance. These patients have neutrophilic predominance. Now, these are the group where you need to put them on long-term macrolides to improve your post-op results. The long-term macrolide use acts as an anti-inflammatory and immunomodulatory drug. So the common product which I use is clarithromycin. Worldwide literature supports the duration of use for 12 weeks, and 250 mg per day is the dosage which I use. And you see significant results in patients. The clinical symptoms improve, the endoscopic scores improve, the CT scores improve, and usually there are no adverse effects. So what are the possible disadvantages? The macrolide groups have been seen to interact with statins, so you need to reduce the dosage or stop them. And there are very rare cases reported with QT prolongation where the patient can land up with arrhythmias. So are they safe to use? Absolutely yes. But you have to take a good cardiac history and a drug history in a patient and consider doing an ECG so that you can actually evaluate the patient beforehand for arrhythmias. So macrolide medications will respond very well in patients who have low serum eosinophilia, low tissue eosinophilia, and normal serum Ig levels. So this is the medical therapy which we use in our patients. Corticosteroids are the baseline drugs which we generally start in most of our patients. What we in our clinical practice recommend to use post-operative is to use intranasal corticosteroid irrigation. So we used to call that douching, but the term used these days is irrigation. We add Budecort. The respules which are available are 0.5 milligram respules. If you add 5 to 10 drops in the solution prepared of 200 ml, you can actually use the solution as an irrigation, and post-op, it gives excellent results. You can actually reduce the recurrence rates quite high. So amongst the systemic steroids, we generally use it very rarely, and the maximum usage is for 7 to 8 days. Now, saline irrigation, as I said, is these days called saline irrigation. We used to call it douching earlier. We generally, the world literature supports that isotonic saline preparations are much better, but in my practice, which we use, we are generally using the product which is commercially available. So 7.8 gram sachet of the commercially available product basically has 4 grams of sodium chloride and small amounts of sodium bicarb and xylitol, which actually enhance the efficacy of the product, the saline solution prepared. Now, once again, we have the secondary CRS. Now, secondary, again, we divide them into localized and the diffuse group. The localized diffuse will have some pathology going on. We have either the odontogenic infection leading to maxillary sinusitis. We can have a fungal ball. The fungal ball is where the fungal debris collects in the sinus. There is foreign body reaction to the fungal material. There is no eosinophilic mucin in this patient, and you have to operate these patients to remove the fungal ball and get the sinus function back. Now, there are also certain scenarios in the local pathology where basically the patient has inverted papilloma or some tumor, and there is associated sinusitis with it. Now, in the next type, which is the diffuse involvement or the secondary type, there is something going on in the body which will lead to uncontrolled inflammation in the nasal cavity, and therefore the patient has either we have the mechanical group, which is in which there is a mucociliary dysfunction, or we have an inflammatory group in which there are certain patients with autoimmune disorders. We have immune deficient patients, which will also land up with recurrent sinusitis. Now, in the mechanical group, the two common are the PCDs and the cystic fibrosis. I have seen few patients with cystic fibrosis. Now, these are the patients who will not respond to your medical therapy. You have to operate these patients, and these patients have known Pseudomonas colonization in their nasal cavity. So you have to take a swab from the middle meatus, prove the Pseudomonas colonization, and start antibiotics appropriately. Amongst the inflammatory group, we have GP and GPA. These are patients who basically have vasculitis and have autoimmune conditions. ANCA is usually positive in such patients. In the immune deficiency group, we have these conditions. Generally, what I have seen in my clinical practice are the patients who have uncontrolled diabetes. So this is the algorithm which the EPOS has proposed. The EPOS group promotes that after the appropriate maximal medical therapy only, you will advise the patient to functional endoscopic sinus surgery. Now, how much to operate, that depends on actually the etiology behind it. And there are various literature available for this. Just a word of very important pointer towards this, that for a patient with pediatric CRS, now you have to evaluate whether this child has adenoid enlargement or not before you plan up the patient for going up for a functional endoscopic sinus surgery. If you see that after medical therapy the patient is not responding and the patient has adenoid hypertrophy, first plan the surgery should be adenoidectomy. So after adenoidectomy, again put the patient on medical management for 6 to 12 weeks and reevaluate your patient. If the patient is still not improving, then you think on the lines of going about for functional endoscopic sinus surgery, or in some cases you may even think about going out for evaluating their immunodeficiencies, because most of these patients who have immunodeficiencies, they generally present in the pediatric age group and they have associated other recurrent infections of the lower airway also. So this is the precision medicine, that in the spectrum of non-TH2 cascade, we are doing the mucosal sparing functional endoscopic sinus surgery and giving macrolides. And in the type 2 group, we have to give post-operative corticosteroid nasal irrigation. We have to put them on allergen immunotherapies, and if possible, we can start biological agents to this. So the post-operative stepwise approach to the medical management is very important. We were here initially in the symptom-based medicine. We were treating a group of patients according to their symptoms. Now we have evidence for everything. So we have progressed to evidence-based medicine. But now, in the era of precision medicine, the P4 medicine, we are giving precise treatment to every single individual of what the patient inflammatory cascade is there. You have to identify each and every phenotype we have in clinical practice and give your treatment accordingly. Thank you, sir.
Thank you, ma'am. Any question? For everyone's sake, just tell us those basic investigations which you do to make your patients cut off into patients who will get into macrolides, patient in steroids. So there are 2-3 investigations. You're working in a government setup, poor patients come to you. So how do you categorize them as to, to give them the adequate medication?
If you're specifically asking for post-operative patients, you always will go for tissue histopathological examination. If the patient has tissue eosinophilia, this is an eosinophilic predominant disease. And if you correlate them back with the histories and they have histories of allergic rhinitis beforehand, then these are the patients who will respond very well to post-operative corticosteroid douchings. And you have to think on the lines of evaluating their allergies, because they may be associated with inhalant allergies. And these are the patients, these are the subgroup of patients, they will respond very, very well to allergen immunotherapy. I am hardly ever seen any patient having recurrence who were put on allergen immunotherapy. So you see your results 1 year, 2 years, 3 years. I now have results 5 years post-operative cases. None of them have recurred. See, I'll tell you, the serum Ig levels usually are elevated in allergic patients, but that is not the benchmark investigation. The investigation of choice should be either a skin prick test or a serum specific Ig. I am also doing component resolve diagnosis. That is actually testing the particular component of a patient, but that is a step ahead in allergy practice. For a general practitioner, you should actually evaluate, take a decision depending on the clinical picture of the patient, the symptoms, the diagnostic endoscopic picture, and the tissue biopsy.
Nitika, they have come up with the third EPOS, and there is a generalized consensus now creating or developing that these allergic polyposis is more of a medical disease rather than a surgical disease.
I wanted to say that, but
what in your books, what is the cutoff you keep? These particular cases are certainly surgical cases.
Sir,
to keep a surgeon alive
Yes.
inside us.
So if I have a central compartment disease, I will first start medical therapy to these patients. And most of these patients, trust me, 40 to 50% patients completely revert back. And if the patient has a fulminant disease, like all the sinuses are involved, there is not limitation of the disease to the central compartment, to the medial compartment. These are the patients I always operate first and then do post-operative management.
Sorry for the interruption. Medical management, how many days or weeks you want to
So
go?
medical management, it is generally 6 to 12 weeks minimum. 6 weeks in case you find that the patient is not at all responding to any of your treatments. There is no improvement in the SNOT score. You can take up a patient even after 6 weeks. But if you ask ideally the medical management should at least be there for 12 weeks.
Ma'am, what about endotyping? How do you do
So
endotyping?
endotyping, we just have two endotypes. We have type 2 inflammation and non-type 2 inflammation. Type 2, there will be inhalant allergy or tissue eosinophilia, and non-type 2, the ones which are leftovers.
So you don't do interleukin levels? We are not.
No.
You don't practice.
I do practice as my allergy segment, but not in a general, not in all patients.
All patients. And ma'am, what if the cytology which you are talking about, if it is eosinophilic predominance, then we follow that method. What if it is neutrophilic in nature?
If it is neutrophilic, we have to give macrolides. They respond very well to macrolides. Clarithromycin is the drug of choice I've been using.
Ma'am, how long you are going to give generally clarithromycin?
Clarithromycin for 3 months.
3 months.
250 mg, one tablet for 3 months.
3 months. And how frequently you have to monitor for, this ECG changes or cardiac
I have just done,
these things?
before starting clarithromycin to a patient, ECG is done.
Yes.
Usually these are patients who are post-operative patients, so ECG is already been evaluated. So
And again, do we need to
yeah,
check?
it has to be done because there are
Repeat.
certain literature who have reported arrhythmias with macrolides. So yes, it should be done. And do ask them about the use of statins. It is these days, we used to actually think that statins are only given above 50 years or 60 years of age. I have seen now patients in their 30s, in their late 20s, even on statins. So please inquire about statins because they definitely interact with statins.
What is the line of management in a pediatric child with adenoids?
So pediatric childhood, I always start these patients on nasal irrigation with saline, follow that with intranasal corticosteroids for 6 weeks. I ask them to come back to my clinic. If they are better, I continue the medical therapy for 12 weeks. And in this duration, since I am doing endoscopy of all my patients, so we do see that whether the adenoids are enlarged or not. So on endoscopic evaluation, you just evaluate after 12 weeks of medical therapy, has the adenoid shrunken to a sufficient size. So if they reduce to type 2, the category 2, you need not operate. But if they are not reducing, you have enlargement of grade 4, you should operate these patients.
Ma'am?
Yeah, hello.
I had a question about your experience with allergen immunotherapy, ma'am. You said some patients, you talked about it in context of post-operative care, but once in your talk you mentioned that these set of patients, if treated early on, they respond very well. So how do you choose what patients and what do you do and what's your protocol?
So as I said, for every patient in my clinical practice, I do a nasal endoscopy. There are 2 specific pointers to evaluate the patients with allergic rhinitis. If you see a patient having pale white middle turbinate and the rest of the nasal cavity is absolutely normal, these are patients who have allergies. In CCAD, the commonest first presentation which you will see would be that there are polypoidal changes on the anterior surface of the middle turbinate. These are the cases, and the ones which develop polypoidal changes along the midline, the septum, along the superior turbinate area. So these are the patients who will respond very well to allergen immunotherapies.
Sorry to interrupt, ma'am. The time is up for the next session.
Excellent presentation. Very congrats to you.
Yeah. Hello, Dr. Nitika. Very nice presentation. I just have a question to you. Are you doing forced expiratory nitric oxide, especially in view of the unified airway concept that these days we are having, and especially the eosinophilic group
So
of...
yes ma'am, I got your question. Yeah. So in my allergy clinic, all patients are evaluated for their lung function test. All patients who have nasal allergies are evaluated. And I have seen patients denying their asthmas because asthma is like a taboo in India. But
Exactly.
I have seen around 30 to 40% patients, they actually have asthmas. And only 5 to 10% know that they have asthmas.
Exactly. Thank you.
Thank you, madam. It's my privilege to introduce the next speaker, Dr. Vinod Felix, on ICA and skull-based surgery. Sir is honorary consultant in endoscopic skull-based surgery at SCTIMST and Regional Cancer Center Trivandrum. Visiting consultant at Federal Center Neurosurgery, Russia. Co-authored 2 chapters in the textbook of skull-based surgery by Luis Borba. Co-editor of the book on 100 complications in ENT. Over to you, sir.
Respected chairpersons, other senior colleagues, dear friends, very good afternoon to all of you. First of all, excellent hospitality, great conference. Congrats, Sabun and team. So I think you all know the skull base has 3 parts, the anterior, middle and posterior skull base. But now we have a term called the central skull base, which basically lines between these 2 lines. I think you can see the lines over there in the back. One line here, other line here. So this is called the central skull base, and that's the endoscopic view of the same central skull base. So this is the region which we approach endovenously for endoscopic skull base surgery. And we have different modules like the sagittal plane and the coronal plane, which basically is divided by the carotid artery. You have the internal carotid artery there on both sides. So the plane between the carotid artery is called the sagittal plane, and what lies laterally is called the coronal plane. Midpoint, yeah, thank you. So basically the one structure which runs through the entire central skull base and which divides the central skull base into 2 planes is the carotid artery. So the good way to understand skull-based surgery is looking at the carotid artery. And as you see from this particular figure, I don't know if you can figure it out, maybe you'll understand this one better. So this is the sphenoid sinus, interior sphenoid sinus. And you have the cellular floor there, and on either side you have the carotid artery. And once you open the sphenoid completely, see, if you just open the sphenoid ostium, you will see only this part. Once you remove the keel of the sphenoid, you will see the clival recess. So this is the view which you get by removing the entire anterior wall of sphenoid sinus. And once you drill this nasopharynx, once you open the nasopharynx, remove the pterygoids, everything, I will get that view. And this exactly shows the IC anatomy. Okay. So this shows the carotid anatomy. You can see the carotid starts from here, it goes all the way up here. So basically you must understand that the cellular floor and this entire clivus, it doesn't lie like that. The cellular floor is not like that. It lies like this. So that means that this is anterior and this is posterior. And this is further posterior. This is more posterior. So carotid runs from posterior to anterior and from lateral to medial. And there are different segments. There are different segments of carotid artery. You have the cochlea lying behind this turn. This is the parapharyngeal carotid artery. It's the parapharyngeal carotid artery. Otherwise, we can call it the cervical carotid. And you have the cochlea lying behind this. So some people call this the cochlear genu. And this part is the cochlear segment of carotid artery. And we have the petrous bone lying behind this carotid. So this is called the horizontal petrous carotid, right? And the petrous bone actually lies in that region. So this is horizontal petrous, and there is a small segment here called the vertical petrous also. This vertical petrous is always called paraclival carotid artery. But actually this is a misnomer, because once you look at the skull, you'll see that the clivus lies from here to there. So if you have the transcranial, we will call this as the paraclival, not this one. But commonly, since people do the endoscopic skull-based surgery, we call this as the paraclival. So paraclival can be better called as laceral segment, because you have the foramen lacerum there. So this is the laceral segment or the vertical petrous or the paraclival. This is the horizontal petrous. And then from here you have the sixth nerve. I think you saw it in the morning when Prabha clearly demonstrated the sixth nerve. Sixth nerve runs like that. So you have the lingual process there, and the petrolingual ligament lies like that. And above that you have another ligament called the petrosphenoid ligament. Between that, the sixth nerve runs to the Dorolus canal. So from here to here is a paraclavial carotid artery, and from here starts the cavernous segment. From here to here is the cavernous segment. And there is a small vertical segment here which we call the short vertical cavernous segment. Okay. I think we will skip all that for the amount of time. Okay, this is important. So that's the sphenoid sinus interior, and you have the cellular floor there. To understand the carotid artery, you must know the structures called the LOCR and MOCR. So I showed you the paraclavial segment, the horizontal petrous, and the cavernous segment from the sixth nerve Dorolus canal to this turn here, because you have the proximal dural rings there. So from here to here is the cavernous segment, and from here to the distal ring is the clinoidal segment. So what you're seeing here is the clinoidal carotid artery. So you have the proximal ring here and the distal ring there. And that's the optic nerve. So this depression here is called the LOCR, or lateral optic carotid, and that is formed by the optic stud. And there you have the tuberculum. Okay, I think I jumped. Okay, so you have the tuberculum running like that. So that's the optic nerve. If you draw a line along inferior aspect of optic nerve, you have the tuberculum. What lies on the superior aspect of optic nerve is called limbus. So at the junction of the tuberculum and the carotid here, there is a bone called the lateral tubercular stud, otherwise called the MOCR. That is important because the tumors here, the sella, the pituitary adenomas, they grow from here up. And they typically follow the snowman pattern, like that. And this compression here, this compression is formed by the MOCR, or lateral tubercular stud. So unless you remove this bone, the tumor won't descend down. So this is why you must understand each and every segment of carotid artery so that you can do the surgery in a better manner. So that's an example of a pituitary macroadenoma. You can see that. That's a carotid artery, right clinoidal carotid, left clinoidal carotid, that's the cellular floor. That's the clival rhesus. Now I am drilling on the right MOCR. This is the carotid artery, the right side. That's the right MOCR being removed. Now that's the left side. You can see the very good middle clinoid process, the middle clinoid process there, which lies just below the MOCR. And once I get this sort of exposure, you can easily remove the pituitary tumor. And I think this anatomy may be a bit high-fi for you because there are things like the dural folds, periosteal layer, the meningeal layer, which covers the two layers of dura over the pituitary gland. So the periosteal layer would run like that over the carotid from the anterior wall. The meningeal layer would go like that from the middle wall of cavernous sinus. And from here you have all these different pituitary ligaments. That is important because sometimes you'll have a tumor which is centered like that. That's a meningioma. And here, unless you understand that dural folds, you cannot do a good work. So that basically I'm actually removing the tumor from here. So you have something called a dorsal clinoidal space. I think that I can leave for this crowd because it's a bit high-fi anatomy. So that's the carotid artery there, and that's optic nerve. We are cutting the meningium, we are releasing the meningium from the optic nerve. So basically meningium, you just keep on rolling it from both sides. Now we are distinct this side, the right side, and that's optic chiasm there. So it's a combination of sharp and blunt dissections. You can see the anterior cerebral vessels there, the A1 and the ACOM, A2, everything there. That's a tumor being delivered. That's A1, ACOM, A2. And the pituitary tumor sometimes goes to the laterally to the cavernous sinus, and there are different segments of cavernous sinus, like you call this a superior segment, this is the posterior, there's the inferior, and there's a lateral compartment, so different compartments. And most commonly you have the tumor going to the superior compartment like that. This is the right side, the tumor has been removed from there, that's a carotid artery. Now we're going to work onto the superior compartment like that. So this is pretty common, and the superior compartment is very safe to work. You don't get any cranial pulse if you work on superior compartment. It's a very safe compartment to work on. And that's the inferior hypophyseal artery there. And this basically is a tumor which we chase all the way up to that's the anterior subluxal, that's at the lateral ventricle there. And you can see the EVD catheter in the lateral ventricle there. You can see the catheter there, that's the catheter. And see a small tumor, like a particular craniopharyngioma. So here, unless you transpose this entire pituitary gland to one side, by dissecting the pituitary gland from the carotid artery, you cannot remove this tumor. So now we are deliberately opening the cavernous sinus here. We are going to open the cavernous sinus here. And we inject the flowseal inside. So now the cavernous sinus is coagulated, and now we are dissecting the pituitary ligaments away. And you are seeing that's an internal carotid artery there, that's the ICA, the cavernous ICA. So once I do that, I can push the entire pituitary gland to one side, that's called a hemitransposition, and I can remove the craniopharyngioma from there. And this now we routinely do for all the functional adenomas, the medial cavernous wall resection. In spite of the tumor involving it laterally or not, we just, in GH secreting macroadenomas, we remove the medial wall of cavernous sinus. Okay. There is again the dura over the carotid artery being opened up, and we remove it like a sleeve. And coming down here, you have all this, between the paraclavial carotid arteries, you have the clival tumors, and laterally here you have the Meckel's cave. You saw that very clearly today morning, the cadaver dissection. So we can have the tumors lying in the Meckel's cave, like a Meckel's cave schwannoma, and that's after removal. So basically you need to work lateral to the paraclavial carotid artery. That is after removal. You can see the V2 fibers, right? The V1 and V2 fibers there. And coming to the foramen lacerum, so here we have a petroclival lesion. There's a petroclival lesion, and we used to do this approach previously. So the right side, there's a median nerve, we drilled around the median nerve. This is the paraclavial carotid artery. We drilled a lingular process there lateral to that, and the entire laceral segment can be moved laterally. So now we are now drilling behind the carotid artery. This is the carotid artery being pushed away, and this bone is called the petrosal prostospinoid bone that's being drilled, and now we are in the petrous apex. So now we don't do this approach much. The tumor is very extensive. We go for something called the contralateral transmaxillary approach, where we come from one side, sublabially, through the maxilla, and go to the petrous apex like that. So that's the anatomy of the contralateral transmaxillary approach. So this is a petroclival meningioma again. So just to give a glimpse of what this approach is like, this is a cadaver dissection. So generally we do the sublabial approach in the slide surgery. This is actually, you open the maxilla, and that's the cellular floor, cavernous carotid, the paraclavial carotid, the sixth nerve. So we drill the bone behind the carotid, that's called the petrosal prostospinoid, and they'll take us all the way to the petrous body. And you can go all the way to the internal aortic canal. That's the internal aortic canal. You can see, you have seen the IAC there. Sorry, internal aortic canal there, you see and this is the ICA loop. You have opened the dura there. That's the fifth nerve. So the same thing in the live surgery. Just a calderal approach. Cellular floor, the paraclavial and the short vertical segment of cavernous carotid. We are now doing the pituitary process sphenoid. And that's the tumor being removed, and you're seeing the fifth nerve there, and you'll have the 7, 8 down there laterally, and the 6th would come somewhere like that. So that's a decent resection, the post-op. There is some residue, but then it's okay. It's a decent resection. And so you'll have, I think JNA, Dr. Kranti is already handling that. We have this JNA with the intracranial extension with the ICA feeders. It's a post-op scan showing complete removal. And the horizontal petrous carotid, this carotid can be better approached by the transcochlear approach also. And that's a child with the Ewing sarcoma. Post-chemotherapy, there is no response. So now that is a transcochlear approach. You are seeing the carotid artery there. That's the entire horizontal petrous carotid. We are now putting the endoscope there, and this is the cochlear genu, and there you have the laceral genu. And that's, I accidentally opened up the internal aortic canal. And we'll have some tumors here. The parapharyngeal carotid is a bit tricky, and the commonest lesion which we have to work around, that is the nasopharyngeal carcinoma, which is very rare in our country, but I think Prabha must be having huge volume of NPCs there. And I think I've only seen 1 or 2 cases of NPC so far recurring after radiotherapy. But that's very common in places like China, Malaysia, Singapore, etc. So we had to cut the eustachian tube, and you remove the tumor from this region. So this is the Vidian nerve. That's a Vidian nerve. That's a Vidian nerve. So you expose this segment there, and we remove the tumor from there. That's the other side Vidian nerve, other side paraclavial carotid artery. We have gone from one parapharyngeal space to other parapharyngeal space. And now we are clearing this region, okay? See, again, the thing is that we don't have much cases like that. So actually, like I caused a small bleed from this segment. There's a small ICA bleed there, but you could fortunately control that. So on the other side, I was more careful. I was just dissecting it with the elevator and then using the co-bleacher. Okay. So sometimes we learn through our mistakes. So that's a Doppler being used to identify the carotid artery. And then then use the elevator, dissected that, and then use the co-ablation like that. This is the transoral approach to the parapharyngeal space, which I can leave, I think, for want of time. And see, all things said, sometimes you will have a catastrophe like this. A revision case, somewhere I lost my orientation, and this is what can happen. I don't know if the carotid was sort of displaced or in this patient, but I had an ICA bleed, and the first time you get that, you really get panicked. But then unless you keep cool and control it, you lose the patient. So that's bleeding. It's complete red out. And now the trick is to get 2 sections, divert the blood to the suction tip, alert the anesthetist there's a blood loss. And now we are trying to get the bleeding with the 2 sections. And once you divert the blood and you identify the bleeding point, you can pack it up with some ghost pack or Mirocell, and then harvest your muscle, crush the muscle and put it there, pack it. It generally stops. It will stop, actually.
Sorry to interrupt, sir.
Yeah, just finish. Last please. Okay. So that's now I got the bleeding point. And once I get that, I can easily pack it off. The suction tip got blocked in the previous clip, I think. Suction tip was blocked. And now that's a muscle patch. And that's a fascia, okay? So I think I can conclude it there and see, once you get it once, see these are all small bleeds. I think the infralateral trunk got, but once you got the experience, it's, this is not a, small bleeds are easy, There is a big bleed, but even with you got it with the big bleed also, right? So I think I can stop it there. So that's the infralateral trunk attachment to the carotid artery right side. So I think I can go for the questions. Thanks.
Thank you very much, sir. That's a wonderful presentation. Any questions from audience?
Sir.
Yes, Sampurna.
This is exciting, like a climax of movie, what is going on here. So I wanted to ask you, see, we don't do many varieties of skull-based cases, but definitely for pituitary, neurosurgeons regularly call us. So many of us who are otherwise a face surgeon just do a little bit of pituitary also. So I want a few tips from you to make sure how far safely we can go to remove the pituitary tumor. Because sometimes neurosurgeons completely give it to, for me, they give it to me because they don't have the complete orientation. Some neurosurgeon take over. So as a ENT surgeon, where we should stop and how we should improve the skill for more and more tumor removal and to prevent recurrent disease or residual disease?
I think you got a very clear answer today morning from Professor Peppa. See, for ENT surgeon, dura is the limit. And the only person who can make you push your limits is the fellow neurosurgeon. The neurosurgeon says, carotid, come work, we'll do it, we can do it. If he says no, stop it there. Because any medical issues, you will be in real trouble, right? So you can do anything extradural. You can do the nasopharyngeal carcinoma, you can do some JNAs, no problem. But intradural, without a neurosurgeon, I wouldn't do that. I had never done that. Maybe in some conference, since the organizers compel me, I'll just say I'll have the neurosurgeon stand by do that. But then, even in my OT, sometimes I do the entire surgery. But if there is some, for the CTM or any ICA bleed, I call him because it's very difficult to work single-handed. You have fellows coming every year, they keep on changing. So unless you get that real four-handed coordination, you cannot work beyond the carotids. I don't know if you have a better answer, How do you want the unison to push the limits? Now, how do you want the ENT surgeons to move ahead with the skull base? Yeah. Where to stop, how much we can do.
I think as ENTs we have enough work, right? Why don't we just concentrate on what we are good in and not go to places that we don't go? Because you can do 1,000 beautiful surgeries. It takes one to screw up your life, your peace of mind, your income, your family's food, shelter, everything. Right? Thanks.
And there are better surgeries. The stapes is much more challenging. Do stapes. Why do you want to go to do skull-based surgery?
Sir, Vinod sir.
Thank you.
Vinod sir, I had that question. How did you manage this ICA? Because recently I also faced a situation like this. And the thing is, it's not that easy that you take a muscle patch and you put over it. So what are the, details of how to, you have taken the muscle patch and then how much to crush it, for how long you have to crush it, and how do you place there? Because it's bleeding like that, you have 2 suction in there, and you showed this video that 1 suction got blocked. So how to do it in detail?
Okay.
If you can say.
So the first thing, the reflex action for any ENT surgery is to pack it up, right? And that's a correct thing to do in the initial phase. So place whatever pack you have, some gauze, Mirocell, whatever, keep it there, apply pressure. Now you inform the anesthetist, see there's a bleed. So he will now take all the things here, right? And then you just stay calm for a couple of minutes because you already packed it. You're maintaining a pressure. You place the pack there, place a blood sleeve over that, you're pushing it. And once you just relax for 2 minutes, stay cool. And then you be ready, take care that both the suctions are working. Alert all the OT technician to keep the suctions working. Now you take 2 suctions, you have a good endoscopist, gently remove the pack, keep 1 suction keep the suctions right over the bleeding point, try to identify the bleeding point. Okay? Then what you do is gently check with gel form and Surgicel, wrap it up, place it there, and 1 section will proceed like that. And I remove the other section. I place a pack. Now we'll go for harvesting your muscle. Take the muscle, place it on the, what you call a kidney tray, something about a kidney tray, just crush it, just beat it with a hammer, like 1 to 2 minutes. And it's practically very difficult to place the muscle as such like that. So sometimes you just take some Surgicel and put the muscle inside the Surgicel. And now you gently remove the suction is still there. Gently remove the pack, keep the suction, remove that fibrillar gel form and everything. Place this crushed muscle with the Surgicel there. Again, keep the suction. Place packs. Place packs, wait for like
half an hour.
Yeah, not half an hour, 5 to 7 minutes, it stops, right? And it generally stops. 5 to 7 minutes, that's enough. And I think there's a protocol like aortic bleed, you have like 5 to 7 minutes to control. IC bleed, you can take like even 15 minutes, right? So you have that time. 15 minutes, if it bleeds, it's almost okay, I think. But generally, we place the pack, we control it, and we can easily manage it.
So your one question. So your experience with carotid stenting preoperatively or?
Carotid stenting. I think I'll discuss it over there, right? You're handling that. I know that we do that, but see, the carotid stenting, it depends on the tumor. Like if you have a tumor around the carotid, you can put the metallic stent and wait for 1 month. And after 1 month, you can dissect around the carotid. Yeah, we do after 1 month, But thing is that we have to work with the anticoagulant. We have the patient on the anticoagulant, we have to work with the anticoagulant. That's a bit tricky. And sometimes we can even put a flow diverter. We can divert the entire flow, it's called a flow diverter. But I think that's a different segment and it will take a lot of time to discuss on that. You can sacrifice the carotid, but then it's a very rare instances.
Thank you, sir. Nice demonstration.
Thank you.
Now, I request Dr. Kranti Bhavana to give her lecture on nasopharyngeal angiofibroma. She is the professor of ENT neurology and skull-base surgery. And she received the prestigious BACO fellowship by British Academy of Conference Otolaryngology at Liverpool in UK 2009. And she received IVS International Visiting Scholarship by American Academy of Otolaryngology and Head and Neck Surgery in 2016. And also she received again the award in 2016 at San Diego University, USA. And she awarded San Diego, USA Annual Meet and Auto Expo in 2016, followed by observership at UCSD at the San Diego School of Medicine Neurology Unit. She won the prestigious Times of India Best ENT Surgeon Award in 2015. Over to Dr. Kranti Bhavana.
Thank you so much. So, at the very outset, thank you, Sampoorna, and your whole team to get me to Hyderabad. The first Hyderabad when I came was in 2005. I was a postgraduate student and I attended the first AOI and understood what ENT is all about. And since then, it has been a dream run in ENT. I love my subject and I think this is one of the best branches. So coming to a topic which is close to my heart is something called angiofibroma, and it has been a slow journey, and now it has come to a stage when it is exciting to operate angiofibromas. Also not because that things have become better in terms of equipment and design, and a lot of things have changed in last few years to make your life easy. So we know I'm going to skip few slides, keeping in mind the time. So we know it's an old thing. Hippocrates told way back that it was the weeping olive of the nose. 0.5% of head and neck tumors are JNAs, and the recurrence rate, that is the problem with angiofibroma. The recurrence rate is as high as 20 to 40%. So this is where all the surgeons have to take a seat back, and this is an entity which humbles you. We know that angiofibroma spreads all around, in all the nooks and corners of the skull base. It goes medially, occupies the nasal cavity, goes superiorly, goes into the sphenoid, goes into the inferior orbital fissure, superior orbital fissure, orbital apex. So what happens is, it is definitely morbid for the patient. But what is there for the surgeon?
You know, for the surgeon, the most challenging part is that you're going to remove the tumor, which is benign, but along with that, you might be injuring all those very, very important structures, which are so important for your living. So today when you were looking at the dissection which Dr. Prepa was doing, I have seen his videos many, many times on YouTube. And whenever I go to operate skull base angiofibromas, these videos really help you as to plan your surgery because you want to see these key areas. Patients present with obstruction, patients present with something as serious as the third image with a huge tumor coming out and the tumor going way down to the laryngopharynx, so much so that we had to tracheostomize the patient. And these are the patients which we did external approach. Diagnosis, clinico-radiological, soft tissue window of a contrast enhanced CT scan is the most important one, imaging which you should have. And if those important structures are involved in the skull base, go for a contrast enhanced MRI. Lot of stagings are available. I'm not going to the detail. UPMC have just been there and they do follow this protocol of residual vascularity because that prognosticates the overall results and tells you which one will recur or which one in which might be the residual is left behind. Janki Ram sir has given stage-wise, progression-wise staging. So patients present to you, you do a clinico-radiological diagnosis and you stage them, whatever staging you are using as a protocol in your practice. And then as I do, I know surgeons who are not embolizing. I routinely embolize all my angiofibromas above stage 2. Lot of questions regarding that, but many literature has told that, you know, this is effective. It is effective at my center. I've been doing this since many years now. Systematic review which just came in 2023 in laryngoscope, which does tell that embolization decreases the blood loss. Now direct puncture embolization has come. What we do at our center is the distal most embolization. Why that is important? Because then it avoids those, these particles going into ophthalmic and all leading to blindness and all other complications. These are our own publications from our own center. So I have a very good team, in fact a very good team of intervention radiologists with whom I work with all my skull base cases. So my surgical journey started in SGPGI Lucknow where we were doing open approaches along with Dr. Isha Tyagi, and he had an excellent, it has been published, we were doing transpalatal approaches with a sublabial extension and opening up the ITF. It was a very good approach. And then when I became consultant there, we shifted to mid-face degloving, again a very good approach, scarless, there's no facial scar, and you get a complete open picture in front of you. Slowly as endoscopes you become more confident and now it's more of an endoscopic story. So endoscopes have revolutionized everything. We all know that. We saw today, we have been seeing since morning what endoscopes have done to ENT. So how do you plan your surgery? So today we'll be talking about stage-wise planning. So there's a small tumor, that's stage 1. Stage 2, nasal cavity, up it, going to the PPF. This is the gross thing which you should keep in your mind. I'm not telling about any names. You can use one type of staging for your center, but this is a gross thing which you should have in your head. So stage 3, ITF, IOF, etc., and stage 4 definitely the intracranial. This is how you plan, and I always make my decision of how will I progress according to these important key areas, the pterygopalatine, the sphenopalatine, what's happening to the ITF, how lateral it has gone on the radiology, what's the status of Vidian, what's the status of the pterygoid wedge, the greater wing of sphenoid, internal orbital fissure, superior orbital fissure. Again, these are difficult areas, when they go in these areas, you need to know the anatomy. And then as it progresses further in staging, the quadrangular space, the cavernous, internal carotid artery, which Dr. Vinod just showed us. So skull base in it itself is surrounded by those important structures which are so important to life. You cannot sacrifice an internal carotid like that. So before you touch the tumor, this is the dictum. Do a very good exposure. So all those approaches which are there, be it the Denkers, so it is for opening up those spaces. Go around, take a superior control. So if you have a tumor where some part of the ethmoid is there, you go back, you open it, go behind, go up to the sphenoid. Take a medial control, come from the septum. take a lateral control, come from the ITF, and then go behind and from the nasopharyngeal vault. Before you hit the tumor, it is a tumor of blood vessels, so you don't want to poke it, even if it is embolized. I'm not going to go into detail. This is a chart which I discuss with my residents stage-wise, how do we do. I can share it later if you want. So this is the Ratkowski staging, and how do we open up the spaces. Navigation aids us. We routinely use navigation at our center. Coagulation, an excellent device for angiofibroma. I think it's one of the devices which has made change to the way we manage angiofibromas nowadays. So let's learn by example. From now on, if I have some time, I'll just show you certain cases. So this is a tumor, if you look carefully, gone completely lateral into the ITF, into the buccal space, into the superior orbital fissure, and to the orbital apex and cavernous. I hope if it's clear, if I can get a pointer, please. And then we embolize that. Part of ICA feeders. This one? Which one? This green? This one? Okay. Okay. So, yeah. Some part of it was not embolized. The interesting thing is this, and I think that's what Dr. Binod has shown. These are the key areas. So you imagine your radiology, you see these key areas. So this is the orbital process of palatine, perpendicular plate of palatine bone, sphenoidal part of the palatine bone, and the medial pterygoid. So this is the key area for angiofibroma, the posterior wall of the maxilla. You go to the ITF here, you go to the superior orbital, inferior orbital fissure, cavernous. We have been discussing this since morning, but as an angiofibroma surgery, you should be able to understand. The paraclival carotid, I'll show you some cases in which that was involved, the pterygoid, the lateral recess, and again the image of the complete ICA. These are endoscopic cadaveric images, paraclival, foramen and lacrum. So what Dr. Vinod told that actually you should call this as a lateral ICA, and the parapharyngeal. So angiofibromas do go into those areas also. So let's, sorry. I cannot find the cursor here in my, because this is going to take time. Sorry. Can you help me with this? No, the cursor is not there. I want to have it in this. Can you change the presentation here? I want the cursor there on the image. No, my mouse is not moving here. Can you give me 2 minutes just to sort this out? Sorry. इसमें मुझे cursor चाहिए. नहीं, इसका presentation बदलना पड़ेगा. No, it's not the HDMI issue. So, the videos are long actually, so I wanted the cursor to just stay there. If anybody can help me out with this. So if I play the, can you just show me how, because the moment I play this, or can you just, I'll show it here. Yeah. This is a keynote and it's coming in this presentation.
Where's it? Can you put that? No, you have to maximize.
Yeah, I'll just maximize. I'll do it without playing then, I think.
No, just play, just
yeah.
play it.
Why?
But you want to put other version, eh?
Yeah,
but
I used to get a, I used to get a...
I understand, but easier is you just play it like this and then... that will take, see the settings, you go to display settings. Systems. Display.
Where is the display?
Mirror display, huh? No.
Play. Cursor नहीं आ रहा ना? That's a Mac presentation. I'm extremely sorry for this.
Let's restart the presentation. Restart it.
Just slide it like this.
I'm not able to see the cursor, that's the problem.
Which one my presentation was?
Yeah, thank you. Sorry for this, and Sampurna, extremely sorry if your program is 5 minutes late. I'm sorry. So this is a full case where we are doing the modified Denkers. Why do you want to do that? You want to use a 0 degree and get the whole picture in front of you. So you remove the medial wall of maxilla. I'm taking a superior control using my debrider to open up the ethmoids and going back to the sphenoids. The medial control from the septum. So angiofibroma takes blood supply from the septum, rarely from the floor of the nose. So you do that, go behind, go up to the keel of the sphenoid, open that area up, and you can use a kerosene punches, you can use a drills, whatever instrument you have. In angiofibroma, better to have all the equipment at your disposal. So this was a big tumor, as you saw in the radiology, a big part medially, a big part laterally. Now what I'm removing here is the part of the orbital plate of the palatine. This is what will open up my inferior orbital fissure and the superior orbital fissure. So I'm gentle traction just to see how far I can go behind. So this is the bone which I'm going to open up later. So this is the bone which I'm going to open up, a big part as I showed you, and that's where I will be doing a piecemeal resection. So don't be afraid of cutting the angiofibroma into pieces. So this is piecemeal resection. This takes time. You know, you're going way behind to the pterygoid wedge area and slowly you cut the tumor. It cuts, it's an embolized tumor. It cuts beautifully. Why I'm doing that? Because I need space to work on those critical areas. I don't want to be blind with blood. So once that is done, I'm going to take the medial part off from the mouth and here is the part which was going into the inferior orbital, superior orbital, and it's coming down. So once I do a gentle traction, the tumor will be delivered below from the cavernous part as well. So just a small, So you can remove this bone with this chip of bone, and if you gently do the traction below, the tumor is going to come out. The cavernous part, not the cavernous, the cancellous bone is very, very important. You have to take care that the area of the wedge, this vault area is slowly removed. They bleed a lot. You can actually use Surgicel gel foam or Surgifoam or even Flow Seal to control this. So finally, so the whole tumor is delivered out, and you can see these globular things, that you understand that the whole thing is out. So that's why I have done a piecemeal resection. So this is the post-op imager of the same patient. This is the second video to show you that in every case, you don't have to do modified Denkers. A small tumor in the corona, come and open your maxilla. But one thing is important, I open my pterygopalatine fossa and my pterygoid wedge in all the cases. So it's better you open that area up, take the medial control, take the lateral control. I have not done a Denkers here. The tumor is a small one, but then very well attached to the sphenoidal floor and the vault. So that's what I'm doing, opening up, maxilla is open, part of pterygopalatine is open, and this is the fat. We all know the fat is what is important. You know that the tumor is not there. A small rent in the sphenoidal floor through which it was going into the sphenoid. So that's what the tumor removal is about. So pre-op and post-op images. 2 cases we did few months back, and I think like last year we did, where the ICA was encased. And I know slowly we are getting more confident in manage ICA we could have managed. This was a tumor which is you can see how broadly the superior orbital fissure has enhanced. And if you look at the MRI, you will see it's around 270-degree encasement of the carotid, and that's where we did the balloon occlusion and planned to coil it. This is the second patient where the paraclival ICA was involved. In a sagittal image, if you see, you can see the ICA completely here around this area. So tumor is here as well. So in both the patients it was coiled, and these two. So again, I'm just going to forward it a huge part laterally, where I'm going to so again piecemeal resection. and slowly dissection from the V2 and look at this area which is lurking behind it. Is from here that will come down from the cavernous part of the, yeah. So slow delivery from the cavernous, the carotid is here, slow delivery from the, so you have to just do a gentle traction, don't poke around, and slowly it will pop out. So that's what is visible. This is the paraclival one. You have removed the tumor completely. I left the paraclival part to be removed at last, and it really bled. So yeah, so this is the part around which the tumor was completely sort of encased. And I'm just going to be a bit fast. So this is the post-op radiology of both the patients in which the tumor was completely out. They're still under follow-up because I'm still suspicious as to what happens to them in long run. Let's see. So you should be ready for the piecemeal resection. You should be ready with superior orbital fissures and all those key areas from which these angiofibromas go, and better to remove them. Interesting cases where the angiofibroma can lurk behind the pterygoids. So people leave these part of angiofibromas of parapharyngeal areas and behind the pterygoids. Remove your pterygoids, so read your radiology and plan your surgery. You plan your surgery, you dream about it, you sleep with it, and then you understand that how you can take it out. Nasopharyngeal vault is another recurrence area. Be careful with that. Pterygoid drilling, we all know, you cannot miss that. Look at the big blob of tumor left behind the pterygoid. So drill it, remove the tumor, and then smoothen that wedge so that those cancellous bones are no more there, okay? Small residual, you can see a very small residual here. We went back and removed this. Kid came to us after a few months and we did remove this part. External approaches, don't forget. You know, COVID taught us, mucormycosis taught us. But we are a generation who was doing external approaches. External approaches do that. Completely
extranasal. So this is in the cheek. Parapharyngeal, just finishing it. Just the last one, this one in which you can see it's in the orbital apex. And you should know where. So this is the area where it is still lurking behind, and you know you need to remove it from there. Greater wing of sphenoid, interesting one in which you had a big tumor there in the greater wing. You can see the invasion here. You can see, and it's completely out. So you are very close to the horizon port of carotid which runs above. So our data, so these are the two cases which are admitted to us, twice operated, now in the cranium, twice operated elsewhere. Now parapharyngeal part is left behind, and this patient has a huge cyst in the cerebellum. So these are some of the challenges. Question to the house, how will you manage this kid? This is my last slide. A huge tumor into the oropharynx. He's a 15-year-old boy and only 19 kgs. Admitted last week. We have been trying to tell him that I refer you to AIMS Delhi. He's not going. So we need to optimize him. My anesthetist, everybody's on board. Let's see how we, and it's a huge oropharyngeal. I know I might have to do a track. But not necessarily, but he's a big mouth breather, and look at his general condition. So as you keep doing, challenges keep coming. Hopefully, I am able to do justice for him. You do follow up your patients at least up to 5 years. Thank you, and thank you for that glitch which was there. I'm extremely sorry for that.
Thank you very much, ma'am. That's a really wonderful presentation.
Thank you.
Next, I would like to introduce our next speaker. I invite you, sir, Dr. Pawan Singhal. He is Senior Professor and Unit Head, SMS Medical College, Jaipur, and is President-elect of the NES and Medical College Teachers Association of Rajasthan, past Secretary of NES, Executive Member of AOI, FHNO, and All India Rhinology Society. And he is Gold Medalist in MS and is an International Fellow of AAO, HNS, ISO, and Johns Hopkins Institute. He has more than 50 articles in international and national journals and has innumerable awards and accolades to his credit.
Good afternoon, everyone. Thanks, Chairperson, for such a humble introduction of my short career. So, after something you have seen a beautiful dissection in the morning by Pripa, and then Vinod substantiated a few approaches, and then Kranti. So from taking you guys from anterior-skull based a bit to the lateral skull base, what experience we have gained at SMS in last 15 years. You know, many youngsters, my whole talk, I want to deliver concepts to youngsters that there is nothing havoc thing going on in the anterior and lateral skull base. The only thing that you see the depth of the practice and the dissection, these stalwarts sitting out there, Vinod and Pripa and Kranti, they have done. More and more temporal bone dissections, practice, reading, following step by step, seeing your own videos, looking into the mistakes and then rectifying it is something will make you a good surgeon, a skull-based surgeon. So if you talk about paragangliomas, basically the glomus word we have been using, it's a misnomer. These are all paragangliomas arising from numerous cells. I'll a bit forward it, and we are like lucky to have them. Most of them are non-functional tumors. If they would have been functional more, we were in trouble because more of adrenaline being rushed in the body of the patient and we were in trouble. So this misnomer should be corrected. These are all paragangliomas, whether it is a carotid one or a vagal one or the tympanojugular one. So there are maybe like temporal bone paragangliomas and neck paragangliomas. Some of the tumors are associated with multiple endocrine neoplasias. Fish has classified them in 4 categories, like confined to the promontory, involving the mastoid, then going along the carotid and intracranial spread. Then Gruppo Autologico from Italy, including our own Sampath Chand Prasad Rao, they modified this classification and included the vertebral artery along, so that it is involving the vertebral artery or not. And then if you talk about experience at SMS, so far we have done around 69, 70 cases at SMS. Most of them have been luckily jugulotympanic paragangliomas. A few of them were multiple paragangliomas, mostly the bilateral ones, and where they did have some familial coincidence as well. So, you know, in the first 5 years when I did advanced skull-based courses there at Dr. Morwani sir's place and Dr. Narayan Jaishankar, then with Sampath, I was an enthusiastic surgeon initial, like the adrenaline flowing through my vessels, and I was ready to do each and every case which I face. So I did a lot of cases in my first go, and with my expertise, like growing up, I did more and more cases in my second 5 years, but then suddenly my number were decreasing. Why was so? The thing is that I learned from my mistakes. I learned that there have been a lot of complications which I was not supposed to give. A patient with a docile tumor which is sitting around there not doing anything, why I'm going to operate, I'm taking so much of extensive dissection, doing maybe a single or multiple cranial of palsies and changing his voice, swallowing patterns, aspirations and all those things. So my numbers decreased. I became more selective. So I learned what not to operate. So then I learned something known as a wait and watch technique. Wait and watch, yearly scans. If the tumor grows more than 2 to 4 mm per year and then becomes symptomatic, young patient, I'll operate. If it's more than 65, already the functions have been retained. Even after such a big tumor, no growth over last 3 or a couple of years, I'll not touch. So these are something important. And the most important thing is ICA. Whenever you try to deal with these tumors, please try to see the relation of the tumor with the internal carotid artery. The most important prognostic factor in these tumors is ICA. And if you know how to deal with that, right from the preoperative evaluation till maybe many months after surgery, then you can operate. So I'm not demeaning your enthusiasm. I'm just trying to think upon that you have to be an expertise of the anatomy dissection and preoperatively plan well before the surgery. Like it was so easy to see Vinod doing and Kranti doing, but you know, really need to have a good knowledge of anatomy and dissection and radiology and the tumor behavior and pathology in these cases. Thanks to Sampath, I have got a few slides from Sampath. He has done a voracious job in lateral skull-based tumors. So, which are the cases I wait? More than 65 years, lower kidney palsies in elderly, normal lower kidney function in young, and then insufficient venous collaterals if I do have. Why to give him some palsies there? Maybe hemiparesis, quadriparesis, or monoparesis and all, or poor general condition. So pre-op assessment revolves around the carotids. You stratify the risk with the things, and you have to explain it to the patient and the attendants. Well, pre-op algorithm you said in what could be the sequelae, how you are gonna deal with the tumors, and intra-op planning and the post-op management and all. Then you have to deal with the carotid with a lot of things. Pre-operative balloon oxygen test you can do, Matas test you can do, modified Matas test. If you do have a genome CT, you can get it done for collateral circulation. Then you do four methods of angiography. It could be non-invasive like MR, it could be invasive like CT scan, or a 4-vessel angiography, and balloon occlusion test. Balloon occlusion test is a must these days if the tumor, even if it is a bit touching to my carotid, to the carotid. So I'll get a balloon occlusion test done, because most of the time at government institute, you see the patient came 6 months back, he has got those radiology with him, and what is the present status, I don't know. If I order for the radiology, half of the patient has gone. So this is a scenario there in India. So I'll not go in the detail of stenting and all. Stenting you can do prior to surgery, 4 to 6 weeks, as we discussed with Vinod. And what happens with the stenting is basically a new intima develops around the stent, and you can even strip the tumor off the carotid. It's so easy. I've done a number of cases in which you do it like you are doing a thyroid. So it makes a big difference when you stent the carotid in these cases. So it was a recently done case 2 months back, type C, Shamlin. It was basically in carotid parangiomas. In the older era, it was supposed to be a very difficult and dangerous surgery. But I'm telling you, if you start from the midpoint in the horizontal section from the common carotid, you go sub-adventitial plane. You use the bipolar cautery and do a good dissection with a backup of the CTVS surgeon, so that if you injure something, or you have already done a stenting part or pre-op embolization, balloon oxygen test you have done, you can ligate. Or if you have not done that pre-op, not available, you can keep a CTVS surgeon. They very well take a saphenous vein or something like that, or they will just do a bypass surgery. It's very easy for them. So you can keep a CTVS surgeon with you. So these are good, easily doable tumors. They are not doable. They are doable tumors. The thing is, pre-op assessment and planning should be done well. So it was post-excision. It was type C. Temporal paragangliomas. You know, there are a lot of protocols. What we follow is, we get a CT-MR done for all of them. We get a 24 hours urine collection for VMAs and all, adrenaline, metanephrine and all those things. There are many surgical techniques like a small tympanicum, which is lying there on the promontory, which has got a blood supply which is coming from the inferior vessel. You can bipolarize it, you can remove the tumor permeatal approach. You can even use the laryngeal vent of the cobblator to flush the promontory of the tumor. That is very easy job. I do that in quite a number of cases. Then you can combine the approaches from transmersal to combine to the infratemporal fossa approach, right? A, B, and C, according to the extension of the tumor. So this was the tumor blush. If you can see that, we did minimal canal drilling there because the tumor was a bit going in the sinus tympani and all. So did this job. Then what is important is to go around the tumor. Even if you are dealing with a small tumor on tympanicum, you have to see the margins of the tumor. So what you do is elevate the whole cup of the external acoustic canal, drill all around the tumor, so you get the space to deal with the tumor from all around. As Dr. Kranti was saying, don't embark on the tumor, any vascular tumor, go on the peripheries, take control of all the corners, nooks and corners of the tumor, then approach. So this is like coming inside. So this is a tumor being, and even I'm using the cobbler, if you can see laryngeal vent, after tumor resection, you have to deal with this tissue there, and then even the osteoplasty can be done. If you have not touched, you need to remove the incus first so that you don't transmit those, you don't transmit heat or your drilling or cobbler energy there in the labyrinth. So remove that, remove the incus so that you don't pass that energy there. And a few difficult cases where the tumor is going in the hypotumeric cells, retrofacial cells. So what you make is you make a bridge of the facial, you go through the retrofacial cells and you connect them with the hypotumeric cells. And the tumor can be removed like both the techniques, combined approach technique, and then canal down, and you can even do a good metoplasty, put in a graft, job done. You don't need to go ahead with a cul-de-sac closure in all these cases. The same case, I'll just finish. Can I take 5 minutes? Maybe no questions, we can discuss later. So I'll skip some tumors which are going intracranially. Don't afraid of the dura, although Dr. Pripa has advised you not to disturb your sleep, meals, money and family life. But a few cases can be dealt by the ENT surgeon as well. You can cauterize the dura, make an incision, go inside, take the tumor out, use the fat places, put it inside and do the cul-de-sac closure. You can do that. So preoperative, post-op, you can see. So I'll just come on the lateral skull-base cancers. We use the Pittsburgh classification method. Surgery is the mainstay of treatment unless it is involving gross intracranial, it has gone gross intracranially. Lateral skull base, lateral temporal dissection, subtotal temporal dissection, and the total temporal dissection. Total temporal bone dissection cases we don't do now. We did around 2 cases in the past, but very morbid. We could not save 1 patient because carotid had to be ligated in those cases. Our experience at SMS, 30 cases we have done so far. So this is a lateral temporal bone dissection case, where what you do basically after elevating post-oral, you do a mastectomy. What you do is you go all around the external-acoustic canal, do a episiotomy, drill the base of the zygoma, come anteriorly, drill the bone, come on the mastoid process, mastoid tip, drill out there, see the facial nerve, save it, and then take out the whole cuff. This is how you do in the lateral temporal dissection. In subtotal temporal dissection, take a C-shape curve, make a cul-de-sac closure, remove all the bone, do a radical mastectomy, do a subtotal petrosectomy-like thing. All the ear cell tracts should be removed. Pre-sinus dura should be exposed. Intraluminal or extraluminal blockage of the sinus should be done, as I have done in this case. And this was a big tumor going in the middle fossa, posterior fossa. You can see the first step I do is cul-de-sac closure in these cases. And then you do a condylectomy, parotidectomy, facial resection has to be done in all these cases. And you have to be well prepared for maybe hypoglossal facial anastomosis or masseterofacial anastomosis. But in these cases, I don't prefer masseter because it is in the vicinity of my tumor. So what I do is facio-hypoglossal anastomosis, maybe a jump graft or a thing. So this is how you remove all the bone from the middle fossa, posterior fossa, remove the entry wall of the sinus. I have drilled the enteroacoustic canal till the CP angle. Then you can see the jugular foramen valve open, all the nerves, lower cranial nerves can be seen and block it. So a lot of complications have been there, 2 mortalities we have seen so far, but there are not only 2. A patient who does not come for your follow-up in the lateral skull-base cancers, that means he is not there with you. So I take it as gone case. So all these things which I have been talking about, well planning, surgical planning, post-op planning prior to the embarking on surgery should be done. And the most important thing is to focus on the anatomy, to focus on the practice you do in your clinical practice, to focus on your cadaveric dissections, learn from the stalwarts like we are seeing sitting in the front row, and focus on your own techniques, rectify your techniques, see your own videos, and then you can get skills and expertise with this focus. Like you can see them. Look at it. His eyes did not move from the ball. He doesn't know he is going to hit with someone or not. He was focused, and this comes with the skill. Thank you so much.
Thank you very much, sir. Any questions from audience?
You are allowing questions. Thank you.
Very, very honest presentation. I really liked it. You just showed your complications. You just showed that which cases not to operate, because people always say all globus jugularis need surgery. It's not like that. I really liked it. Thank you.
Thank you so much.
So now is
Saha, sir.
See, if you are getting a case of middle ear malignancy, okay, will you do the cul-de-sac closure or?
Certainly, sir, cul-de-sac closure.
But
because no functional preservation is there, I'll be drilling all the bone from the mastoid.
No, but are you sure?
You are talking about, I'll do at least subtotal temporal bone flexion.
No, are you sure that you have removed? It's very difficult to be sure that you have removed every bit of cancer in that case, and patient need post-operative radiotherapy.
Certainly, sir, we are sending all these cases. Without any doubt, all these cases do require adjuvant therapy.
Right.
Yes.
Thank you. Thank you.
Thank you, sir.
With this, we come to our third session. May I request our chairperson, Dr. C. Subramaniam, to felicitate our speaker, Dr. Nitika Gupta. Okay. May I request chairperson, Dr. C. Subramaniam, again, to felicitate Dr. Vinod Felix. So please come onto the dais. Now, may I request our next chairperson, Dr. Ashok Prithvi Raju, to felicitate Dr. Kranti Bhavna. One big round of applause, please. Now, may I request our chairperson of this session, Dr. Baisakhi Bhagat, to felicitate Dr. Pavan Singhal. Thank you, sir. Now, may I request Dr. Vinod Felix to once again come on to the dais to felicitate our chairpersons of this session, Dr. C. Subramaniam and Dr. Ashok Prithvi Raju. May I now request Dr. Kranti Bhavna to felicitate our chairperson, Dr. Baisakhi Bhagat.
I'm sure we all have enjoyed this third session. Please, big round of applause to our chairpersons and speakers. Thank you so much. Thank you to all the dignitaries on the stage. Thank you so much. We are now going to start our fourth session, which is dedicated to cochlear plant. May I invite our chief guest faculty, the most dynamic Professor Dr. Prepaganan and Dr. Ram Babu, an ENT consultant at Apollo Hospital, Jubilee Hills, Hyderabad, to please come onto the dais to chair this session.
No. Share it. Always better.
Over to you, sir.
Good afternoon, ladies and gentlemen. I think we'll go ahead with the fourth session. It's my pleasure to invite Dr. J.M. Hans. Hans, sir, good afternoon. I still remember our journey in Munich, Innsbruck. He's a very good singer, personal. Sir is present pole, Chairman, Department of ENT and Cochlear Implant Center, Venkateshwar Hospital, Delhi. He's holding so many posts. I have to read. The best will be the ENT surgeon to the ex-Honorable Prime Minister of India, Advisor UPSC Personality Test Board, Advisor UPSC Personality Test for Combined Medical Examination, Member Central Coordination Committee for Prevention of Deafness, Ministry of Health, Government of India, Member of Executive Council, National Institute of Speech and Hearing, Mysore, Expert EDIP Program, Cochlear Implant, Government of India, Professional Visit Abroad Workshops in Cochlear Implant like Australia, WHO Fellowship, Cancer, 1995, Toronto, Canada, USA, many other places abroad. The best is he is awarded Padma Shri by Honorable President of India, Sri APJ Abdul Kalam, sir, 2005. I welcome, sir,
Thank you.
for the guest lecture.
Thank you very much. Thank you very much, Chairpersons. Thank you, sir, for coming to India and telling us about your experiences. I was a cancer surgeon before I joined the cochlear implant group. And after my MS from PGI Chandigarh, my primary surgery was cancer, but I stopped doing. When I see Vinod Felix doing all that, it gives me a shiver, really. So I wanted to do something which would give me happiness and also peace of mind, as Sir said. So, but doing cochlear implants for the last 25 years have still given me a lot of problems, because if you're a surgeon and if there are no problems, it can't be like that. So if you are operating, there has to be, because what nature has created, you're trying to spoil it, and this is what I'm going to talk today. Preserving nature in technique and technology. That's my thing. And in 25 years, I've seen what these guys give us. We put it without realizing that we should not have done it the way they told us. And this is what it is. So my journey in cochlear implant started in 1993. And from 1993 to 1998, I visited as WHO fellow to all these places, met stalwarts from Professor Graham Clark to Netzelski to Dela Cruz and everybody, and I worked with them for almost 6 months each visit I made as a WHO fellow. Obviously, my inspiration was Professor Graham Clark, whom I stayed twice for 6 months each in the Beinecker Institute in Melbourne. But the soul was, for a very short term, in the year 1998, when I went to Saloniki and met this great man, my concept, my learning in those last 6-7 years of posterior tympanotomy and cochlear implant changed completely. Though the theory did help me, because cochlear implant is not just surgery. There's a lot of things also associated, and as a surgeon, you have to know that why is the intraop telemetry not coming, why is the NRT not coming. You have to explain them that why is it so. But as far as the surgical part is concerned, my concept about cochlear implant changed completely, and henceforth, I never looked back.
So my first thing is the Varia technique. And as the human beings have spoiled nature completely, and that's the reason why we keep seeing tsunamis and flooding everywhere, this is what is happening probably in our system also. So we have to respect this nature. We have to utilize this. Obviously, when we are operating, we'll have to utilize that. But we have to preserve this nature also. And that's what is important. And in a surgical technique, this is done by organ preservation, minimal surgery, and with adequate exposure. So if we have these three things accomplished, I think we probably are saving what nature has created inside us. So for that, in cochlear implant, you will have to understand that it is not only the anatomy you should be worried about. What people do is, I know the anatomy, I know this, and I do it. No. I think we'll have to go back to the physiology also of the organ. We cannot compromise on the physiology of the structure in order to do that, and this is what really creates a problem in that. And to know the physiology, we will have to know the embryology. And in a temporal bone, embryology is what is important. We know temporal bone has 4 parts: the petromastoid, the styloid process, the squamous part, and the tympanic plate. We also know that the facial nerve is a part of the petromastoid part of the temporal bone. It will never come into the facial recess because the facial recess is formed by the union of the tympanic plate to the mastoid bone. 100 years back, this gentleman told facial recess because the facial nerve will never ever be in this part of the temporal bone. And we have probably forgotten, and that's the reason why many of us could not understand the Varia technique, because it takes only a fraction of this facial recess to create a tunnel instead of the posterior tympanotomy. And why we don't want the posterior tympanotomy? Because we have to understand the physiology. In a child as small as 6 months, my youngest child, what I've done is 6 months of age, and in a child as small as 6 months, who is still mother is giving the bottle and making the child feed while the child is sleeping. That's what India is. We keep teaching them, but they do. We have a small, short, and straight eustachian tube, which is connected to the nasopharynx and into the middle ear cleft straight away. So any infection, adenoids, infections are coming to this region without any barrier. Now from there, nature created a wonderful thing. They created the attic, the adductus, the antrum, and the honeycombing of the mastoid air cell system. So the infection from the middle ear, from the mesotympanum, actually takes a little while to go through the anticus and posticus. In the adductus and the antrum, you have, in the attic and you have these ossicles with the mucosa around. So it's pretty difficult for the infection to go straight away to the antrum, and from the antrum spread into the mastoid air cell system, the supralabyrinthine to the petrous apex. Now, what do? You create a where is the light? Center? So you create now this gentleman must have done a very good surgery. Look at the posterior tympanotomy he has created, and only a good surgeon would do that kind of a posterior tympanotomy, a huge posterior tympanotomy. This case was done by me 10 years back with the Varia on one side and a posterior tympanotomy on the other side. And the thing got infected within 6 months, and the patient came back to me that this has happened. Now, it may not happen in every case, but we are potentially opening up the floodgates for the infection in a small child to get into from the mesotympanum into the mastoid system by creating a large posterior tympanotomy there. Now that is what my aim is, not to do a mastodectomy or not to do a posterior tympanotomy in a child as small as 6 months of age. That is what Varia tells us. I don't say those people who are doing posterior tympanotomy are doing anything wrong, but just imagine posterior tympanotomy was started for cochlear implantation in adults. When we started doing children, we really faced a lot of problems of many others which I'll show you just now. Now, I still do the post-oral incision for double reasons. Now, it is a difficult incision, and you'll have to learn it to understand it properly. And this gives us a beautiful exposure of the the mesotympanum. And the only structure when we raise the tympanomeatal flap is the round window and the promontory. So that's the beauty of this technique, that you are creating a tunnel as small as 1.4 millimeters and having an exposure of the cochlear and the promontory of such a panoramic view. So that's what the beauty of this technique is, and you can see in the subsequent things I'll tell you how it is beautiful. More important than this is that the end-oral approach is not crossing the line of the electrodes. Now, the electrodes go straight into the area, and if you have to do a subsequent surgery, you will realize that you will have to open this up. A double-breasted arterial-based flaps which cover the implant very well. There is no chance of any skin necrosis there, and never ever, if you want to do a revision surgery, will you have to cross where the electrodes go inside the thing. And you can have this kind of thing post-oral. So when you do that, you get into trouble, and these kind of exposures of the electrode come because you are jeopardizing the vascularity of the area, and that's the reason why it will give up. Yes, these things can happen in a end-oral incision also. You can see a bad scar there, and we opened it up. It did not cross the area where the electrodes were passing into the canal, and we could stitch it back without even going to that area where the electrodes are. Now, this is what Varia technique is all about. This is, you have to straighten the posterior canal wall first, and then with this perforator, drill a 1.4 millimeter tunnel into the at the back of the external canal. That is all the surgery is. And you get a panoramic view of the mesotympanum with the promontory and the cochlea, where you can do that surgery very well. Now, that is a little suprameatal well what we create, where the extra electrode is put, and that also helps you to create a tunnel behind the wall, not on the wall. So that's important. And by not doing this and getting that exposure to doing that and getting that beautiful exposure is what Varia technique is all about. And you can see there it is far ahead of the facial nerve in that tunnel where we create vis-a-vis the posterior tympanotomy, the mastoid cavity. You can see the electrode goes straight into, and you just direct the electrode inside, which doesn't take more than 30-35 minutes of surgery. Now, the most important thing which was told to me when I started this, and mind you, I was alone in 1991, and for the couple of years after that, I was the only person in this country getting into somebody which everybody was ridiculing that time. But I had the firm conviction that this probably is right, because I've learned the anatomy, physiology, and the embryology of the whole thing, and I know it is right. So there was danger to the facial nerve. That's what people keep telling us today. And for that reason, you will have to understand the embryology, that what we are trying to achieve is a tunnel 1.4 millimeter in the posterior tympanotomy, just below the incus bar. And it will never happen like that you will get into the facial nerve unless and until you are not careful. Now, the careful thing is, the care to be taken is that you'll have to irrigate the area with lots of saline so that it doesn't get heated up. That's the only time when you have this problem and the facial goes, but otherwise you are much ahead of that thing, and that is the area. If you come below towards the area where the chorda joins the facial nerve, the facial recess becomes very narrow, and the chances are that you might injure the facial nerve, but that is not where we go. On the right side, we go from 11 o'clock to 10 o'clock straight into the cochlea, so there is never any problem. Now, it was almost 18 years later that the cochlear guys called me to their Cochlear Skill Institute. They gave me 2 temporal bones, and they made me do the the Varia technique. And then they did a histopathology of the whole thing. And you can see that this is what I had done. And when they did the histopathology, you can see that the tunnel is, that is the lateral semicircular canal, the tunnel, and the facial nerve. So the facial nerve is far behind, far posteriorly as far as the tunnel is concerned, and never ever would the tunnel injure the facial nerve, if you are right. Now, doing that and getting that exposure, to doing that and getting that exposure, this is a posterior tympanotomy, a pretty good posterior tympanotomy, and that is what the exposure is when you do a tympanomeatal flap elevation. We do a stapes through that, and we have to drill the bony overhang to get into that stapes. Here we don't have to do, it is right in front of you, and this is what you can see, the tunnel. This is all you tunnel you create. This is the tunnel you're creating, that's the facial. You don't have to create a large mastoid cavity there to do that. Now, why do you want that? Somebody would ask me that, why do you want? As you do more and more cochlear implants, different situations will come to you which are difficult. And these are few, I'll tell you. You have an anteriorly placed sigmoid sinus, very anteriorly. You have a low-lying dura sometimes. You can have a ossified basal turn, and unfortunately, most of the time, the basal turn is ossified, and that's a bad thing for the cochlear implant surgeon. So you have to make an anterior cochleostomy, okay? Then the facial nerve is dehiscent, but still it could be done very beautifully. You have a high jugular, dehiscent jugular bulb, which is covering the round window. You could still do a cochleostomy and do the implant. You can do a drill out beautifully. Now that was an ossified cochlea, and almost about 8 millimeters of till here, the drilling had to be done to get the electrode inside. So we drilled that is called the drill out of the cochlea, and as we were told by Dr. Vinod that you have the cochlear part and you have the internal carotid right in front of that, and people have gone into the internal carotid canal, drilling that area through that angle of the posterior tympanotomy. But here you are at right angles and you keep drilling and you turn anterosuperiorly on the right side as you come near because you're seeing the basal turn completely, the promontory completely. And last but not the least, this will also happen if you are doing, basal turn fistulas, you are doing gushers. And this is what we have devised, the 3-hand technique in CSF gushers. You can see this is the suction line there. The electrode is already inside. We should put the electrode when the gusher is on, not when we have drained the gusher completely, because then if you pack it and you've not packed it properly, next day you'll see all soakages and you'll have to keep doing lumbar punctures. Today, with this 3-hand technique, there is no need for I don't see any leakages next day. And with 2 hands, you can put the periosteum there inside the cochlea. I also here would take some opportunities because I'm talking on technology also. The form electrode of the medal implant, which is supposed to be used in this, is not a good implant, not a good electrode, because this cone of the elastic doesn't go and block the CSF gusher, particularly if there is an internal carotid artery continuity of the cochlear structure. So you have to put a large amount of perichondrium inside so that it pushes the perichondrium outside as the gusher pressure increases. So you can beautifully close all these kinds of conditions very, very nicely with the Varia technique, with the beautiful exposure of the the promontory and the mesotympanum. In a child, we also know that there is a probability of cochlear rotations. In the first 2 years, when the petrous base is expanding, the cochlea can rotate, and we still would go because this is the area where we will have to put the. See, this is the round window. This is not the anterior-inferior portion of the round window. We have to see the basal turn where it comes and attaches to the round window, and that is the area where the cochleostomy needs to be done. And you can see that we will make a very small, adequate cochleostomy in which any kind of array would fit in properly, snugly. So you can see that when you go through the round window, the crista can always give you a problem putting the electrode, and I have seen electrodes going into the vestibule and other places. You can drill this crista only through the cochleostomy. This is a crista, that is the round window dish. this crista can be drilled only when you are doing a cochleostomy and being there. So that is the crista, and that is the round window niche. Putting that, you drill the crista, the round window niche, or you have to drill the crista to be going straight into the thing. Most important, this implant is not going to last you for 100 years there. You will have to do a revision sometimes or the other. If you don't do it, somebody will have to do this revision for change in technology. Maybe you want to upgrade the technology, what you have put inside, and we have done a lot of it. We put these ceramic implants, and now we are putting Sonata 3, where the synchronies, where it is 3D compatible, and tomorrow what will happen, we don't know. You will have to do a revision surgery. Now, revision surgery is so easy in Varia that you just remove the electrode and put another one 31.3 millimeters in length, which goes in smoothly. Now that's only because of the technique, and it takes only about 30 minutes if there is a revision to be done. It is only possible with the Varia technique because you have the tunnel already there. The electrode goes through the tunnel into the cochlea straight away, and you just have to just glide it inside, and the whole insertion is complete. More than 3,000 implants now in the last 25 years, many times 8 to 10. I used to go in the morning to areas where government programs were going on. I'm not taking any Limca book record in that, just to say it is the technique which is very simple. You have 2 OTs, so I just finish that, somebody stitches it, I'd go to the other one, and in a day I have done more than 8 to 10, starting 9 o'clock till 6 o'clock in the evening. I was the only Asian in this group in 2002, and today we have over 100 surgeons in the country doing this technique in Pakistan, Nepal, and Bangladesh. Many people come and learn. We have a temporal bone lab, all the necessary things for a thing. Now coming to the ideal cochlear implant. Now this was surgery which I have to take because I'm very passionate about it and spend my life doing it. The implant which they have given us had many problems, and this is what I want to discuss with you and why we need something different today. Now, there are 3 things to an implant. There is an anatomically aligned receiver stimulator, so it has to be aligned in such a way that in the small convex skull of the child, it sits nicely there. An MRI compatible magnet and a situation-specific electrode array. You can't have one electrode for every situation. You have to have a different electrode for every situation. I have done almost every kind, not almost every kind, because I was in government. I was not promoting one implant system, so whatever they would say I have done, starting from the pulsar to the synchrony today, to the nucleus and this thing. So I have done all of them, and I found that these implants are a dangerous thing inside the skull of a child. Any little trauma can actually lead to these kind of situations, hematoma. Now this may be many years, 10 years, 12 years after the child is doing pretty well, and then one day they come out with a hematoma which you have to drain. And if you don't drain them, they get infected, and this is what the situation is. So we have to have something which is not changing the structure of the squamous temporal bone inside, and they are very safe. You have then magnets which keep coming out, and you have to put them back and stitch them back. Nobody wants, no parent wants these things to happen. They give it us, the parents come to us, and they're angry at us that why didn't you tell us these things can happen? You do tell them, but they are not listening to you. So you have to be very particular in telling that these things can happen, but yes, these things are happens because they are giving us, we are doing them, they go away, and we have to face the parents who are very, very angry. Now, the coil has to be in such a way that it goes and sits onto the squamous temporal bone properly. The child's squamous bone is very, very convex, and if the electrode implant, such a big one, doesn't sit there properly, you can have situations. Now, there are still certain implants which are giving us this rounded thing, and the tissue can grow under it because of the convexity, and it can actually come out. Now, I'm not saying, this is not theoretical what I'm saying. I'm giving you a reason that what they are giving us is wrong, and we have to keep justifying them and doing our bit. I mean, the problem comes on our head. And the parents have spent a lot of money. They've given the children to us, and we are putting things which are, in my opinion, not so good for the children we put in. Okay? Now coming to the electrode array. It should be adequately long. I don't think we need so long electrodes, which probably in our setup are too long for the cochlear duct to accommodate. 13.3 millimeters may be good in Europe or other places, but definitely not. So you'll have to really see what size of electrode you want. The problem is that if we take a medium size electrode, then the ring doesn't come to the place where we need it to be. It comes at the same place where it is supposed to be, and it is not giving us the... So it should be adequately long to fit in all the lengths and diameters of the cochlea. The cochlear diameters can also keep changing. The sizes congenitally can change and acquired can change. So you need a different electrode for every situation, because you will not be able to put the implant properly in these. It should be soft and malleable. Now, what do I mean by malleable electrode array? If you see the electrodes, most of the electrodes are straight wires. Now, if you kink a wire, it will remain kinked. It will not come back to its same position. But if you have a wavy spring-like wire, and if you kink it, it would not get kinked, and it will come back to its position. So to have these, now this I have understood now, because I realized, my God, these things they kept giving us, you are kinking there are open circuits, short circuits because of mishandling of the electrode, and the poor child has to suffer. So how they create the wires inside the electrode array so that they don't get kinked is also important. And they should be smooth surface. Earlier they gave us electrodes, these are earlier electrodes they gave us, and the biofilm will form like this, and when you pull out this for upgrading the implant system, you will not be able to put the electrodes inside. So these things have to be seen, and why didn't they realize it earlier and didn't tell us earlier is the thing, and they have to now do it properly now. So when we are doing a revision, both things are important, the technique and the technology. The electrode has to be smooth so that it comes out properly and the next one goes in properly. So that is what the revision is. Now, very big no to a perimodular. Why? I'll tell you that. That in a perimodular, you need a bipolar stimulation. That's what they say, that it is better you give a bipolar stimulation. I won't tell you what bipolar and monopolar is, but monopolar stimulation is the one we like because it is less traumatic to the electrode and to the spiral ganglion. But if you bring it closer by a perimodular, you will ask for a bipolar electrical current, which is not the right thing to do. So why are they giving us electrodes which are perimodular? Secondly, the diameter of the spiral ganglion can vary, and if you are putting this kind of a thing, it will strangulate the spiral ganglion, which will start giving you bad results gradually. And this also leads to scalar deviation, so that the electrode passes from the scala tympani to the scala medii and to the scala media, and all these things happen, and this happens maximum in perimodular and midmodular, very little in this thing. So for that reason, because of the scalar deviations and all this, they came up with slim modular electrodes, but they started having tip foldovers. You can see the tip foldovers started occurring, and to remove this electrode and put another one was another great difficult thing to do and problem. So what is the normal implant? The normal implant is that you have a DSP outside which digitalizes the sound and gives it to the inner structure, which is an electronics which converts the sound waves into electrical waves. But today, and this is what it gets heated up, because if it is placed right onto the dura gets heated up. The mapping is not correct. The electrical current which is passing is high. They get heated up, and it is the dura only reacts to heat, and the child gets pain and all these things. And these are the kind of things children are getting because of the electronics inside. I recently started doing an implant which is called the New Bio. I've done about 50 of these also. There is a DSP and an FSM, both outside, and there is an inert structure inside, just like a 1 rupee coin. Thickness is also like that. And you can see that it is electronic free device inside. There is a thickness is 3.5 millimeters. It is the smallest, 28 millimeter into 24.5 millimeter, and only 4 grams. So you don't have to drill the bed of that thing. You are not, causing any problem. The total surgery with Varia takes only about 30 minutes. You have a beautiful electrode, and this is how it goes back. I won't go into that, but our brain is an analog brain, and this is analog stimulus which it is giving you, a very good implant. Yes, every time, whether it is surgery or technology, technique or technology, leading the way is a difficult thing to do. You are pretty lonely there when you are saying something, but tomorrow when many people take it over and feel happy about it, they follow you, and thank you very much.
Thank you very much, sir. It was very difficult for me to stop you. You are a passionate lecturer and you made it very look and sound simple. Thank you very much, sir.
Thank you.
The next lecture, I'd like to invite my colleague, Dr. Janardhan Rao Jagini. He's the head of the Department of ENT and senior consultant at KIMS Hospital. He worked as assistant professor ENT, Gandhi Medical College, and he was ENT consultant at Apollo Hospital, Hyderabad till 2004. He did his fellowship in pediatric ENT at Detroit Medical Center, Wayne State University, Detroit, USA, from 2005 to 2007. Worked as faculty in pediatric ENT department at Children's Hospital, Michigan, Detroit, 2007 to 2015. Welcome, Dr. Janardhan.
Thank you. I'm sure, sir, many of the crowd has come here to see you and to watch you. We are just here to give some rest to you. So, at the outset, I would like to thank Dr. Sampurna Ghosh and her team for giving me this opportunity of speaking on round window surgical anatomy. The round window, as we know, so we know it as one of the two openings which connects the middle ear and the inner ear. So when we were younger age and we were juniors, we hardly used to pay any attention on the round window at all. All the focus was on the oval window and the staphylectomy surgery. So the round window, we used to use it only for round window reflex, to check the round window reflex during tympanoplasty, and that's all. But the cochlear implants have changed everything. Now every cochlear implant surgeon or every aspiring cochlear implant surgeon has to know a thorough anatomy of this round window, because this is like a gateway to this cochlear implant array. So for benefit of junior faculty, I would like to discuss under these headings. First, the anatomy of the round window niche, followed by the anatomy of the round window membrane itself, then how the round membrane is related to the scala tympani, and Dr. Hans was pointing out about the crista or the hook region. It's very important to understand the variability and the anatomy of the hook region and all the relevant points of this anatomy to the cochlear implant surgery. So a round window niche is an area bounded by the cebiculum posteriorly and superiorly, and the funiculus anteriorly and inferiorly. The cebiculum separates the round window niche from the sinus tympani, and the funiculus separates it from the jugular bulb below. But the round window niche is very variable. Everything in the round window anatomy, right from niche to membrane to hook region, the striking thing is variability. So you may see a very prominent funiculus. Sometimes if it is a high riding jugular bulb, the funiculus may be small or even absent. Then the round window niche itself hides much of the round window membrane in majority of cases, and it is bounded by posterior pillar, a tegmen, and the anterior pillar. The posterior pillar fuses with the sibiculum, whereas the anterior pillar is almost continuous with the funiculus. Then there is a thumb-like bony projection going from styloid eminence towards the basal turn, which is called the fustis, which is well described in autoendoscopic anatomy. This points towards the basal turn of the cochlea. The importance of this would be in a difficult round window or in an ossified round window cases. And between the fustis and the funiculus, you may see a cell tract. And again, the importance here is a junior may mistake this for the round window itself. It is a subcochlear tunnel, which is also again variable. You may see very cellular subcochlear tunnel, which goes right up to petrous apex, and sometimes it may be very small tunnel. And the round window itself may be covered with many times false membrane. So this niche anatomy is important to understand, because in many cases the round window membrane is well hidden with the niche. So the average depth is about 2 millimeters, and pillar lengths are very variable, and tegmen width is also very variable, and we see very frequently false membrane. And unless we remove this membrane, we may not see even the round window reflex. So it's very important to remove this membrane and understand this anatomy of the round window niche. And the relations of the round window niche, I have given many figures here are from various articles. So I gave credit to the authors at the bottom. So the round window niche is posterior and inferior to the oval window. So for a junior, it's very important to understand this fact that it's posterior and inferior to the oval window. And sometimes the niche may be very minimal and you may see the whole round window, or sometimes the round window membrane itself may be well covered with the niche. A step further. And when we, in earlier days, we always used to do a cochleostomy, anterior and inferior to the round window niche. And in those days, I remember we never used to see the membrane completely. But now, we, as a rule, we always remove the whole niche and clearly see the membrane. Then in the next few minutes, we will see why we do like that. Then it's important to understand the distances of the round window niche to various neurovascular structures around. So round window niche is nothing but just the posterior inferior edge of the promontory, and round window to oval window, as I already said, is about 2 mm, and anterior niche is about 5 to 6 mm away from the carotid artery, and the facial nerve is 5 mm to 6 mm posterior and lateral to the round window, and the jugular bulb is about 2 to 3 mm. Again, everything is variable, as I mentioned. So it's important to understand these diagrammatic pictures to see the relations. And you can see the distance between the oval window to the facial nerve, to the carotid artery from the anterior margin of the niche, and the distance to the jugular bulb. And all the distances we should clearly appreciate. This is the left ear, and if you see, just to summarize the whole thing, so between the funiculus inferiorly, sibiculum, and the round window membrane hidden with by the tegmen and anterior and posterior pillars, and the fustis pointing out towards the basal turn of the cochlea. So now we come to the membrane itself. Again, like the niche, the membrane is very variable, and interestingly, it is not round at all in most of the cases. So there is a paper called "Is the round window really round?" It is not. Most of the time it is saddle shape, oval shape, and it comes in various shapes, and sizes are also very variable. These are all mentioned, the average sizes of the round window membrane. And the last line is very important from cochlear implant point of view, because you can have a posteriorly faced, posterior inferiorly placed, or inferiorly placed round window. Obviously, the most advantageous for an implant surgeon is if it is posteriorly placed, because your scala tympani tunnel will be just in line with your view. But the most common direction of the round window membrane is posterior inferior, and inferior round window also can be seen. So in a very nice paper from Italy, endoscopic anatomy of the round window area, they have described various ways the round window can happen. You may see clearly, but some rarely you may not see clearly the round window through the posterior tympanotomy. And the round window shape comes in various sizes, and the infracochlear tunnel is also variable, and the direction of the opening, as I said, most common is posterior-inferior, but sometimes you can have inferior or sometimes even rarely posterior. So this is the take-home slide of my presentation, because you have to understand this round window membrane, how it looks from inside. Suppose you open the round window membrane and go. What do you see? So you know the scala tympani ends blindly at the round window area, but the round window membrane is not like a door to the scala tympani. It closes the scala tympani from the side, which essentially means that when you open the round window membrane here, what you see just in front will be modulus. It will not be a scala tympani, because scala tympani goes antero-inferior to the round window, and as scala tympani approaches the round window area, it is called like a fish hook. It bends and makes it very narrow here. And here, the superior edge of the round window is very close to the osseous spiral lamina and the basilar membrane. And at this edge, at the superior edge, all the things fuse. The osseous spiral lamina and whereas spiral ligament, everything fuses, and the scala tympani becomes very narrow in this area. So one should, if you try to insert your electrode array just through the membrane, you are very likely to hit the osseous spiral lamina or the modulus. And if you are lucky, it can turn back into scala tympani. But if you are not fortunate enough, you may perforate the very thin ground lamina, the osseous spiral lamina or the basilar membrane, and translocate into scala vestibuli, which is then you will be joining, which is doesn't give optimum results as far as the outcomes are concerned. So our main aim as a cochlear implant surgeon is that the electrode array should go smoothly into scala tympani. If you want that, it is important to understand this anatomy of the round window membrane from inside also very clearly. So the upper edge of the superior, upper edge of the round window membrane is osseous spiral lamina and basilar membrane. The posterior edge is related to the ductus reunions. And if you go directly superiorly, you will enter the vestibule, obviously. And if you go antero-superiorly, you will get the scala vestibuli. So our main interest is antero-inferior and towards the basal turn of the cochlea and towards that promontory area where this space is narrowed, and this is this crista or the hook region. So in this specimen it is drilled, but in this is normally there is a thick bone here, and that is also variable. The crista or hook region is variable, and unless you drill this crista or the hook region, your electrode array will not go smoothly into scala tympani. So this outline was given in this paper, and I tried to do what we do is, once you completely see the round window membrane, you divide it into 4 quadrants: antero-superior, antero-inferior, antero-superior, posterior-superior, posterior-inferior, antero-inferior. So you should never go superiorly and you should never go antero-superiorly. You should always go in this quadrant. Even here I tried to imaginary line draw like this and go more inferiorly than anteriorly. So it is more of infero-anterior than antero-inferior. So if you go in this trajectory, then you will go directly into the scala tympani. And the floor of the round window is related to cochlear aqueduct and inferior cochlear vein. So to make it very simple, it's a left ear. So if this is the exposed round window membrane, your scala tympani tunnel is like this. So never try to just perforate the membrane and go inside. So you have to define this tunnel and go antero-inferior, so that trajectory should be posterior-superior to antero-inferior. So this is the hook region, and this area is the hook region. You can see the scala tympani is very wide as it goes inferiorly and anteriorly. But at the end area of the round window, it's very narrow, and this is the place where this osseous spiral lamina and everything come in one place. So we should avoid this region and go here. So these are some of the pictures. I'll skip due to time lag, but there are many papers showing clearly the round window anatomy, how it looks from inside and how you should, and this is the hook region which, and this is the way the scala tympani, you can see it becomes very narrow as it approaches the round window, and you have to drill this area to get into this thing. And this is a beautiful picture showing the crista, which has to be drilled for you so that your line of trajectory will be in line with this thing. So this is how we do during surgery. Expose the whole round window membrane, divide it into 4 quadrants, go to the anterior-inferior, that too more inferiorly. Here, you can see me small depression being made near the annulus of the round window. Then you open the round window and unite this by drilling that edge. Then you see the tunnel. So the idea is to go into the tunnel, not just to put the implant in. So your aim is to have good outcomes and to preserve residual hearing and to minimize intracochlear trauma. If you want to minimize intracochlear trauma, you have to know in detail about the intracochlear anatomy. So what should you do? You should insert in line with the tunnel and you should avoid the modulus. You should not damage all these structures, spiral ligament, osseous spiral lamina and the basement membrane, and avoid translocation into scala vestibuli. So how do you do that? You evaluate your anatomy clearly with the scans also pre-op and during intra-op. Avoid anterosuperior area and superior edge of round window and enter scala tympani from inferior anterior edge of round window and aim for tunnel. Whatever the technique, the discussion is not on round window, extended round window, cochleostomy. Whatever technique you use, as long as you put your electrode array smoothly into scala tympani, that is the main aim of this understanding the whole anatomy of this area. So I would recommend to juniors to read this beautiful article which gives all 3D models of the round window membrane. So thank you from the KIMS Hospital Cochlear Implant team and especially our chairman Dr. Bhaskar Rao, who gives unlimited support to our program. Then we have fellowship program for juniors both in audiology and surgery. If anybody is interested, they can contact us. And we have a one-day workshop coming up, which includes live, not only live surgery, live mapping and live activation. So it is not only for surgeons, audiologists and auditoverbal therapists. Thank you very much.
Thank you, Dr. Janardhan, for your extensive and elaborative information about the round window, which makes us confident of approaching. Thank you very much. Any questions, please?
Thank you so much for such an elaborative lecture on round window, sir. Amazing lecture. I switched over to round window from the cochleostomy now. I usually started with Varia. Now, due to our randomized trial, randomized study, I am doing posterior anatomy also. The same thing I observed, sir. The inferiorly faced, inferior type of round window, this implant last I did, I could not get on the round window because I could not see that it was inferiorly facing through the posterior anatomy then. So what I did everything to see with the relation of everything. I tried to see the fusties and all because I don't believe in cochlear rotation. It is the external acoustic canal wall which is coming like this, which makes it type 3, 1, 2, 3, 4 round window. So what I did is, sir, I elevated the posterior canal skin. And then I tilted the head, saw the round window, put in my pick from this side, and then I localized that. So this was one experience. So inferior one are the most difficult one, round windows. Thank you so much.
Thank you.
Sir, one request and question, whatever you say. Can you please speak on the radiological way to know whether you have put in the correct chamber? Whether it is in...
you mean intra-op or post-op?
Post-op. Have you done that?
No.
Or if
you
somebody
mean
wants
whether
to
it is in scala tympani or scala vestibuli?
How somebody can confirm that, like evidence-based, that it is there?
Yeah, I don't have any experience on that. Ram Babu?
No, I don't think we will be able to clearly find out that through the radiological.
But there are many papers which say many of the earlier implants we did are in the scala vestibuli, not in the scala tympani. Especially when you do cochleostomy anterior to the round window, because in our earlier cases, we did together many cases, invariably you will be more lateral than ideal, and you will damage the spiral ligament, and many of them will be in scala vestibuli if you don't go through round window. The advantage of round window is you are definitely in scala tympani, but the disadvantage is that, as Dr. Hans pointed out, we have to remove that crista, that inferiorly that small piece of bone has to be removed so that the tunnel comes in line.
Actually, to remove the crista is very difficult through the round window than to the cochleostomy, because it is like flattening a mountain standing at the base and at the top. At the top, if you want to flatten a mountain, you can flatten it. So when you're doing a cochleostomy, and the only thing is, maybe in the surgery tomorrow, I'll tell you that why always, if you do a cochleostomy, why always you are in the scala tympani. Because we are doing where the basal turn comes and meet the round window. What now also you explain.
Yeah, you are bypassing the crista area basically.
No, not bypassing. We go anterior superiorly and then drill the crista down. So when you are in the cochleostomy, and secondly also I feel for hearing preservation, if you have a baffle effect of the round window still there, it is better to be preserving, and particularly if you are doing EAS and virtual implants, hybrid implants, sorry, you have to have the round window baffle effect still remaining. Now, if you put an electrode through the round window, the baffle effect would not remain. Some say this is a third window somewhere, but I don't understand if the cochlear aqueduct is so wide enough to give you a third window. But in my opinion, if you keep the round window membrane intact, the better preservation of the lower frequencies remain.
Yeah, there are many arguments you can do in favor of cochleostomy compared to round window. I agree with you, sir.
Thank you, Dr. Janardhan.
Thank you.
We go on to the last speaker for the session, the cochlear implant session. And I don't think she needs any introduction, right? Is there anyone who doesn't know her? Please raise your hands. Dr. Shampuna Ghosh, who's the chair. She looks very pretty today.
I've only known her as a student, now she's a master.
Yes, she's a big lady now. So, gold medal from Calcutta, cochlear implant surgery, OS-day surgery, academic inclination, a learner of new techniques, invited speaker, surgical faculty and panelists in many national and international academic forums. I'm sure we'll be seeing her many, many, many more times in the future. Sampuna, the floor is yours.
Is it on now? Working? Working now? Please help me on this one. Anna, help me in that. Yeah. Is this okay, no? Yeah, which one?
This is back one.
This is the front one. Okay. Good afternoon, everybody. Long sessions and discussions going on. From basic otology to advanced otology, we are moving. I thought to talk on how to venture into cochlear implant because it is a dream for many otologists. So what is the expectation versus reality? I'm going to talk on that topic now. Today started the Olympics in Paris, and we are doing this like mini Olympics for ENT surgeons. 400 delegates from all over country, and Southeast Asia is not a joke. It is a really something like Olympic for us. Once more, welcome to the city, which has the blend of the old historical places as well as the beautiful high-tech city where you are sitting in. And I always feel proud to show my picture with my mentors, Professor Somnath Saha, Dr. Srinivas Kishore, and Professor J.M. Hans. And you can see Hans sir's guru, Dr. Trifon, is also there in the picture. And I'm also grateful to Dr. Janardhan Rao Jagini, who has helped me to learn the posterior tympanotomy. And whenever I am in some trouble, I do take his help as well. And I recently had training from Professor Robert Briggs in Sydney as well. So what is the learning curve of CI? So I just thought that what I have seen that there are two ways people learn. Some people are there who after master degree will go for fellowship, or which is definitely the best way, but everybody's journey is different, especially for ladies. If you are a mother, if you have a family, if somebody have a transferable job, there are people who go to their mentor for short multiple teaching courses and then start on their own, how I did mine. And of course there are lucky people who during their MS or GNB in their own institute get a good exposure of the CI techniques. They are very well versed with the post-op protocols, pre-op investigations and all. But there is pros and cons of both these groups. Those who are exposed in early stage, once they learn during the MS, but the time they reach to a level when their practice is established, even a CI candidate will consider them to be trustable enough to do CI for their child. There may be a long gap, so they have to be in constant touch of the technique and keep practicing that. And they have to do, because the early exposure, they have to keep doing cadaver dissection. They can also practice in the artificial bone model. The other group, exposure during practice, that is like you can visit to the mentor's place multiple times. You can have your mentor to your center, like how I have been very lucky that Han sir agreed to come for all my initial cases from Delhi to Hyderabad. So you have to select the proper person who will not only just give you a fellowship certificate, but actually will catch your hand to take you to the level when you are independently able to do it. And keep on going, learn and implement, learn and implement. Don't think I will learn this completely, then I will do the first case. There is nothing such in any of the surgical subspecialty. You have to learn, you have to do and layer up your knowledge as you keep doing. How easy it is to start CI practice? So again, government setup and private setup, two different approach. Government setup, of course, you need the approval and you need to set up a nice team. Whereas in private practice, it is quite difficult to start. It needs persistent efforts. It is not enough just to learn the technique. You have to be very, very passionate to start. It will take a lot of effort. There have to be a long-term plan and vision, otherwise it will not run smoothly. You cannot have in the first year itself 10-15 patients who will come to you for CI. It will start with 2-3 and then gradually it will increase, but you have to have that patience and passion still there to search for patients to continue your journey of learning. You must build a team of audiologists and AVT therapists, and you have to search for different free schemes, NGOs, if you really want to continue this. Equipment is an issue in both the setup, especially in India, but outside countries also. So whether it is government, you have to wait that I need this, and in private also you have to ensure them that I am able to revenue generate enough that you will invest this for me. But if you are not able to do that, my suggestion is always invest in your equipment. Buy it, start doing it, the rest of it will keep coming. My reason of starting with Varia was two. One, I immediately loved the technique when I saw Hans sir doing it in the first place. And second, I told him, sir, I do not even have Zeiss microscope. At that time, I was operating with Opto. And Opto is quite good, by the way. They have their stall. I'm not diminishing them. But I said, sir, I have an Opto microscope. I have a marathon drill. I don't have Medtronics drill. I don't have nerve monitor. So do you think this is doable? He said, no, beta. With a loop also you can do. Go ahead. So with minimum equipment can be started, and later on you can upgrade your equipments. When can you start a CI clinic? You have to first build a very, very good general ENT practice. Like Prepa sir beautifully answered my question and bowled me out about the pituitary, why you want to ruin your peace of mind. So basically your routine septoplasty, tympanoplasty, tonsil adenoid, these are our bread and butter. Once you establish that practice so well that your name is well known and people trust you, then only CI patient will come. Nobody can directly live on just doing CI if somebody has not done 3000 like Hans sir. So people like us have to respect our regular ENT practice and live on that, and these are only bonus. These are to enjoy, not for money. Navigating the market. This, I don't know how much applicable for Malaysia, but for India, that was really, really tough. Cochlear implant, I think like stents in cardiology or knee implant in orthopedic, this is the only thing which is very costly the ENT surgeons deal with. So there is a lot of business model and politics and monopoly which you have to go through, but if you have the wish, it can be done. How to navigate the market? You have to know about different company products yourself very well. Ask your mentors, ask the audiologist, don't get completely biased by what the company people are teaching you. As a surgeon, you should take the upper hand, you should learn the science and technology so that you can decide and not being completely driven by the company people. At the same time, you have to make friendship with them because these are the people who will train your audiologist. Your audiologist may not know anything about CI. They will give training. They will come for initial mapping. They will come to your OT. So there should be a nice balance maintaining your self-dignity. How you may feel initially. I think everybody knows this series. So Game of the Thrones, everybody is behind getting the thrones. So initially this feeling may come when a new CI surgeon has started to do, but it will not persist. We can grow together. How? Be open-minded. Learn all the techniques. You may love one particular technique, but don't be biased that the person who is doing PT is bad or the person who is doing Varia doesn't know anything. You should know both the techniques because there are situations when you may like to do the other technique, so you can deal with all the complicated cases, and you have to learn from your audiology team and AVT also. Don't think that you are the superior most person. No, without a team, you are nothing. Your job is only to put the implant. Rest all will be taken care of them. The patient will be more in touch with the AVT team and the audiologist. And most important, don't hesitate to call the mentors because initially when I started, I used to get simple cases like normal cochlea, good thickness of nerve, but as your number increases, then only you start getting the anomalous cochlea, thin nerve, different syndromic child. So don't think, okay, I have seen that somewhere, I will manage it. No, feel free to call your own mentor. If he or she is not available, make connection with the local CI surgeons who can help you, and definitely if you tell somebody, sir or madam, I need your help in OT, they will come down. By doing that, you will be in a safe zone. Slowly you will start navigating through the difficult cases and you will have the confidence of giving the good result. So the situation from Game of the Thrones can change to this. Whoever have watched this may understand how the situation changed for Sachiv ji once he came to that remote village versus once he was leaving from it. Let us simplify. We ENT surgeons from the MBBS MS, we are used to see this graph more than beta. That is the truth. We are more see PTA. We don't see so much beta. So to remember that when the PTA graph is showing a loss in this red area, that is more than 70%, then you think about CI. Don't think that it is 80, 90. Below 70, start thinking of CI. About pediatric criteria, everybody knows. Okay, in the MS question comes, but what I have seen, I was not taught about adult CI candidacy much in my training period, and presently also among the audiologists and among general ENT practitioners, this is very hazy area. People don't talk much about the adult candidacy. That is why I have put this, and you see from 1985 to 2019 how the criteria has changed, how they have become more lucid now and their guard has come down. At time it was only bilateral profound loss. From there it came down to severe to profound. Then it came down to moderate to profound. And now we are doing single-sided deafness as well. These are the common criterias. And coming to candidacy, I always say that think beyond the audiogram. Audiogram does not give the whole scenario. Audiogram gives you an idea about sound perception, but sound sensation perception are different. You have to look into the speech discrimination score. You have to ask your patient about clarity. Are you able to understand what you are watching in the TV, what you are speaking in the phone? Are you missing the sound? Many times they can say, I'm able to hear, but I'm not able to understand. We don't give much attention to these kind of things. We simply write hearing aid trial. After going to the trial, what happens? We sometimes don't track them. But it is mandatory that after hearing a trial, the patient should come back to you and then you evaluate all these things. If you see there is less speech discrimination, less clarity, and the hearing is deteriorating on the lane,
then you counsel that probably you need CI. Immediately the patient may not have the budget, may not be ready, but at the end of 1 or 2 years, they will think about it that the life doesn't end here. I'm not getting benefit, so there is another option. They will come back to you for CI. This is the 60-60 guideline which was formed to guide the American audiologists when to send the adult candidates for CI, where they have said that if the PTA average is more than 60 decibel, in better year, 500, 1K and 2K Hz, and if the unaided word recognition score is less than 60%, you can consider the candidate for CI. They will not benefit much with single hearing aids. There are different kind of other implants as well. Tomorrow there is a talk on this, and Dr. Sanjay Sachdeva is going to talk on Baha, and Shailaja from MEDAL will speak on all these devices, so please do attend that. Audiological assessment you all know, start with BERA, OAE, ASSR rarely I do, impedance I definitely do, like tomorrow's case has been admitted and today we repeated the impedance because anytime they can develop glue ear. Role of OAE, OAE is a screening tool, so if BERA is not showing any peak, you look into the OAE. OAE absent means you should be happy as a CI surgeon that yes, I can give a good result. The problem is in cochlear outer hair cell. OAE is present mean doubtful, it is ANSD. Will you not recommend CI? Of course you will recommend CI because there is no other tool available to give them hearing, but you will have a guarded prognosis. You will spend more time counseling the patient along with your audiology team. These are the radiological assessment, and even though we read all these chapters during the MS, but that is only for exam preparation. If you don't really do that after just 2-3 years, then because I get the calls that madam so and so patient is there, what scan we will write? It's very simple. Just go for a CT temporal bone and a MRI, look for the nerve and look for the cochlear overall anatomy. These are the radiology specification. This is how a normal cochlea should look. This is a 3D image. If you have this, good, but if you don't have, a simple CT or MRI will be sufficient also. You have to identify simple things like labyrinthitis ossificans, and you have to set your eyes to identify normal versus anomalous inner ear. This side is normal, this side is anomalous. Early implant is the main thing nowadays that developed countries are doing implant less than 1 year age. We are little behind that because our neonatal hearing screening is not yet universal. Varia technique will be shown tomorrow, so I am not showing any video here. Similarly, PT video also I will skip. Candidacy for difficult cases. Can we do for MR autism? Yes. Can we do in common cavity? Yes. Can we do in Mondinis? Yes. All these cases CI can be done and good result comes. Only again you have to explain the parents what to expect and what not to expect, how much the speech will come. Definitely child will hear because the technology is simple and CI is one of the most reliable implant in the medical science. So you have to assure them at the same time give a realistic picture. Inner ear malformation. Previously when I started going to different CI workshops, when I thought may I learn this, I used to hear so much talk about this, which literally demotivated me. Classifications, this, that, but probably this is not so much important because not all cochlea are anomalous, or small percentage of cochlea is anomalous. And if you don't remember those classification, it's okay. You can start your journey. While doing, you will learn again. Candidacy for difficult cases, ANSD, yes, can be done. Simultaneous versus sequential, very important. If your budget, patient has adequate budget, child is fit for surgery, you are confident that you can finish on time, then go for simultaneous bilateral CI. Postlingual candidates give excellent result because they are already exposed to sound. These are different kind of audio processor, implant. Slowly you can learn that. 1 more minute, sir. How do you select implant? This is another thing the beginner will stumble. Which implant I will give? Should I give cochlea? Should I give MEDAL? Should I give AB? Again in cochlea there are so many classification. MEDAL has so many nomenclature. Just look into the reliability. Every company will have that data in their website. and talk about the MRI compatibility. These two are the main things. Expectation versus outcome. This is a balance game in CI. Don't give a dreamy picture to a child who has come to you at 5 years age without any auditory stimulation before. Don't tell them, yeah, after doing within 1 year, the child will go to normal school. You have to tell them, earlier the implant, better is the outcome. So should I venture into the new domain? Of course. If you have the passion, you are passionate enough, your thought process will manifest and you will convert into that particular domain. You will be a regular CI surgeon if you really want. These are some of the pictures of my patients who are from different states of the country and different countries as well. And luckily I have the experience of doing from 1 year old to adults. And this is how the journey is going on. Thank you all. The main reason of selecting this topic today was, I asked Dindal sir before coming, sir, how many ENT surgeons are there in India? Probably 12,000 you said. 12,000 ENT surgeons in India. We have a group called CG, only 800 members. And that in 800, 400 are audiologists. So in 12,000 ENT surgeons, 400 CI surgeon. Is CI surgery so difficult? Not at all. Just you need right mentor, right setup, and we need more CI surgeon because by 2050, the number of deafness will increase and Southeast Asia is the hub of congenital hearing loss. So we should not keep the knowledge within ourselves. There should not be monopoly. I expect that you all who wants to learn, select your own mentor and start into the venture. Thank you all.
Thank you, Dr. Sampuna. Very nicely illuminated, very nicely explained. Do we have any questions? So before we start the next session, any burning questions? We are already slightly behind time. We can take 1 or 2 questions.
We have a question.
I think your presentation was too clear.
Or too basic, anything.
No, I think it was very clear, to the point. Very honest as well.
Thank you, sir.
So if that's the case, we will close the session and allow the next session to start so that we can get ready for the rock and roll tonight. Thank you.
There's an announcement. Tea is served at the balcony. Anybody interested or free to have hot tea and refreshments. Now, we'll start with the felicitation. May I request the chairperson, Dr. K. Rambabu, to felicitate the speaker, Dr. J. Hans, and Dr. Janardhan Rao Jagini. Please, round of applause to our speakers. May I request Dr. Prepagrin to felicitate speaker. Sorry. I'm sorry. Now I request Dr. Prepagrin to felicitate our organizer, chairperson, and speaker, Dr. Sampurna Ghosh. To felicitate our chairperson, may I request Dr. Janardhan Rao Jagni to felicitate our chairperson, Dr. Prepagrin. And now, may I request Dr. D.S. Deen Dayal to felicitate Dr. K. Rambabu. Thank you, dignitaries. An announcement. Delegates who have not collected their dinner coupon, kindly you can approach our registration counter and collect the dinner coupon. It's at 7:30 onwards. Now, I hope our delegates have really enjoyed all the sessions we had till now. Yes or no? Yes? No sound. Yeah. Now we proceed on to our last session of the day. Shall I start? May I call upon our chairperson, Dr. D. Shekhar Reddy, and Dr. Sudeep M., consultant at Aparna Hospital, Warangal, to please chair the session. May I call upon our chairperson, Dr. D. Shekhar Reddy, President of AOI Telangana branch, to chair the session. Thank you.
I would like to invite Dr. Monica Pokhrel. She's working as a professor for the MBBS students and MS otolaryngology students at the Dhulikhel Hospital, Kathmandu University Hospital till date. Trained in sleep medicine, West Plus, Clinicum from Germany. Published about 31 publications in international and national PubMed journals. You can start, ma'am.
Am I audible?
This is the point. Laser. Forward.
Respected dignitaries, ladies and gentlemen, a very warm good afternoon. And today I will be talking about sleep stage scoring and polysomnography. So, starting with my journey of polysomnography, how I started the sleep lab at Dhulikhel Hospital is, like, I am working in a setup of 450 bedded hospital that is called Dhulikhel Hospital, which is situated 30 kilometers away from Kathmandu. And we have almost a coverage area of coverage of 2.5 million patients, and we get referrals from all around Nepal for this obstructive sleep apnea. So my journey started when I went to Germany, Westphals Klinikum, Kaiserslautern, and I had my mentor, Professor Dr. Norbert Stasche, who trained me in sleep medicine. And since I saw that there are a lot of patients in Nepal who are suffering from obstructive sleep apnea, and it is only forming a tip of an iceberg. There are so many patients, so we just need to ask leading questions to them and find out the problems, and then know the real gravity of the situation and then move forward. So that's why I decided of continuing this field in my country, because there are very few people who are working in this field in my country. And mostly sleep lab is set up by the pulmonologists and the sleep technicians are doing it. So what I thought is, as an ENT surgeon, since we are getting most patients, so it will be nice if we have some idea about how the sleep lab functions and how we can run it, and if we do the sleep testing by ourselves and then see the patients, it becomes more effective. So that is how I started the lab. And so starting with the presentation, I'll be talking about the sleep stage nomenclature. So the RNK system, was initially the RNK system divided sleep into the wake stage and the stages 1, 2, 3, 4 and REM stage sleep, which was further modified by the American Academy of Sleep Medicine into wake stage and N1, N2 and N3 stages of non-REM sleep, followed by the REM sleep, rapid eye movement sleep. And this slide shows the optimal duration of the epochs in which we do the sleep scoring. That is, for the sleep staging we use 30 seconds epoch, for the respiratory events we use 60 to 120 seconds epoch, for the clinical EEG 15 seconds, and for the ECG rhythms we do 10 seconds. And also very importantly, I would like to tell you that we need a team approach for approaching our OSA patients. So we have a very good dedicated team of cardiologists, pulmonologists, oromaxillofacial surgeons, and also the psychiatrists who are working along with me in order to see the sleep patients who are suffering from the sleep problems. So basically the scoring of sleep is done in 4 steps. That is the staging of the sleep, staging of respiratory events, scoring of arousals, and the periodic limb movements. So this slide shows the way we fix the electrodes in case of polysomnography. So this is a modified version of the given by the American Academy of Sleep Medicine. So here we can see that we have cut down the number of leads which is traditionally kept by the in the EEG. So here we only use the frontal, central and occipital electrodes, and the even number indicates right side and the odd number indicates the left side. This is the picture we are showing the traditional EEG way of putting the electrodes, which is modified by the AASM now. And this is the electrooculography. So we can see here that the electrodes are placed up and down, one above the eye and one below the eye, so that the grafts do not overlap each other. So they move on the 2 sides so that they don't overlap. And for classifying the EEG waveforms, we need to count the cycles per second of each wave on the epoch, that is the 10-second epoch. And we have the various kinds of EEG waveforms. We have alpha waves, theta waves, sleep spindles, and the delta waves. Now coming to how do we prepare the patient for polysomnography. So there are various kinds of polysomnography that can be done. That is, one is the MSLT, the another is the traditional 48-channel polysomnography like we are having in our center. We are using the Miniscreen Pro device by the Hein-Lowenstein company, and it's functioning very well. Likewise, we have many other popular companies like ResMed and so on. And so you can just have one of them, and what you need to do is you have to prepare the patient very well, and you have to tell them to take a very good head bath so that there is no sweat and it doesn't interfere with your electrode placement. So patient comes at night after doing their regular work, and you place the electrodes, and for that you need electrode cream. Or in case if you don't have the electrode cream, you can use the ultrasound gel and some spirit swabs, and if there is some hair, you have to shave it. And after that, you place the electrodes as such. So these are the frontal, central, and occipital electrodes, and also you can see the EOG electrodes, electrooculography, that's placed above and below the eye so that the grafts don't overlap, and the nasal thermometer is placed. The submental plethysmogram is placed, and we have the chest and abdominal belts, and we also have the SpO2 monitor, and we have a anterior tibialis monitor also, so as to see the periodic limb movements. So after that, this is connected to a computer, and this is just shown, kept here so that I can tell you, but preferably we ask the patient to sleep in a very cozy and comfortable kind of room, which resembles our normal room, and the computer is placed in the another room where the sleep technician is sleeping, seeing the patient. So first, we have to calibrate the device. So for that, we ask them to close the eyes, look right, up, down, left, blink eyes, clench jaw, flex foot, breathe in, and snore sound. So why I am telling you all these things is that when I started the sleep lab at my center, we didn't have a sleep technician. So I was the one who went to the Germany, and I saw that I saw the sleep lab there, and I was very impressed, and I wanted to start this in my country, and we didn't have any sleep technician. So what I did is I read books. I read many books on sleep medicine, and also I took training from there, and I did it myself first. And later, as we started getting more patients, we sent a sleep technician for training in the same center, Westfalls Clinicum, and then we started getting referrals from all around Nepal. So after that, and then also I started doing the manual scoring all by myself, not by the sleep technician. Because then you come to know the gravity of the situation, and sometimes you can have manual errors also. There will be computer errors in the report given by the sleep technician sometimes. So if you are able to understand that well, then you can treat your patients well. So this is how the calibration is done. And now coming to the various stages of sleep, we can see here we have the stage N1 stage of sleep of the non-REM, which constitutes 3 to 8% of the normal sleep. So this is the lightest form of sleep, and it is a gateway of sleep. So you are easily arousable in this kind of stage, and you are in a stage that your body is relaxing, especially at the end of the day when your body feels dozy, or as if you want to just sleep. That is the stage 1 sleep. After that, you enter a slightly deeper stage of sleep, which is when your eye movements will slow down, and you enter a stage where you are not at the deepest stage and you are not at the superficial stage. You are just in between. So that is the N2 stage of sleep, when you need a bigger stimulus to arouse you. And also we spend most of the time of our sleep in N2 stage sleep. After that, we enter the N3 stage sleep, which is the deepest form of sleep, in which you are non-arousable and your body becomes flabby. And this is the part when it is the restorative stage for the body. So it is restorative for your tissues, and your body muscles are getting relaxed. So after that, you are entering a stage called the REM stage of sleep. In REM stage of sleep, this is also called the rapid eye movement stage sleep, and this is very important. Right now, I am doing some researches on this REM stage of sleep, because usually what we have seen is the obstructive sleep apnea is more common in obese, very obese people, and who are elderly, or usually it is more commonly seen in men. But REM OSA, it is more common in females, and it is seen in mild to moderate OSA patients, and it has more detrimental effects on your cardiovascular health and also your metabolic health. So this concept is upcoming now. And also REM stage of sleep is very important for our body, because it is restorative to our brain. So we can do judgment, and we can do the more judgment, and you can do the memory consolidation in this stage. So this is very important, and the children spend most of the time in REM stage of sleep. That's why they can learn things better than adults. So as you can see here, in stage N2, we can see the sleep spindles and the K complex. So here you can see sleep spindles are very sharp waves, which you see in the stage N2. And the K complex is the upward and downward reflection that you see. This can be elicited by knocking the door, or some loud kind of stimulus, like a loud sound. So if such situations happen, then we can see the K complex in N2. And in N3, we can see the ocean wave-like graph. So this is a very restorative kind of state in which the tissues are relaxing. So as we can see here, we spend 4 to 7 hours of our sleep in stage 1, 2 and 3 and only 90 to 120 minutes in the REM stage of sleep. And this chronology will sometimes get disturbed, especially in obstructive sleep apnea patients. So they go into N1 and they go to N2, and again if there is a stimulus, they come back to N1 and then N2 and so on. And in the stage of wakefulness, there will be very sharp waves, and we can see alpha waves. And the EOG will show conjugate irregular, sharply peaked eye movements. And the electromyogram will have normal to high chin muscle tone. As I said, in stage N1, we have the theta waves and the vortex sharp waves. So there will be slow eye movements because it is just the initiation of the sleep. And EMG will show normal chin muscle tone. In stage N2, we have theta waves and the spindles and the K complex as I showed earlier. And the EOG is similar to EEG. And there is variable to normal chin muscle tone. This is the picture showing the K complex. And we also can see here some sleep spindles. So sleep spindles are these kind of graphs that we see in N2. K complex is basically, it has a biphasic deflection and the duration is more than or equal to 0.5 seconds, and it is a characteristic of N2 sleep. Usually these recordings are done by the computer itself. It is self-generated, but sometimes there will be manual errors. So I recommend that everybody should check the graphs themselves. So here we can see the ocean-like waves, and in stage N3 we can see that there is a variable to low chin muscle tone. This is stage REM stage of sleep. So we can see that there are movements in the eyes. Also, we can score arousals, but I want to skip this slide because we are running out of time. So we can score arousals, mainly 3 types: respiratory, movement, and spontaneous arousals. So, talking about obstructive sleep apnea. In obstructive sleep apnea, we meet all the apnea criteria, and we can see that there will be cessation of outflow, nasal airflow, but the chest and abdominal efforts will be there. Unlike the central apnea, in which there is absent inspiratory effort, but there is also absent airflow. So we can see here that there is chest and abdominal efforts are not there, and also the graph is flat. There is no airflow. Whereas in mixed apneas, what happens is there is absent inspiratory effort, and initially we can see that there will be a cessation, but later again it will resume. So this is about the mixed apneas. Hypoapnea is similar to apnea, but the duration is less than 10 seconds. And there is associated desaturation of 4% with airflow reduction to 30%. So this is a crescendo, decrescendo pattern of graphs seen in Cheyne-Stokes breathing. And we can see periodic limb movement over here. So I will just, this is the graph showing the, this is the way we see the polysomnograph. So it is the same. Thank you very much.
Thank you, Dr. Monica. That was excellent presentation.
This one? Shall I give this?
No.
pizza? No pizza?
Before that, you have to announce it, right?
Yeah.
Now we are going to start OSA panel discussion. I request our volunteers to please arrange the chairs. While we are arranging for our panel discussion, I invite our Dr. Pavan Singhal to moderate a quick short quiz for our audience and request our chairperson. One of our chairperson of the session was also Dr. L. Sudarshan. I request all our three chairpersons to have a seat on the sofa.
Hi. So, just to decrease the boredom after heavy lectures going through your ears, I call it OST, overhead transmission sometime. We used to afford during our residency and MBBS time. So I used to call that overhead transmission. Teacher took a lecture, it went ahead with the over the head and nothing going inside. So there is something Sampurna has kept. I don't know the questions. They have got a quiz there. So one who answers will get a chocolate and also a coupon from Santosh Surgicals. They will give you 20% discount on the purchase of 5,000 bucks. Each 5,000, 20% discount. So that is there, and a lot of chocolates. So, and it is open for even international faculties who are sitting out there. Yeah. So first question, results of osteoclast depends on following factors except tension of the assembly, angulation between malleus and stapes, air around the ossicular assembly, material or prosthesis used. Oh, that young man there, raise the hand. Yeah. Air around the ossicular assembly. Anyone who differs, he'll get a chocolate also. Lenticular process. Oh, material prosthesis. Okay. So, as the quiz master's decision is final always, although I have not made the questions, but it is a tricky one, no doubt. If you take this third answer correct, you are talking about that air bubble you leave in the middle ear. And that is required there. Yeah. So that is something, air bubble around the ossicles, which is always required. And that's what makes the basis of me doing a vertical strut. Because I do a lot of middle ear space I give, that is an air bubble there, and even in total annulus excision because we place the graft lateral to it. But the fourth answer is also correct. So 2 chocolates. Get me. So I will take. Yeah.
You have to raise a hand, sir.
Vinod will share a chocolate with Appara, sir.
Yay!
And one for the
young gen.
So the next question we have, 15 years old is waking up from an adenotonsillectomy for grade 4 and adenoids when he develops respiratory distress and has a frothy pink material that is expectorating. What is the etiology? Pneumonia, pharyngeal edema, post-adenotonsillectomy bleeding, post-obstructive pulmonary edema.
No. You have to raise your hand, please.
So first one from the fellow of Dr. Kranti. No, Dr. Kranti, you can't raise hand. Your fellow answered first.
Option 4,
okay, give me a chocolate.
Pulmonary
and
edema.
2 chocolates there. Yeah.
So it's post-operative pulmonary edema.
Yes. So you are the 5th one to answer the same, to give us the same answer.
I object.
Yes.
Sorry, Post-obstructive
It
pulmonary
is not
edema.
post-operative. You know,
Post-obstructive pulmonary edema.
you know,
Both of them.
I'll get you an example. 12 years girl. I was doing a septum along with adenoidectomy. No problem with my surgery. I did adenoid, packed the nasopharynx. I was doing septum because it was grade 3. It was trabenoceptal relationship type 3 on left side. Suddenly, I myself saw that endotracheal tube had got some frothy, pink froth coming. I stopped there, called my anesthetist. Faculty, they sip coffee outside and the residents are working there. So they were, okay, pulmonary edema is there. And they will start pumping more and more, hyperventilation, all those things. You know, then I decided to go for an extensive ECG workup, or if required, there is some history of rheumatic disease, for mitral stenosis you have to work out, maybe a 2D echo. The kids who has got even the mild mitral stenosis, if an extra fluid goes intraoperatively, it will precipitate pulmonary edema. So you have to be prepared for these sequelae, because you have to face the attendant and the public and the media, not the anesthetist. So as a surgeon you have to face, you have to be very vigilant what is going on around. Third question. So we got the chocolate to the winners? Okay. There were 4 or 5. What is the definition of apnea? Anyone from residents? Yeah? You have got a chocolate, man. You will become diabetic. Anyone else? Yeah. The second man close to him. He told you from the back? Okay. You tell me. Absence of breathing for more than 10 seconds. Cessation of breathing with a decrease in oxygen. Cessation breathing 10, 5, and breathing irrespective of time duration. What is there? So okay, so he is correct. So we do have obstructive OSA surgeons sitting out there, Dr. Srinivas and Sampurna. They say second is correct. Okay, give a chocolate to him. Anyone else prompted out there? No. Okay, so he is the one who got this. Yeah, so when you raise a hand, tell us your name, get some recognition from the crowd, man. Okay, and then tell us the answer. So fourth question, all of the following investigations can tell whether horizontal semicircular canal is intact or not, except calorie test. Srinivas put it on his slide in the morning. Rotary chair, functional hit or V hit, and C-vamp. Oh, I'm sorry. Yes. Kranti?
No, not the frontline benches.
No, the frontline benches. Oh, they already got a chocolate. No. You can't discriminate. Because we gave a chocolate to frontline benchers there, Felix and Appar sir. So you can give one to Kranti. She is going to share it. She can't afford one whole. She's going to share it. And one to him. Number 4. Can you please describe why C-vamp cannot be? So the vamp is there for utricle and saccule. And all these 3, including the calorie test for only lateral canal. Calorie cannot be used for other canals. Calorie can only be used for lateral canal. Okay? But V hit and functional hit you can use for all the other canals. Thank you for such an answer. A big round of applause for the ones who have responded and got a chocolate. Thank you so much.
Shall I ask? I request Dr. D. Shekhar Reddy, chairperson, to please call upon our moderator of this OSA panel.
Okay, next session is OSA panel discussion. May I request senior ENT surgeon from Hyderabad, Dr. Deendayal sir,
to be the moderator for this section. And the panelists, Dr. Monica, Dr. Chandra Jayasuriya, Dr. Srinivas Kishore, Dr. Sandeep Danchuri, Dr. Manilal, yeah. Srinivas Kishore, okay. Sanjay Sachdev, a brief introduction about Deen Dayal sir. He is very, very famous in this part of the world. He was the first person to use radio frequency in India. Since 1996, he is using radio frequency. And in South India, he was the first person to perform silent endoscopy. He has done a lot of cadaver dissection courses and live surgical workshop and conferences, and is a patron for IASSA, Indian Association of Surgeons for Sleep Apnea. He has published so many books and have different publications also. Management of Snoring and Obstructive Sleep Apnea 2022, which is published by Springer. And he has been awarded with numerous awards. And one of prominent one is Bharatiya Chikitsak Ratna Award, which is presented in July 2010 by Council of Economic Growth Research, Bombay. Over to sir.
Thank you, Shekhar, for your kind introduction. Good evening to all of you. And I think today's last session is obstructive sleep apnea panel discussion. And we have here an array of panelists. We have here Dr. Sanjay Sachdeva, a dear friend of mine from Delhi, and he is an advisor for Indian Association of Surgeons for Sleep Apnea, and he does a lot of sleep apnea surgery work. We have Dr. Chandra Jayasuriya from Sri Lanka, another dear friend of mine, and she also does a lot of work on snoring and obstructive sleep apnea. And we have here Professor Monica from Kathmandu. Am I right? Wonderful. And we have just heard her talk about the stages of sleep. And we have our dear Sandeep Dachuri, person from Medicover itself and from Hyderabad, and a dear friend, Dr. Srinivas Kishore, and he is the past president of Indian Association of Surgeons for Sleep Apnea, and he has been associated with a lot of people who are doing work nationally and internationally in this particular field. So actually, if you're looking in terms of the panel that I put forward, you see ethical management of treatment failures in obstructive sleep apnea. A little confusion. One word is ethical management, the other one is treatment failure. Anyway, just before I continue, I would say I'll just take 5 minutes to introduce into the topic, and then we will have the discussion so that it becomes a little more relevant. Ethical management is where you're talking in terms of giving treatment from the point of view of being truthful, fair, and honest. Truthful, fair, and honest, not just by evidence-based and things like that, because every patient is different. So there is what is called as a little bit of a moral fiber.
Second thing, if you're looking in terms of treatment failure, just for us to understand, we know the first line of treatment for obstructive sleep apnea is PAP therapy. There could be a patient, you have prescribed PAP, and the patient comes back saying that there's no relief. There could be another patient who has come to you with snoring, but on examination you found that there is obstructive sleep apnea after testing, but you have ended up doing a nasal surgery and the snoring continued. So it is a treatment failure. And there could be a third level wherein actually a patient has gone to a cardiologist with a heart problem, a coronary problem, but the primary cause for it is obstructive sleep apnea. All these things actually, if you look at, comes under the heading called treatment failure. So why so much of a thing onto this is the 21st century disease. And literally for me to point across, I would like you to have a quick look at these comorbidities or medical consequences of either untreated or treatment failure cases. You can start off from the cardiovascular, as common as hypertension. And of course, we know about pulmonary hypertension and other consequences, which are very much written there. But in children, if you have a look, it is simple things like ADHA and growth delay. I wanted to stress on one important point. Irrespective of the comorbidities, the lifespan of that individual comes down. Irrespective, a person is supposed to live up to 70 years, because of obstructive sleep apnea might live only up to 50 or 55. So that is one important point that we need to keep in mind. This is another slide before we start the panel. You just see, it is the effect of untreated pediatric obstructive sleep apnea treatment and what is its effect in adult life of that child. You see the percentages there. That means children who have obstructive sleep apnea in childhood, 50% of them will become hypertensives, 25% congestive cardiac failure, heart problems, coronary syndrome, 30%. If you look down below, about 60% of them will have strokes. So how important it is to manage cases with obstructive sleep apnea. Type 2 diabetes is another known thing, and you have overlap syndromes. We have so many infertility clinics coming up all over India. See the number that are obstructive sleep apnea causing infertility problem. What has surprised me in literature here is GERD, 60% of patients of adult GERD have childhood obstructive sleep apnea, and head and neck cancers, 76%. With this little introduction, let me start off with my first question. I'll start from there. Dr. Srinivas Kishore, you have we are all focusing on treatment failure. We are not focusing on anything else. A patient, either a treatment failure, whatever the treatment could be, has come to you that I have a failed, treatment in terms of being operated elsewhere. For an adult patient, what are the things that you are going to look into in evaluating anything specific? Or you have a system of doing it?
So whether there is a failure or not, I think what you have enlisted here, I think pretty much sums up every kind of evaluation. So if you have to quickly go through everything, ESS will give you the burden in terms of how sleepy he is, but it's obviously not a diagnosis of sleep apnea, but sort of gives us quantification of his daytime symptomatology. And especially since we are talking about failures, I think a dental exam is something that we all as ENTs miss. So when we talk about treatment failures, one more point that I would like to emphasize on is dental examination, especially things like malocclusion. Almost 60% of patients with OSA have malocclusions. Then end expiratory phase assessment, tongue position, and of course sleep endoscopy and sleep study. I think I would give those two a lot of importance, especially when we are talking about treatment failures. And the rest of them we will also really look at. But if it's a child, I will give more importance to dynamic MR.
Wonderful. Sandeep, would you like to add up something?
Sir, first thing is what treatment he has undergone is very important, because every OSA surgeon every ENT surgeon is not well trained in doing OSA surgeries. So what treatment he has undergone? Was it just a septoplasty with some tonsillectomy, or we need to see in detail what they have undergone, if the OT notes is available, or if you can talk to the previous surgeon or something like that. So we need to know what they have undergone, why it has failed, and then I dive into investigating them.
And you would agree to these particular points?
Yes, sir.
Right.
And if they have undergone, if it is a child or an adult, I would also see for the base of tongue especially, is there any lingual tonsillar hypertrophy along with...
No, this is an adult one we are talking
Yeah, even in an adult, if he has already undergone adenotonsillectomy, sometimes tonsils can enlarge. So I will look into that also. But what surgery was done previously?
Dr. Monica?
Yeah, I would like to add some points, like we may have missed the psychiatric evaluation. So we must also make sure that the patient doesn't have any psychiatric issues. Along with that, also we should see the dental, like the sir said. Suppose the patient is having retrognathia and you are missing that. So also the drug history has to be taken. And suppose if the patient is using CPAP, so it may not be being used properly. So maybe there is a malfitting of the CPAP mask, or it's not comfortable enough for the patient, or maybe patient is not using it as it is advised, or maybe it is some other disease like REM OSA or positional OSA. So we must first categorize the OSA. That is what I want to add.
I got the point here. See, there are a few take-home points before I come this side. The first and foremost take-home point for us as ENT surgeons, which we tend to miss, is the dental examination. In my next slides, I'm going to talk about that. A dental examination is one of the most important things. And like the way Dr. Sandeep has put forward, a detailed history of what the patient has gone into would definitely give you a guideline or a way how to go about and manage. And nice points brought in by Dr. Monica is keep also a point of a psychological issues. Drug intake is another beautiful thing that has been put forward. And of course, other things like polysomnography and others. Dr. Chandra, would you like to add?
We have to ask about the shift duty. Whether that person is doing night shifts, that also maybe, and then hypothyroidism also we have to exclude.
Do you have to put it on?
We have to exclude hypothyroidism, TSH level, and a full blood count, arterial blood gas we can do and see how severe the disease is. And the other thing is about the shift duty, and if it is a CPAP failure, we have to concentrate on the nose, whether there is nasal septal deviation and turbinate hypertrophy. So if the PAP therapy was given by a chest physician, I'm sure they may not have concentrated on ENT examination.
That is a nice point, that many a time when PAP therapy is given by chest physician, a complete ENT evaluation is not done. And that could be a reason why the PAP failure would have occurred. Dr. Sanjay?
I think probably that would sum it all. I think what Dr. Srinivas said, that at this point in time, you have to revise the whole process of starting from history taking, surgery history, other medical histories, lifestyle issues, getting the investigations done again to find out what happened, and also to think of any other cause which was probably causing a neuromuscular disorder which we have probably missed. And sleep study would obviously tell you whether it is an obstructive or some element of central which was missed, which could have been contributing to persistence of symptoms or daytime sleepiness, as the patient would probably come with that. So I think just a revision of the whole lot of investigations would probably give us some clue why the whole thing failed.
Perfect. I think this would completely sum up the whole thing. There's only one more question I'll ask here before we go to the next slide. Sleep endoscopy or DICE, its role in a treatment failure. One sentence, please. Starting from Dr. Srinivas.
Sir, sleep endoscopy is to look at the behavior of the upper airway during sleep. There are lots of usefulness. There are, of course, some issues also with it. For example, sleep endoscopy cannot tell us the behavior of the upper airway in REM sleep, which is the biggest fallacy of DICE. But having said that, I think when we are especially looking at treatment failures, whether it is PAP therapy failure or soft tissue therapy failure or a failure of a mandibular advancing device, there are now in literature and also in our practice that there are red flags that you know that when you see those on your sleep endoscopy, we know why the earlier treatment may have failed. Nobody can be 100% sure, but each one of the treatment modalities have some red flags based on which you know why this worked or why this did not work.
So you say that DICE has a role in treatment failure cases for you to identify where, but has no role if it is mostly a REM sleep obstructions. Sandeep.
I think if we can record the DICE, it will be easier to discuss with the patient, especially in failure cases. If you want to do something revision, if you want to revise the procedure, it will be very useful to discuss with the family, show it to the patient, see boss, this is the problem, this is the level you are having a problem, so that we can do.
Documentation is a very important thing, not only for explaining, but also for other medical legal purposes.
Yeah, I also agree to the same thing, that it must be done for the documentation and also to plan our surgery well.
Would you do DICE for a case of a treatment failure?
Treatment failure, for documentation, of course, yes, but not, we can't always say that treatment failure, it is a part of protocol, so I think which must be done.
No, the reason why I'm repeatedly asking that question is, we know basically there are 4 treatments: conservative, devices, third one is a PAP, and fourth one is surgery. These are the basic things. In conservative, medical and other things come into the picture. So already the patient has gone in some form of treatment or the other. So the patient is not improving. So do we need to identify where in the upper airway this issue is?
Of course, we have to.
So that is the reason why DICE, see, we have to give them a take-home message. Somebody has come with a treatment failure, DICE is a part and parcel of it. Would you agree to that?
Yes, of course.
Dr. Chandra.
I think one condition the PAP therapy will fail is epiglottic collapse. So I think that we can detect while doing DICE. I think it's very important because actually with the epiglottic collapse, PAP therapy will worsen the condition.
Correct.
Patient will get suffocated with high pressure.
I think that is a nice thing for those, juniors. Whenever there is an epiglottic collapse, the PAP therapy doesn't fail. Patient gets choked. And the only way to diagnose it is through DICE. Dr. Sanjay, would you like to add something?
Just one thing, that no one single test can 100% tell you what is going to happen. So you will have to collect information from wherever and whatever you can. So DICE should also be made as a part of the treatment, investigative.
Perfect. All the things put together plus DICE. Now coming to evaluation of a child, we'll quickly run through. We have done an adenotonsillectomy for a child who is snoring and who is having choking spells, and the child's BMI is slightly on the higher side, and the patient's parents come and say that no, the child is still snoring, still having choking spells. how would you go about, Dr. Srinivas?
Sir, I think we'll have to go back to the drawing board again and see where we have faltered. Basically, when we talk about OSA in children, when you do an adenotonsillectomy, it is the gold standard of care. And the success rate, unfortunately, can be anywhere between 20% to 80%.
See, that is a big statement, 20 to 80%.
To 80. So if you take every kid who has OSA and do adenotonsillectomy, irrespective of what they have, your success rate will be anywhere between that percentage. Now, so what are the factors that can pull your success rate down? Number one, of course, BMI. So it is shown that in an obese child, especially if you were to do a sleep study and quantify the amount of sleep apnea that the patient has or the child has, in fact, weight reduction would actually give them a higher success rate than would an adenotonsillectomy on an obese child. So that's as far as obesity is concerned. When it comes to dental exam, again, if there is a child with a high-arched ogival palate and a typical adenoid facies, just doing an adenotonsillectomy will not suffice. You will have significant amount of residual OSA because of the high-arched palate. FTP, again, if there is a single cause that can actually bring down your success rate for adenotonsillectomy, it's again FTP or modified Mallampati. Then quickly going down, CineMR, as I said before, it's a beautiful investigation when it comes to residual OSA because in one shot, it gives you soft tissue components and bony components simultaneously. FLP and drug-induced sleep endoscopy, now the International Pediatric ENT Association has also given it as given a new classification and guideline. PSG, unfortunately, we will not be able to do a level 1, which is the gold standard investigation. But the British Thoracic Society has now released certain guidelines into when and where you can use level 3 and pulse oximetry. And again, videotaping has at least 60 to 70% positive predictive value in your patients with sleep apnea.
I think well said. Sandeep, would you like to add anything?
Maybe, as ma'am has told, we need to rule out some hypothyroidism or any neurological
things. So you have to look for certain systemic conditions.
Are we missing something?
Right. Dr. Monica?
Yeah, I would like to add that if it is a case of adenoid, like Sir said, there is a high arch palate. So these days they are recommending that we should do a rapid maxillary expansion from the dental side.
Right.
So that will be a very good adjunct to the treatment and it may help the patient. So that should be considered.
I wonder whether the child has any syndromic condition where there is hypotonia of muscles. So I think
yes, syndromic conditions have to be kept in mind. One of the commonest being Downs that need to be looked into.
So two things I'd like to add here. One is, of course, to do an echo. Second is, if the age of the patient when you're doing adenotonsillectomy is more than 7 years, then there are a lot of people saying that after 7 years, you may not be able to correct obstructive sleep apnea in a pediatric age group 100%. So you will probably get what Dr. Srinivas already talked to us about, 60-70%. So that fact also has to be kept in mind.
I think excellent take-home points. Keep in mind pediatric age groups will have silent myocardial problems, especially severe obstructive sleep apnea cases and especially treatment failure ones, and those patients might require a cardiac checkup. That is one. Second thing I wanted to just add up, something as simple as X-ray lateral view nasopharynx. I've had quite a few cases in my practice where in the notes it is written adenotonsillectomy done. And when, as a routine nowadays, I even get an X-ray lateral view and the adenoids were grade 3 and grade 4. So there is a high possibility a part of it was removed or nothing was removed. So you cannot go by what that has been said. So something as simple as that history would definitely give you a lot. And audio and video taping is a wonderful tool to convince your patient's parents about the management which you're planning to do, and they'll quickly agree to that. Anything else you'd like to add?
Yeah, just one second. Allergies we can't miss.
Allergies is a must. Perfect.
And
allergies is a beautiful
now that
thing.
age group has become 18, this child, when he went through adenotonsillectomy age of 6, the adenoid might have grown because of allergies or whatever, and then what Professor Deendayal is saying, that you can sometimes get an adenoid grade 3, which is quite common in our practice now. So that is another thing that we have to really
One point I would like to make, sir, sometimes there can be coexistent synchronous airway lesions.
Yes.
Do not forget that there
Overlap.
could be a synchronous airway lesion, there could be a abductor palsy that we can miss.
Yeah.
We can also miss what is called as a sleep-dependent laryngomalacia that we can pick up on dyes. And of course, patients with sickle cell anemia, they have a chance of a lot of adenotonsillar hypertrophy, and once you remove that, lingual tonsils will immediately regrow.
Yeah.
So those things we have to keep in mind.
So coming to the treatment options, like I have put in here, what I'm going to do is, because of paucity of time, one part I'll ask, so that we can quickly run through the whole thing. Can you? Okay.
During Doordarshan days, we used to get these ads.
होता है? Anyway,
Sir, one thing, sir.
We'll talk about conservative. I'll give the conservative part to it. Srinivas, conservative management, its role in cases with, treatment failure. Stick to that.
I think very valid point brought up by Dr. Sachdeva is when you have a child with overlap allergic rhinitis as a comorbidity, conservative management plays a significant role. However, having said that, you have to give that conservative management that much amount of time for it to work, a fair chance for it to work. But having said that, if the child is having repeated apneas and your videos are telling you that you do not have so much time, so that you do not have the time for the conservative management to work, of course the algorithm shifts into another direction, but otherwise a minimum of 3 months should be given for the conservative management.
Can you quickly enumerate the conservative things that you would like to?
So adenoid tissue, if there is regrowth, has a lot of leukotriene in receptors. So montelukast, which is a leukotriene receptor, has a lot of receptor antagonist, has a lot of role, and so does intranasal corticosteroids.
Steroids.
And last but not the least, anti-reflux management.
Anti-reflux management, weight loss, and other things. To that, I will quickly add maybe one more. Babu, knock forward. Stuck in there.
Sir, can I add one point on this?
Yes, please.
So we can also do the oromyofascial functional exercises. It's a very good thing to...
Wonderful.
Yeah,
That
so
was another
that works a lot actually. It's a very good treatment for anybody who wants conservative management, and also the weight loss. So for that you can motivate the patient, but not for the morbidly obese or moderate and severe sleep apnea patients, just who are borderline. They can try the
That's absolutely
weight loss.
correct, because more than obesity, the neck circumference actually plays a role in.
I think the only thing is it's wonderful, but it's an adjunct. It cannot be a standalone therapy. It's an adjunct therapy to whatever we're trying to do.
You are correct about that particular part, that we have to keep in mind this myofunctional therapy. That is very, very important in treatment failure cases, and it definitely helps them completely. Sandeep.
Sir.
PAP therapy. PAP therapy, especially there are two questions for me. I'll ask you PAP therapy in treatment failed post-surgery cases. How would it be?
And still they are snoring. So a lot of them would be convinced to use PAP therapy, sir. That is one thing. And second thing is, I usually do not operate unless the patient has tried PAP therapy already.
Good take-home point, never operate without getting a PAP trial done.
At least a month. They should know what is PAP, and they should not claim that I was never told about medical treatment. You directly operated me for my sleep apnea. So they should know what is PAP therapy. Then only the patient from their side should ask for surgery rather than we forcing our surgeries on a sleep apnea patient. That is what I...
Perfect. Both. It's for both.
For
It's
pediatric,
for both.
I would not recommend.
See, when I'm talking about, we are talking in terms of both part of it.
For pediatric, I would not recommend PAP that
But
easily.
adult, 1 month, I don't think many of them would do it. Maybe 15 days is what they will accept it. Dr. Monica, for you, pertaining to PAP therapy, what are the cases where you see there is a PAP failure? See, PAP itself is a therapy and PAP failure is treatment failure. So what are the cases you've seen? What are they where the PAP therapy fails?
So when you are choosing the incorrect PAP, because in PAP you have different types of PAP. CPAP, adaptive servo ventilation, you have BiPAP. So you should correctly choose what is required for the patient.
Correct selection of the PAP.
Correct selection of the PAP, correct selection of the mask. The kind of mask, and also correct uses of the CPAP.
How to use it.
How to use it and effectively use it. And suppose if you are using it for a few days and next day you are not using it, so it's not going to work. And also whether the patient is adequately motivated and compliant.
Right.
So these are the things you must
see. Dr. Chandra?
I think we have to exclude obesity hypoventilation syndrome also. Some patients, they may need a tracheostomy initially.
Epiglottic collapse
yeah,
also.
And then when they are morbidly obese also, PAP therapy can fail. So we have to keep that in mind.
So like anatomical conditions, what are the things that, one is you used of obesity, hypoventilation, second you said epiglottic collapse before. Like, people with nasal mask, with complete nasal obstruction is a failure.
Yeah.
That is something that need to be kept in mind.
Yeah, because if the nose is obstructed, they will keep the mouth open. And then the tongue will collapse and then it will worsen the condition.
Right. Sir, one more thing. Yeah. The CPAP, if you are not correctly selecting, then you may be inducing CPAP-related central apneas. So that thing also you must keep into mind. And the polysomnography reading, that's why I told you that it should be done by us. It's a better way to select the patient for the correct treatment. Because if you are selecting a patient who has actually central apneas and you are asking the patient for, another kind of treatment, then it's not going to work. So that's all.
See, the best way to do is do it yourself. But being an ENT surgeon, sometimes it's very impractical to sit down. I mean, I'm being very clear about it. So you need to depend on
my point is you ask your sleep technician to do it, but at last you have to check it.
Sure.
That is what I'm doing.
That's
what I'm doing.
That's a must.
In the initial days, I used to, when there was no proper thing, then at that time I used to do. But these days, the sleep technician does it, and then the final thing, I check it, and then I give the report to the patient.
Right. Dr. Sanjay. Yes, sir. I'm going to shift to orthodontics and dental appliances. In your practice, wherever there is a treatment failure for OSA, have you tried dental appliances or orthodontics?
Yes, I've tried dental appliances.
Can you give me your feedback as to how good they are and...
So if DICE shows that you have a 75% tongue collapse, for epiglottis collapse there is no confusion. I mean, there's nothing else that you can do except do surgery. But tongue collapse, especially if you have a upper lower both together getting collapsed into the airway, and then dental appliance, you can do a simple maneuver by pushing the jaw in front and seeing whether the saturation improves or not. If it does, then these patients can try dental appliances, and if they increase the diameter of or the dimension of the airway by 1 centimeter, the ratio that increases is 4 times higher as far as the airway resistance. So that can sometimes improve these conditions quite well.
I think it's a very good take-home point. What I wanted to actually put in a point here is, we as ENT surgeons don't really look at the stomatognathic system. The stomatognathic system is, very much that of a dental side or a little bit of a maxillofacial side. But if you look at it, most of the things pertaining to it affects in obstructive sleep apnea. Lips open, teeth, high arched palate, then, the muscles of mastication being affected. And in fact, if you look at, this I picked up from a book from the dental side, that if you see in patients with snoring and OSA, what are all the things that are there pertaining to. So what the point here is that maybe we are underusing the advancement devices, and I'm so happy that Dr. Sanjay is using, and I know that Srinivas is using. Sandeep, are you? For treatment failure cases?
No, sir.
No. See, actually, there are certain times what happens when surgically operated, when you put a PAP, because of the tongue falling back, you ask them to use CPAP. They're very uncomfortable. Just give them a mandibular advancement device and put a PAP machine, they're happy. They're very happy. So a combination of this might help us in managing those cases. So actually the word I wanted to put here is sleep disturbed breathing is a disorder that needs to be evaluated and managed by a team of specialists, and the role of dentistry in sleep disorder is becoming more significant, especially in co-managing patients with simple snoring, mild to moderate OSA. Now quick run through. Your cases of OSA, do you get a dental checkup done if in case you suspect something?
Yes.
What percentage of your cases need dental checkup?
Pediatric?
Yes.
Most of them.
Adult?
Adult, I would say 50%.
Yes. Sandeep, would you get the dental checkup done or no?
Frankly speaking, no.
No.
Not.
Same. And Dr. Monica?
For me, I evaluate the patients. If it is necessary, I send. Or if they are not having, if I feel that they don't have
no,
any.
But a chunk of very
less adults.
Dr. Chandra?
Actually, we don't have facility to make mandibular advancement devices in Sri Lanka. I tried to discuss with our dental surgeons. They are not for it. And by examining the tongue, if there are indentation of teeth marks, so I sometimes refer them to dental surgeon.
Dr. Sanjay?
So send them to Dr. Deendayal. So we do, I think about 30% of our adults, they get a dental this thing, because there is a high likelihood, like all those important points which you had just highlighted about the bruxism, the cusp going down, the mandibles going like this, and all those things are very important, which they are much more keener and finer in diagnosing than what we are. Of course we can, but we may just go wrong, and that is maybe a major cause for failure of treatment.
In America, everyone goes for a dental checkup. Now they have asked the dental surgeons to do a few questions from patients and refer them for sleep apnea examination. So I think the dental surgeons are playing a major role in detecting, because everyone doesn't go to ENT, but every person goes to dental surgeon. So they are asked few questions about sleep apnea.
Wonderful. I think how much time do we have left? 10 minutes?
5 minutes only.
1 minute? 1 minute?
5 minutes. 5 minutes.
Huh? 5 minutes or 1 minute?
Make it 5 minutes.
So, see, this
So
we
we
have.
are also learning from your presentation. Please continue.
No, like you know, we have already discussed about this, that polysomnography is important for surgery. And without a prior sleep PAP trial, do not take up a case for surgery. Now, quickly running through surgeries. We all know that nasal surgery only assists and it doesn't really cure obstructive sleep apnea. Now, my point here is I'll only stick to 3 out of this whole thing. That is, number 1, tongue base. Tongue base is one area when it is not addressed, the patients come back with recurrence. And Dr. Srinivas, you agree on that particular part of it? Sandeep? Yes, tongue base is one most important thing. And here, Dr. Sanjay, yes. In a tongue-based surgery, we have 2 groups of surgeries. One is a tongue base reduction, whichever way it is, or the other one is like what we call it as a hyomandibular suspension or a hyoid suspension. Where do you do these? Yeah, please go ahead.
Okay, so for me, whenever there is a tongue baser, I actually divide them into 4 phenotypes. The first phenotype is the lingual tongue base, which is the lowest lying fruit when it comes to tongue base management. The second one is relative macroglossia or absolute macroglossia.
Right.
The third one, so when I'm talking about relative macroglossia, I'm talking about the tongue base is because of the size of the chin. The third one I'm talking about is absolute macroglossia. That means there is absolutely huge tongue, real macroglossia not fitting. The fourth, which is now becoming very, very common, is the loss of what we call as tongue coupling. That means there is no coupling happening between the tongue and the hard palate, so the tongue is falling back. Each one of them have to be treated separately. So based on that, I would go about it.
Perfect. I think that's absolutely perfect. I think one question before then we go to the next. Sandeep, if a patient comes to you and says, I don't want to put a PAP med, I don't want a mandibular advancement device, but I want to get operated, one surgery give me 100% relief.
100% relief, I tell them clearly.
No, one surgery give me 100% relief.
Tracheostomy.
Wonderful. That's the take-home point. If a patient demands, tracheostomy is the answer. And I wanted only 2 things to be put forward. I think one part is the perioperative part of it for surgery, where the Pope syndrome has already been discussed. There is another thing down below called as silent apnea. This silent apnea post-operatively, has any of the panelists experienced it? Would you like to give me your...
Yeah, I think that is another point where CPAP is also a problem. Sometimes when we do too much of excision there, and the CPAP works on an airway resistance pattern. So if there is no airway resistance built up because of the surgery that you've done, the CPAPs also don't work, and that is the time when there would be a failure on both the fronts, surgical as well as CPAP failure.
Any of you have seen that silent apnea? I've had one case. This is actually called REM sleep rebound. And it can happen anywhere between 1 to 5 days post-operatively. Because of a sudden opening of the airway, the patient goes into deep slumber at the REM level. And that is when they start choking and they go into silent apnea. So that is something we have to tell the patients in advance, that to keep a watch whenever there's people who are next to them, that you just have to tap and they get up. They go into this REM sleep rebound. So coming to the last two slides, then we close. I think we all agree that team management is most important, and the primary people are the chest physicians, ENT, neuro, pediatric, dental, and maxillofacial. And what I was wanting to put across in treatment failure is all the treatments given by the people on the other side, starting from family physician to endocrinologist, are they really treating the primary cause for the problems which they are coming to them? Suppose an endocrinologist has a patient with diabetes, with a large BMI and a snorer with obstructive sleep apnea, are they catching on that? A fertility specialist, are they catching on that? Let it be even a plastic surgeon or a gerontologist. We will see that even in cardiology we are not. So somewhere along the line, all those where it is not caught is a treatment failure. Are we all agreeing on that particular part of it? It is and a quick word from any one of you in terms of how to prevent obstructive sleep apnea. Anybody?
Exercise.
Exercise.
Right.
Okay, wonderful. Anything else? Anybody? How to prevent obstructive sleep apnea?
Catch them young.
Catch them young. Wonderful.
Lifestyle
modification.
Mass communication, public education, then people will come very early to the doctors.
So education.
Yes.
Education is another thing. Actually, I wanted to add three more things. One, breastfeeding for a period of 1.5 years will prevent obstructive sleep apnea. Never ever ask your child to be fed in a bottle and no pacifier. The whole maxilla, mandible and dentition change because of that. But if there is breastfeeding, there's no obstructive sleep apnea. There's been a lot of research done, and of late, if you see, most of the pediatricians are talking in terms of breastfeeding, breastfeeding, breastfeeding. Everywhere you see the pedico and the conferences, they talk in terms of breastfeeding. So number one, breastfeeding. Second thing to prevent it is myofunctional exercises is another thing that can definitely prevent. And of course, I agree with the statement made, catch them young. Whenever you suspect obstructive sleep apnea in a pediatric case, go out and treat the patient, because you don't want them to become an adult obstructive sleep apnea patient with comorbidities. That is the important take-home point. So, lastly, success is resolution or improvement of symptoms. It is not like, the AHI before surgery was 35, post-surgery is 12. No. Or any of those objective things are not the thing. A patient has come with a symptom, the symptoms have to be alleviated. So one must evaluate the patient with the objective results taken into the light of subjective complaints. And team management is the answer. I thank each and every one of you for the active. Give them a big hand, please. Thank you.
Don't chase the AHI.
Don't chase the AHI.
Thank you, sir.
That was a nice panel discussion, sir.
And I would like to add one point, sir. Please operate these cases in a setup where there is ICU, where you have good backup, and don't operate these cases in a small hospital, because I have burned my hands previously. In Bangalore, I was operating. Anesthetist had to go to some other setup, so he extubated very early. Patient arrested, and he could not re-intubate. I have re-intubated, and after 40 minutes, we could save the patient. That day I realized never operate a OSA patient in small setups. You need ICU backup, you need a good anesthetist, you need intensivist who can take care. You will operate and you will go home. If something happens, there should be somebody who can intubate.
Wonderful. Thank you.
thank you to the entire team of OSA panel. Now, I would like to call upon Dr. Shekhar Reddy, the chairperson, to felicitate Dr. Monica Pokhrel, our speaker of the topic, OSA. Please. I request our speaker, Dr. Monica Pokhrel, to felicitate our chairperson, Dr. Sudeep M. That's I request Dr. Chandra J. Surya to felicitate Dr. Shekhar Reddy. Now, OSA panel. I request our moderator, Dr. Deen Dayal, to felicitate all the panelists. I'll call one by one. Dr. Monica Pokhrel. Dr. Chandra J. Surya. Dr. Srinivas Kishore. Dr. Sandeep Dachuri. And Dr. Sanjay Sastdev. I request Dr. Chandra J. Surya to felicitate our moderator, Dr. Deen Dayal. Thank you, dignitaries. I once again announce, please, who have not taken the dinner coupon, please collect it from our registration counter. Thank you so much. As we wrap up the inaugural day of our scientific sessions, we have set the stage for an exciting journey ahead. See you all tomorrow sharp at 8:30 a.m. Thank you.
once again we're announcing that we have arranged a musical cocktail dinner party today at 7:30 sharp. So we request all our delegates to please take your dinner coupon and enjoy your dinner today.